from USA, and the chairperson are Professor Alexia Penna, Australia, and Professor Sheila Bhattacharya from India. Our third panelist will be Professor Preeti Debaghav, and she's a professor in the Department of Endocrinology from Sanjay Gandhi Postgraduate Institute of Medical Sciences, Raebareli Road, Lucknow, India. Our second chairperson is Dr. Alexia Penna. She's Associate Professor in the University of Adelaide and Women's and Children Hospital. Her area of interest are obesity, polycystic ovary syndrome, type 2 diabetes, and medical education. Our third chairperson is Dr. Sheila S. Bhattacharya. She is pediatric and adolescent endocrinologist, and she's working in Shiva Jyoti Clinic and Manipal Hospital, Bangalore. Her area of interest is pediatric obesity, diabetes, and growth disorders. I request the chairpersons to be kindly on the dais. Madam,
Third day of APIS ISPE joint meeting, and it's a privilege to hear Professor Silva Arslanian, and I would request Sheila to introduce her to the audience.
Please.
Yeah. Professor Silva is Professor of Pediatrics and Professor of Clinical and Translational Science Institute from University of Pittsburgh School of Medicine. She holds a Royal Endowed Chair in Pediatrics at the UPMC Children's Hospital of Pittsburgh, Director of Pediatric Clinical and Research Center, Director of Pediatric Research in Obesity and Metabolism at UPMC Children's Hospital. She has served the national and international scientific communities in various educational and advisory capacities. She has many publications and also outstanding achievement in clinical diabetes research for her seminal contributions in advancing scientific discoveries in youth type 2 diabetes, childhood insulin resistance, and beta cell function. I think we all have gathered here to listen to this pandemic of type 2 diabetes and obesity in children. Over to you, Dr. Silva.
Thank you. I want to thank the Scientific Program Committee and the local organizers. What's happening? They don't want me to move forward. Okay, one more time. So I thank the Scientific Organizing Committee and the local organizing committee for the kind invitation, and my dear colleague and friend Maria Craig, who sent me the email. And had it not been her, I would have said, sorry, it's too long of a trip, but I couldn't say no to her. So Maria, you twisted my arm gently. So these are my disclosures. The talk that I'm going to present to you today couldn't have happened without the contribution of all these individuals over the years, whether they were pediatric endocrine fellows, junior faculty, PhD postdoc, nurses, coordinators, funding agencies. So my gratitude goes to all those individuals. I'm going to start my talk with this case, which was a real case. CW was a 14-and-a-half-year-old girl with obesity referred to pediatric endocrinology, which happened to be me, fortunately, for evaluation of secondary amenorrhea of 3 years duration. In addition, she had acne, hirsutism, no other complaints except for long-standing obesity. Her family history was positive for overweight obesity, hypertension, type 2 diabetes, and dyslipidemia. Her mother had PCOS, and she underwent sleeve gastrectomy and lost 100 pounds. On examination, her weight was 121 kilograms. Her BMI was 37.5, consistent with class 2 obesity. Her blood pressure was 133/83 on the 95th percentile for her height and sex. She had acanthosis nigricans around her neck, knuckles, and intertrigonous regions. She had striae over her abdomen and hips. Because she was referred for evaluation of amenorrhea, of course, we had to rule out PCOS, and her total and free testosterone were elevated. Her HbA1c, as part of the screening for obesity-associated comorbidities, her HbA1c was 7.4%. She was totally asymptomatic for diabetes. Her random plasma glucose was normal at 165. Her liver enzymes, both ALT and AST, were elevated. Her triglyceride was elevated, and her HDL was low. Because she was totally asymptomatic for diabetes symptoms, and based on the American Diabetes Association guidelines, you have to document a second abnormal test result. So we called them as soon as we got this, told them to go the next morning, repeat HbA1c, and do a fasting plasma glucose. And lo and behold, this is what it turned out to be: A1c 7.1%, fasting plasma glucose above 126, consistent with diabetes. So this girl at the age of 14 and a half embodies the textbook description of obesity-associated comorbidities. She had PCOS, symptomatic. She had type 2 diabetes, asymptomatic. Had we not screened her for obesity-associated comorbidities, we wouldn't have discovered that she has diabetes. She had NAFLD NASH, which nowadays the terminology is MASLD MASH, which I don't like it, but that's okay. And again, that was discovered as part of the screening program. She had dyslipidemia as part of the screening program. She had hypertension by exam. She had sleep apnea by history, so we referred her to pulmonology to perform a polysomnogram. She already had mental health disorder. She was on treatment for depression. And of course, she had long-standing obesity. Now, this is the outline of what I would like to cover with you. You're going to miss your coffee break. So let's start with the health consequences, comorbidities of obesity. On the right side, I've listed for you all the systemic consequences. Pseudotumor cerebri. Patients present with increased intracranial pressure, recurrent headaches, papilledema, increased CSF pressure. I've had one patient like that. Orthopedic complications, slip, capital femoral epiphysis. Focal segmental glomerulosclerosis, which presents with proteinuria, okay? Just merely obesity associated. Cholelithiasis, which we seem to be seeing more and more. Psychosocial complications, asthma, and gastroesophageal reflux. But we are here as pediatric endocrinologists, and we're passionate about these things that I've listed on the left side. Insulin resistance, type 2 diabetes, PCOS, NAFLD, dyslipidemia, sleep apnea, hypertension, and risk of cardiovascular disease, which this girl had all of this. It is believed that the linchpin between all these obesity-associated comorbidities is insulin resistance driven by obesity, particularly abdominal visceral obesity. This is a study which we performed a long time ago. We typically do something called hyperinsulinemic euglycemic clamps, which assesses whole body insulin sensitivity. We assessed that in adolescents with obesity in red and their normal weight peers in green. You can see that insulin sensitivity is around 50% lower in adolescents with obesity versus their normal weight peers. However, if you take two groups of adolescents with the same BMI, 35.2 mean, with the same percent body fat, 43% mean, with DEXA, and you divide them to those with high visceral fat. You can see here, I don't want this to, high visceral fat. Is it showing? No. Oh, this is too weak. Okay. High visceral fat with CT scan or MRI on the belly. You can see inside the belly a lot of fat, and low visceral fat depicted in blue. Those individuals with high visceral fat have further significant decrements in insulin sensitivity. So it's not only total body adiposity, but visceral adiposity that further accentuates the insulin resistance. We looked in around 600 kids in our obesity clinic population who underwent oral glucose tolerance tests to see what is the prevalence of dysglycemia versus normal glycemia. You can see that around 60% had normal glycemia, but around 38 or 40% had dysglycemia, varying from type 2 to IFG and IGT combination, impaired fasting glucose, impaired glucose tolerance, to impaired glucose tolerance, 12.9%, IFG isolated 9.8%. So a significant proportion had dysglycemia. Furthermore, we wanted to see what happens, what is the percent dysglycemia if you have one risk factor, two risk factors, or more, 4 or more risk factors. You can see that if you have one risk factor for dysglycemia in an obesity background, the rate of dysglycemia is around 23%. But if you have 4 or more, almost half of the patients would have dysglycemia. Okay, so it's not surprising that obesity is driving the abnormalities in glycemic control. Moreover, the significant contributors to this dysglycemia were family history of type 2 diabetes with an odds ratio of 1.5, and our patient had family history of type 2 diabetes. A more significant risk factor was gestational diabetes mellitus during the child's gestation, odds ratio of 1.7, and dyslipidemia, odds ratio of 1.6, and she did have dyslipidemia, as I shared with you. So I'm going to talk to you from here on about type 2 diabetes. This is the global incidence of type 2 diabetes in youth less than 20 years of age. The box, the red box, shows who's leading the pack: US, India, and China. And here I've pointed to the Indian contribution to the global incidence of type 2 diabetes. Unfortunately, the marker is not working as good as I would like it to, and it's not, you can barely see it probably. Do you have a stronger one, please? Okay. Now, this is old data from Dr. Kitagawa in Japan. If anybody is here from Japan, he was one of the pioneers about youth type 2 diabetes. He demonstrated that the increasing rates of type 2 diabetes parallels the increasing rates of obesity. These are old data, but it holds true until today. Moreover, between 2001, but it's weak. It's very weak. Thank you. Oh, that's better. Thank you, sir. Okay. Moreover, the relative increase in type 2 diabetes in children and adolescents was 95.3% versus 45% in type 1 diabetes. But yet, at least in the US, NIH and funding agencies invest a lot of money in type 1 diabetes, not type 2 diabetes. 95.3% relative increase from 2001 until 2017 versus 45. Okay, this was a kid who came to us a long time ago, and I put this picture to show you the contrast, because when I stand next to this very adolescents with significant obesity, I always have a distorted image of myself looking anorexic. Okay? So why is youth onset type 2 diabetes important to discuss? Why? For several reasons. Number one, prevalence and incidence of youth type 2 diabetes continue to increase, both in the US and worldwide. There is earlier onset of complications in youth with type 2 diabetes versus type 1 diabetes. And youth onset type 2 diabetes is more hazardous and lethal. And I'm quoting the title of the papers that I've listed below, more lethal than type 1 diabetes with increased mortality rate. Which brings us next to the pathophysiology of youth type 2 diabetes. But before we go to the pathophysiology, I think it's very important to understand this critical crosstalk between insulin-sensitive tissues, skeletal muscle, liver, adipose tissue, and the beta cell. This slide depicts insulin sensitivity on the x-axis, going from high insulin sensitivity to low insulin sensitivity, and insulin secretion on the y-axis from low insulin secretion to high. The product is the multiplication of insulin sensitivity and insulin secretion, which is called disposition index. In reality, it's a measure of beta cell function relative to insulin sensitivity. We are all born with a fixed DI of around 40% genetically determined, but life circumstances can modulate. So let's take, if an individual, an athlete, will have high insulin sensitivity and will not require as much insulin to maintain glucose homeostasis. An individual with obesity will have low insulin sensitivity or will be insulin resistant, but in the presence of robust pancreatic beta cell, it will compensate for the insulin resistance with hyperinsulinemia and overcome that insulin resistance and maintain glucose homeostasis. Individuals who have low insulin sensitivity and low insulin secretion will fall below the curve, and those are people who have prediabetes or type 2 diabetes. In all of our research over the years, we've assessed insulin sensitivity using hyperinsulinemic euglycemic clamps and insulin secretion using hyperglycemic clamp, where you elevate the plasma glucose concentration to 225 milligram per deciliter, maintain it there for 2 hours, and look at first phase and second phase insulin secretion that I'll show later. So in 2005, when type 2 diabetes was in infancy, we got interested into probing the pathophysiology of type 2 diabetes in youth. By then, our adult colleagues had dealt with adult type 2 diabetes for decades. And the overall belief was that it's the product of hepatic insulin resistance, peripheral insulin resistance, combined together with beta cell failure. Without the beta cell failure, we will not have diabetes, okay? So we delved in to assess this, and lo and behold, we found the same thing. This is the red represents adolescents with obesity and type 2 diabetes, and blue represents adolescents with equal obesity, equal Tanner staging and age without diabetes by OGTT and HbA1c. Hepatic glucose production is increased in adolescents with type 2 diabetes. Peripheral insulin sensitivity is 50% lower in youth with type 2 diabetes. They have the same BMI, the same visceral fat, the same, but there is a genetic or maybe epigenetic insulin resistance in kids with type 2 diabetes. When you look at first phase and second phase insulin secretion during the 2-hour hyperglycemia, you can assess that significantly impaired compared to the first phase and second phase insulin secretion in youth without type 2 diabetes. And when you express this first phase insulin secretion relative to the insulin resistance, the disposition index is around 90% impaired soon after the diagnosis of diabetes. Not only that, adiponectin levels are significantly lower in youth with type 2 diabetes compared with their peers without diabetes. As you know, adiponectin is an insulin sensitizing hormone produced by the fat. Next, we proceeded to demonstrate that in addition to beta cell failure, there is alpha cell dysfunction manifested as hyperglucagonemia. And here we collaborated with Eli Ferranini and Andrea Mari, and who did mathematical modeling of our OGTTs. And we demonstrated that glucagon concentrations corrected for the glycemia, because hyperglycemia is supposed to suppress glucagon secretion. But despite correction, youth with type 2 diabetes had significantly elevated glucagon throughout the OGTT. The same was true for youth with IGT, impaired glucose tolerance, even to lesser degrees of elevation. And this is in NGT. So we concluded that there was alpha cell dysfunction with increased glucagon concentrations, both in type 2 diabetes and IGT. Next, we were curious to see if there is impaired incretin action or decreased incretin concentrations. So here we collaborated with Eli Ferranini and Andrea Mari, who did mathematical modeling of the OGTT C-peptide secretion compared with the clamp C-peptide, and we demonstrated that incretin effect is significantly impaired in youth with type 2 diabetes, manifested in red, lower incretin effect compared to the blue non-diabetic individuals, and the same was true of impaired incretin effect in adolescents with IGT. So the fact that we demonstrated impaired incretin effect opens up the armamentarium for GLP-1 treatment modalities in youth with type 2 diabetes. But what about incretin concentrations? They were not different among the three groups. Concentrations were normal, but the effect was impaired in youth with type 2. Next, we demonstrated that there was increased lipolysis and adipose tissue insulin resistance. So not only hepatic tissue insulin resistance, but I don't think I have time to show the data here. Next, let's go to lessons learned from today, which now is yesterday. Today stands for treatment options for type 2 diabetes in adolescents and youth. It was conducted in 15 academic centers, supported by the NIH. The groups came together in 2002. We planned the protocol, and the major question that today wanted to answer was, what is the best treatment in preventing loss of glycemic control in youth with type 2 diabetes? And the definition of loss of glycemic control was sustained elevations above 8% for more than 6 months, or the inability to wean insulin if insulin was started during an acute interparent illness. Is it metformin alone? Is it metformin plus intensive lifestyle? Or is it metformin plus rosiglitazone? Intensive lifestyle was truly intensive and not realistic in real life. Why do I say that? Because the patient and the family met with the lifestyle coach once a week for the first 6 months, every other week for the next 6 months, every month for the following 6 months, and every 3 months thereafter. At least in the US, no insurance company will support that. And I don't think anybody can afford out of pocket or social services coverage. So that's why I say it was unrealistic, but this was research. So let's see what was the outcome. Lesson number one that we learned from today: therapeutic failure rates are high. Overall failure rate, all three treatments combined, was 45.6%. Metformin failure rate, 51.7%. More than 50% of those patients receiving metformin failed to maintain an HbA1c below 8%. We're not talking below 6%, below 8%. Guess what was the best? Metformin plus Rosi. The failure rate was the lowest, meaning that the glycemic outcome was best. You may have wondered, why did we choose rosiglitazone when it was not approved for use in adolescents, and it is still not approved? We chose it because it's a very potent peripheral insulin sensitizer. And I shared with you data that these kids with type 2 diabetes are severely insulin resistant. So it made sense to use a sensitizer. So the outcome was the best, and metformin plus lifestyle failure rate was not any different from metformin alone. So all that time and money and energy invested in intensive lifestyle did not pay off. Now, one thing we learned, that the metformin failure rates in kids with type 2 diabetes, depicted in red, compared with adults from the literature, though this is not head-to-head comparison, but comparing today to what was reported in the literature in adults, the failure rates are much higher in kids with type 2 diabetes. You can see that after 1 year, 2 years, 3 years, the failure rates are much higher in kids. You may wonder, why is this the case? So we thought the same way. So could it be that one of the pathophysiological mechanisms, either insulin sensitivity or beta cell function, is worse in kids? And here I show you the data. We collaborated with our adult colleagues in endocrinology, and for every one child, adolescent with impaired glucose tolerance, for every one adult with impaired glucose tolerance, we matched 2 adolescents with impaired glucose tolerance. We wanted to study impaired glucose tolerance and not type 2 diabetes because we did not want treatment to overshadow the underlying abnormalities. So we matched them for BMI, for sex, for race. And what we found was that insulin sensitivity in youth was significantly lower, almost 50% compared with adults. So adolescents are much more insulin resistant than adults with the same BMI, with the same sex, with the same race, with the same IGT situation. In addition, hepatic insulin sensitivity was significantly lower. So the fact that they're very insulin resistant at the liver and the periphery could be one reason why therapeutic failure rates are much higher in adolescents with type 2. We did not assess insulin secretion, but we had another study that looked at it. But in addition, later on, we had another head-to-head comparison that was called RISE, Restoring Insulin Secretion. We studied adults and we studied adolescents. And in that study too, you can see that youth with type 2 diabetes or IGT had lower insulin sensitivity compared with adults doing the exact same protocols. And during OGTT, it was the case. So there's no question that youth or adolescents with type 2 diabetes or IGT are much more insulin resistant than their adult counterparts. Lesson number 2. If you're wondering what this number here is, the number of publications, but probably by now it's more. Youth type 2 diabetes has an aggressive course with early onset and rapid progression of complications. Why do I say that? At the time of the initial study, in 2010, 2011, 85% of youth with type 2 diabetes in today had no evidence of diabetic retinopathy. Within 7 to 8 years, this dropped down to 51% because around 45% developed very mild or moderate, non-proliferative diabetic retinopathy. But the disturbing factor is that 3.8% developed proliferative diabetic retinopathy, prodrome to blindness. And this is at the peak adult reproductive age of 25 years, still only 12 years of type 2 diabetes. So tell me this is not rapid progression in diabetic retinopathy. And guess what was the major determinant of the progression of diabetic retinopathy? Glycemic control, HbA1c. Okay. In this slide, I'm showing you the various complications of type 2 diabetes. At baseline, hypertension prevalence was 19.2%. Cumulative incidence over time went up to 67.5%. Kidney disease at baseline, 8%. Cumulative incidence continues to increase to 54%. Dyslipidemia or anti-lipidemic treatment at baseline, 20.8%, increases to 51.6%. Nerve disease, 1%, cumulative incidence, 32.4%. And if you look at any one microvascular complication, you can see how it's escalating over time. At baseline, it was 9%, cumulative incidence, 80%. So there is no question that it's a rapidly progressing aggressive disease. Lesson number 3. Beta cell function deteriorates fast, around 35% per year. I shared with you our data that beta cell function was impaired around 90-95%. The reason why I have it 60 to 90% because it depends on the methodology of assessing beta cell function. This is soon after diagnosis. The UKPDS and the ADOPT study showed that in adults, on average, there is 7 to 11% decline per year in beta cell function. We had no idea what this was in youth until we did several clamp longitudinal studies in Pittsburgh, and then the Today study that showed there's on average 25 to 30% decline. So remember that I said maybe one of the pathophysiological mechanisms in youth is worse. I showed you that insulin resistance was worse. Now here we're showing that the deterioration in beta cell function is much faster than what has been described in adults. These are the data in Today. Today had 699 participants. You can't do clamps, so we looked at surrogate estimates using insulin sensitivity, 1 over fasting insulin, and insulinogenic index, which is the delta insulin over delta glucose in the first 30 minutes of the oral glucose tolerance test. The blue line depicts individuals, today participants who were able to maintain glycemic control. The red line depicts those patients who failed to maintain glycemic control. When we looked at insulin sensitivity over 36 months, there was absolutely no difference between those who failed versus those who did not fail to maintain glycemic control. But when we looked at insulinogenic index, look what happens in those who failed to maintain glycemic control. It decreased precipitously within the first 6 months, continued to decline up to 36 months. So there was a rapid nosedive in beta cell function. And when you express this as a function of insulin sensitivity, you can see that within 6 months, beta cell function declines by 27%. Within two years, adolescents with type 2 diabetes lose 50% of their beta cell function. And within 3 years, 67%. So it's not surprising that after 2 years, metformin stops working because the beta cell in a non-scientific fashion is pooped out. It's not working anymore. So you need to add more pharmacotherapy to the armamentarium. But importantly, we found that the initial beta cell reserve and HbA1c were independent predictors of glycemic control. What does it mean? Because you may say, okay, if there is good beta cell reserve, HbA1c will be good. But they were independent, meaning the earlier you make a diagnosis when the HbA1c is 6.7% versus 8%, the outcome is better. The lower the HbA1c at diagnosis, the better the glycemic outcome. In the same fashion, the more reserve in beta cell function, the better the glycemic outcome. And you can catch better reserve if you make the diagnosis early in the course of the disease. Lesson number 4, HbA1c levels escalate over time. Here I've shown you what happens after 6 years in the follow-up of the today participants. You can see that mean and median HbA1cs are very high. At the start, at randomization, 75% of the participants with type 2 diabetes in today had HbA1cs less than 6.5%. Look what happened. Over time, by 15 years, only 19% had an HbA1c less than 6%. At the time of randomization, 25% had an HbA1c more than 6.5 or less than 8. Over time, 60% had it above 8%, and almost 34% had an HbA1c above 10%. So if you're experiencing the same in your patients, it is universal. So to summarize so far, youth type 2 diabetes starts decades earlier than adults, mean age around 13, 14. Insulin resistance is worse in youth compared with adults, 50% worse or 50% lower insulin sensitivity. Beta cell function deteriorates faster in youth than adults, 3 to 4-fold faster. HbA1c levels escalate over time. Complications progress fast. Mortality higher than type 1 diabetes. Treatment options are very limited. So what's next? We need new pharmacotherapeutic agents for youth with type 2 diabetes, which brings us to the next item, pathophysiology-based pharmacotherapy. Now, please bear in mind the following while treating youth type 2 diabetes. It should be based on known pathophysiological abnormalities and not simply on reducing HbA1c levels. It may require multiple drugs in combination to correct multiple pathophysiological defects and must be started early in the natural history of type 2 if progressive beta cell failure is to be prevented. Because if we catch them earlier when there is more beta cell reserve and lower HbA1c, the outcome is going to be better. So keep that in mind, and let's proceed with pathophysiology-based treatments in youth type 2 diabetes. Metformin. Metformin is a good hepatic insulin sensitizer. It is a lousy peripheral insulin sensitizer. Unfortunately, people use metformin to decrease weight, to do this, or even it is lousy peripheral insulin sensitizer. Don't waste your money on it. Okay? The study that led to metformin's approval by the FDA was in 2002. It was a 16-week trial where new onset youth with type 2 diabetes were randomized to either receive placebo in red or metformin in blue, and the HbA1c outcome was in favor of metformin. So this led to its approval. But this was only a 16-week trial. What happens after a year? What happens after 2 years? We had no idea, but we had nothing else then. This was it. Until I shared with you that in the today, metformin failure rate was 51.7. More than 50% of the patients failed to maintain glycemic control below 8% within a median of 11 months or a mean of 2.5 years. So that's a very fast deterioration of glycemia. Rosiglitazone, a potent peripheral insulin sensitizer, but still not approved in pediatrics, not only in the US, in the EU, and everywhere else. So I shared with you that the metformin failure rates were the lowest. Rosiglitazone failure rates were the lowest. Okay, but unfortunately, in the US, we can't use it because we have too many lawyers. And then let's come to GLP-1 receptor agonist. Here are the biological effects of incretin hormones. They increase insulin secretion, decrease glucagon secretion. They improve insulin sensitivity. They decrease hepatic glucose production. They decrease gastric emptying, and they suppress appetite. I shared with you that these are problems, pathophysiological abnormalities in youth. This is a problem. This is a problem. So it makes sense to use GLP-1 receptor agonist. And I shared with you that there is decreased incretin effect. So maybe exogenous GLP-1 administration will overcome the decreased effect and improve beta cell function, improve alpha cell function and suppress glucagon concentration, lower hepatic glucose production, improve peripheral insulin sensitivity, and dampen appetite, resulting in weight loss. Here I've listed to you all the medications, advancements in pharmacotherapy that were approved from 2019 to date. The first column is the drug class, GLP-1 receptor agonist, or SGLT2 inhibitors. The second column is the mode of administration, daily sub-Q, weekly sub-Q, or daily oral. The third column is the estimated treatment difference in HbA1c, meaning the difference between drug and placebo in improving HbA1c. And the fourth column is the estimated treatment difference, drug versus placebo, in improving fasting plasma glucose concentrations. And if you're wondering what are those numbers, it's the dates of FDA approval. In the last 5 years, 6 pharmacotherapeutic agents approved in the US, and it's true partly in the EM. But if you look at all of this, you can see that the largest estimated treatment difference decrease in HbA1c is with dulaglutide. I'm going to share some of these studies with you, but not all of them. This was the liraglutide study. Double-blind, placebo-controlled, daily sub-Q injection of liraglutide, starting at 0.6 milligram, gradually escalating to a maximum tolerated dose of 1.8 milligram. You can see that in the placebo arm, HbA1cs are escalating, while in the liraglutide arm, they decline, such that at the primary outcome of 26 weeks, the estimated treatment difference was a decline of 1% in HbA1c in favor of liraglutide. The same thing happened with fasting plasma glucose concentration. They're increasing in the placebo arm, decreasing in the liraglutide arm, such that 26 weeks, the difference between the two was a decline of 34 milligram per deciliter in fasting plasma glucose concentration. This study, published in the New England Journal, resulted in June of 2019 for FDA to approve liraglutide, that is called Victoza, daily sub-Q injections for youth 10 years and older with type 2 diabetes. Uh-oh. What happened? This title. This is extended release. I have no idea why it's black. It was supposed to be white with the title. But anyway, it's for extended release exenatide, placebo versus exenatide. Primary outcome out. What's happened? Uh-oh. I think here. Yay. Once weekly exenatide in youth. Placebo versus exenatide. Primary outcome at 24 weeks. The estimated treatment difference not as robust, but significant at 0.85 decrease in HbA1c. Unfortunately, there was no difference in fasting plasma glucose concentration between placebo and exenatide weekly injections. But we need treatments, HbA1c improvements. So July of 2021, FDA approved exenatide extended release weekly by Durian, once weekly in adolescents with type 2 diabetes 10 and older. The next study was once weekly dulaglutide at 2 different doses. The low dose, 0.75 milligram a week, and the higher dose in blue, 1.5 milligram a week. Again, gradual escalation over time. You can see that the HbA1c in the placebo arm is increasing, while in both of the doses of dulaglutide, they're decreasing. And at the primary outcome of 26 weeks, the estimated difference is the following. In the high dose, there's a decrease of 1.5% in HbA1c, in the low dose, 1%, and in the full dose, 1.3%. That's why I said that outcome, HbA1c outcome, was the best with the dulaglutide trial. When you look at fasting plasma glucose concentration, in the placebo, it increased by 17 milligram per deciliter. In the high dose, decreased by 27, and the estimated treatment difference is a decline in fasting plasma glucose concentration of 45 milligram per deciliter. And around 50 to 60% of the recipients of dulaglutide were able to achieve an HbA1c less than 7% compared to only 18% on placebo. So in November 2022, FDA approved dulaglutide called Trulicity, once weekly injectable for youth 10 years and older with type 2 diabetes. Now let's come to the SGLT2 inhibitors. I'm sure we all remember from our medical school years that in the proximal renal tubule, there is increased reabsorption of glucose and sodium. What SGLT2s do, they inhibit the reabsorption of sodium and glucose, resulting in glycosuria and decreasing plasma glucose concentrations. Among those are dapagliflozin, empagliflozin, canagliflozin. Empagliflozin trial was done before dapagliflozin, even though the outcome was significant, but it was not as strong as the DAPA. So I'm going to share with you only the dapagliflozin trial. Here is the dapagliflozin. Placebo versus dapagliflozin. You can see, as always, HbA1c escalating over time in the placebo group, but declining in the dapagliflozin group, such that at the 26-week primary outcome time, the estimated treatment difference in HbA1c is a decline of 1%. Again, less than the dulaglutide, which was 1.5%, and fasting plasma glucose declined by around 19.5 milligram per deciliter. So this one was the latest to approve by the FDA in June of 2024. It's called Farxiga. Honestly, I can't keep track of the names, but here they are. Okay. Every year in February, Diabetes Care Supplement comes up with treatment guidelines for all diabetes, and this is an expert for the adolescents with type 2 diabetes. If glycemic goals are no longer met with metformin plus insulin, long-acting or multiple daily injection of insulin, glucagon-like peptide receptor agonist therapy and or empagliflozin should be considered. Why did they say empagliflozin? Because it came out in February and dapagliflozin was approved in July. But empagliflozin can do the job, but probably it's better to use DAPA since the reduction in HbA1c was strong. Next, let's come to DPP-4 inhibitors. Endogenous GLP-1 half-life is very short because DPP-4 enzyme degrade the endogenous. DPP-4 inhibitors will inhibit this enzyme and prolong the half-life of GLP-1 receptor agonists. I never thought there would be any positive results from the DPP-4 inhibitors, and looking in the glass ball, I was right, I guess. So neither sitagliptin, nor saxagliptin, nor linagliptin proved to be efficacious in reducing glycemia in kids with type 2 diabetes. You may wonder, okay, you talked about GLP-1, you talked about SGLT1, what are the adverse side effects? I'm sure you're all familiar that GLP-1 receptor agonist have class drug adverse events that are all GI related, nausea, vomiting, diarrhea, abdominal pain. So these are very typical of all GLP-1 receptor agonists, whether they're used for weight reduction or type 2 diabetes. These are not the case for SGLT2 inhibitors, but there you can see the urinary tract infection because of the increased glycosuria, fungal genital infections, and the concern is euglycemic ketoacidosis. Unless you have your radars up and aware of this possibility, you may miss a euglycemic DKA. Now, we use GLP-1 receptor agonists for weight reduction in adolescents. What happened to weight in all these GLP-1 receptor agonist trials and SGLT2? None of the trials, none, showed any weight or BMI decline at the time of primary outcome. You may wonder why. I'm going to keep the suspense, and I'm happy to discuss it during the question-answer session. But let me share with you this data that we took adolescents from today with type 2 diabetes depicted in red, and adolescents from the teen labs, which is the bariatric surgery, 24 of whom underwent Roux and Y gastric bypass and 6 vertical sleeve gastrectomy. You can see that the participants, the adolescents who participated in the teen labs, their BMI was much higher. But look what happened. After surgery, their BMI came down from 55 mean to 40 and stayed there. In the today, with metformin or metformin plus rosy or lifestyle, even though BMI was lower, it didn't budge. It stayed the same despite all that intensive lifestyle. But more importantly, to see what happened to HbA1c. In the teens lab, HbA1c dropped within the first year parallel with the drop in BMI and stayed in the lower range there. But as I shared with you in the today, HbA1c is escalated over time to levels 9, 10, 12%. Okay, so maybe weight reduction in adolescents with type 2 diabetes can result in reduction in HbA1c and maintaining it within a reasonable range. So because of that, metabolic surgery, people don't call it anymore bariatric surgery, it's metabolic surgery. The recommendation is that adolescents with type 2 diabetes who have class 2 obesity, BMI above 35 kilogram per meter square, with significant elevations in HbA1c or significant comorbidities may be undergo metabolic surgery, but the surgery must be done by experienced surgeons in experienced centers. Finally, let's come to assessment and management of type 2 diabetes complications. In 2018, when the first guidelines came up, I happened to have the honor or the pleasure of being the first author with some of my esteemed colleagues. And this was an expert from there. But since then, 2021, 23, 24, not much has changed, because even though our knowledge in advancing improvement in HbA1c and pharmacotherapy advanced, but still we need more time to assess the outcome of complications. I've listed all the complications here: nephropathy, hypertension, dyslipidemia, retinopathy that I shared with you, neuropathy, NAFLD, OSA, PCOS. Our patient, she has all of this. Okay, so how do we manage dyslipidemia in adolescents with type 2 diabetes? The optimal cholesterol range goals are LDL less than 100 milligram per deciliter. For those of you who deal with millimoles, it's in parentheses. HDL above 35, it's very difficult to improve HDL, much easier to improve LDL. And triglyceride less than 150 milligram. If after 6 months of lifestyle intervention, LDL goal is not achieved, meaning LDL is still above 130 milligram per deciliter, start statin treatment. Because diabetes itself is a major risk factor for cardiovascular disease. You add to it dyslipidemia, you're compounding the risk for cardiovascular disease. So start treatment with statin. Now, NAFLD, we heard yesterday about a very nicely performed study of metformin versus placebo in NAFLD, and we saw that it did really nothing. To date, there is no evidence-based treatment for NAFLD, whether it's in type 2 kids, type 2 adults, or in obesity, except just recently, retatrutide was shown to improve in adults with obesity to improve NAFLD. We don't have that data yet in adolescents, whether obese or not. But because NAFLD is very common in youth with type 2 diabetes, from the day of diagnosis, check ALT, AST, or liver enzymes. If elevated, maybe you should do an ultrasound, which only detects liver fat more than 30%. And if over time, sometimes with improvement in glycemic control, liver enzymes improve, but if over time this did not improve, send them to the gastroenterologist. My gastroenterologist hates me every time I send them one, because they say, what can we do? It's obesity related. So to sum it up one more time, youth type 2 diabetes starts decades earlier than adults, 14 versus 50, 60. Insulin resistance is worse than adults. Beta cell function deteriorates faster. HbA1c levels escalate over time. Complications progress fast. Mortality higher than type 1. And yes, in the last 5 years, we have made tremendous strides in finding new therapeutic agents, but we don't have long-term data. We don't know how GLP-1 treatment will impact complications or SGLT2 treatment, how it's going to. So we have to be very cautious as we move forward. So I think we should learn from our past as we look forward in addressing and answering more questions. With this, shukriya, and thank you very much. Is it here? Or go back?
This being a plenary, are we still allowed some questions?
We have a very short time, so we can accommodate 1 or 2 questions. That should be fine.
Yeah.
Thank you. Ganesh here from New Delhi. I wanted to ask if, in your experience, the adherence to treatment or follow-up rates of type 2 diabetes versus I find that the adherence to treatment or follow-up rates are much more poorer even compared to type 1 diabetes.
I'm sorry, what treatment is what?
Adherence to
Adherence,
treatment.
Adherence
yes.
to treatment and follow-up.
Absolutely. If I had more time, I would have shown you the data. Adherence to treatment by pill count in today was around 50%. And even after we started insulin when they failed, that's even worse. And not only adherence to treatment, but monitoring. Plasma finger stick blood monitoring was a median of 40%. So you're absolutely right. And that's why now we're resorting to continuous glucose monitoring in the US. However, insurance companies will not approve it unless the patient is on insulin, because always the justification for CGM is prevent hypoglycemia.
Thank you.
Thank you.
Thank you for that wonderful lecture, Zahila. Just a question on the questionable risk for bladder cancer with rosiglitazone. And is it still wise to try it in youth?
So, as I said, rosiglitazone outcome was the best, but it's not approved in the US. And in academic centers, at least we are, and myself and the group I'm with, we are very conservative in using unapproved things because uh, the legal system is very different. If you have the patient on rosiglitazone and he's crossing the street from the parking lot to the hospital, he falls and breaks his leg, then it's the fault of rosiglitazone. So that's why we're very hesitant to use anything off-label. I personally have not used it, even though I know it's a good drug. But remember, it's not going to result in weight loss. If anything, it's going to increase weight gain or. Sure.
Very nice talk. Just a point regarding the use of GLP-1 receptor analog. We know that the weight reducing dose is much higher as compared to the dose which we're using in diabetes. So at least in those who have severe morbid obesity, would you like to go ahead with a higher dose in that scenario?
That's a very correct comment that yes, the doses are higher for weight reduction. But I think the reason why we did not see any BMI weight change in type 2 diabetes is not only a matter of dose. I think because when you improve the hyperglycemia, you're lessening calorie wasting in the toilet bowl, and you're making the patient more anabolic. At the same time, even though you recommend lifestyle change, they're not changing their eating habits, their activity habits. That's why they did not lose the weight. Could we use higher doses? Yes, but let me give you just this scenario that a few days ago I got an email about. I saw a patient with type 2 diabetes, and I put him on Trulicity, dulaglutide, for weight reduction. For diabetes management. And the insurance company declined it because, no, sorry, my jet lag is messing me up. I put him on semaglutide, Wegovy, for diabetes management, which has a lower dose than the obesity management. And the insurance company declined it because I wanted him to lose weight and have the higher dose. They said, no, we will only approve diabetes treatment. Meanwhile, this kid's HbA1c is 6.2%. So I don't want the treatment for his diabetes. I want it for him to lose weight. So in the US, that's what we deal with. And if the patient is to pay out of pocket, it costs anywhere $1,200 to $1,500 a month. So, sure.
Dr. Menon from New Delhi. Thank you for a very splendid talk covering all aspects of type 2 diabetes, especially with obesity.
Thank you.
My question is practice-based. You said it is very difficult to manage a child with type 2 diabetes, with obesity, and NAFLD. Unfortunately, we have to treat them. So instead of sending to gastroenterologist, how do you manage? What is the way forward for managing them? Most of the drugs, nothing seems to be working.
Yeah, I heard yesterday that you have very high rates of NAFLD in adolescents, not necessarily with diabetes, but just pure obesity. Again, we, of course, like you, recommend lifestyle change, lower caloric intake, increased activity, high fiber, lower carbohydrates, stop drinking soda 6 cans a day if fructose does anything. But the trials that have done that have not shown any significant improvement. So what do? You start taking antidepressants yourself.
That's for me, but what for the parents?
No, you're absolutely right.
You cannot just tell them that no, nothing is available.
Well, that's why you send them to the gastroenterologist. Let him take care of it. You get the burden off your shoulders. No, I totally agree with you. But I know right now there are 2 trials of tirzepatide that Eli Lilly is conducting in adolescents with obesity and adolescents with type 2 diabetes. I'm aware of it because I'm the chair of the data monitoring committee. Hopefully in a year or 2, we will have the results. And as part of the safety management, we're looking at ALT, AST, and all that. Maybe something positive will come, just like in the adults.
Let us hope for the future.
Yeah, but look at it. Don't give up hope. In the last 5 years, we had 6 pharmacotherapeutic agents. Maybe in the next 5 years, when I'm retired, there'll be more for NAFLD.
Thank you.
It was a wonderful session, and I
Thank
think
you.
there are so many questions that we need to ask, and I hope we can all take them in the felicitation ceremony. I'll request, after this wonderful lecture, I request, ma'am, please come up for the felicitation. I would request Dr. Rajesh Khadgawat sir, Dr. Sangeeta ma'am to please accompany the speaker for the felicitation ceremony, and Dr. PSN Menon sir. Thank you. Thank you, everyone. Now we go ahead with the second session. Dr. Suchit will start the session.
Good morning, everyone. The next session is going to be an interesting symposium on DSD. To chair this session, I'm privileged to invite Professor Kenichi Kashimada, who is working as Associate Professor in the Tokyo Medical and Dental University, Japan. His areas of interest are embryonic medicine and pediatrics, metabolic and endocrinology, medical biochemistry, developmental biology, and molecular biology. I also am privileged to invite Professor Vijay Lakshmi Bhatia, Professor, Department of Endocrinology, SGPGI Lucknow. She's having area of interest of bone and mineral metabolism.
Kenichi Kashimada from Tokyo. And the first talk about the symposium of DSD is Genetics of DSD by Dr. Atsushi Hattori from Japan. So could you start your talk, please?
Thank you for the introduction. It is my great pleasure to speak at this symposium. I have no conflicts of interest to disclose. I am from the Department of Molecular Endocrinology at National Research Institute for Child Health and Development in Japan. Our research interests are broad, ranging from endocrine disorders to other congenital disorders. We are particularly interested in sex development, sexual maturation, and reproduction. Today's topic is sex development during the embryonic and fetal periods. Differences or disorders of sex development, abbreviated as DSD, are classified into sex chromosome DSD, 46XX DSD, and 46XY DSD. Most cases of 46XX DSD are attributed to 21-hydroxylase deficiency. In rare cases, 46XX individuals can exhibit testicular formation, a condition known as 46XX testicular ovotesticular DSD. 46XY DSD includes disorders of androgen biosynthesis, androgen insensitivity syndrome, and disorders of testicular development, such as gonadal dysgenesis and testicular regression syndrome. Today, I will focus on 46XX testicular ovotesticular DSD and 46XY DSD. In this presentation, I will begin with 46XY DSD. I will provide an overview of genetic etiologies, and then introduce DHX37, a gene recently recognized as responsible for 46XY DSD. And lastly, I will discuss the genetic etiologies of 46XX testicular ovotesticular DSD. And I will start with an overview of genetic etiologies of 46XY DSD. To date, more than 10 genetic screening studies on 46XY DSD have been reported. Among these, I will focus on 2 studies, both of which analyzed more than 200 individuals with 46XY DSD. One article on the left was published from Australia in 2016, and the other article on the right was published from Brazil in 2022. The major clinical diagnoses were gonadal dysgenesis and disorders of androgen biosynthesis or action in both studies. On these participants, next-generation sequencing using gene panels and/or exome sequencing was performed. Overall, the genetic diagnosis was established in 44% in the left study and 60% in the right study. And next, we will examine the results by the subgroups of DSD. This slide summarizes the results of disorders of androgen biosynthesis or action. Overall, the genetic diagnostic rates in this subgroup are high, especially in the right study. More than 90% of cases achieved genetic diagnosis. The major responsible genes were AR and SRD5A2 in both studies. In contrast, the genetic diagnostic rates in gonadal dysgenesis is not so high, ranging from 30% to 40%. The major responsible genes included NR5A1, MAP3K1, SRY, and DHX37. Notably, DHX37 was not included in the left study because this gene was not recognized as responsible for 46XY DSD at this time. DHX37 was first reported as DSD responsible gene in 2019, and I will discuss this gene in more details in the next few slides. DHX37 is an ATP-dependent RNA helicase. It processes ribosomal RNA and contributes to ribosome biosynthesis. It has two REC-A-like domains, which are critical for binding ATP and RNA. Almost all variants causing DSD are located within these two regions. Clinical manifestations are characterized by regression of Mullerian derivatives, and findings of external genitalia are diverse among cases. The patients receive a clinical diagnosis of testicular regression syndrome, gonadal dysgenesis, or 46XY DSD with clinically unspecified etiologies. Conventionally, testicular regression syndrome and gonadal dysgenesis were considered two distinct conditions. In the next slide, I will discuss our putative mechanism for why these two distinct conditions are caused by mutations in the same gene. In individuals with DHX37 variants, it is presumed that the testes are initially formed but regress afterwards. In the physiological, embryonic, and fetal sex development, the external genitalia are masculinized between 8 and 12 weeks of gestation by testosterone produced by Leydig cell and its metabolite dihydrotestosterone. And the Mullerian duct regression occurs between 7 weeks of gestation and 11 weeks of gestation by AMH produced by Sertoli cells. Therefore, if the testes regress after 12 weeks of gestation, when the external genitalia are fully masculinized, the clinical phenotype would be testicular regression syndrome. However, if the testes regress earlier, the external genitalia would not be sufficiently masculinized. The clinical phenotype would resemble gonadal dysgenesis. Importantly, in this gonadal dysgenesis-like phenotype caused by DHX37 variants, regression of the Mullerian ducts occurs. This is not our typical finding in gonadal dysgenesis due to other etiologies. This slide summarizes the DHX37 variants that were identified at our institution. 3 variants were identified in 4 patients. Patients 1 to 3 received a diagnosis of testicular regression syndrome, and patient 4 exhibited with gonadal dysgenesis-like phenotype. All 3 variants were previously reported pathogenic variants, and the affected residues were highly conserved across species from human to yeast and were located within the 2 critical regions, 2 REC-A-like domains. This slide summarizes the clinical findings of the 4 patients. The Mullerian derivatives were not observed or only rudimentary. The findings of the external genitalia were diverse among cases. As for gonads, patients 1 and 2 had streak gonads. In patient 3, the testes were palpable at the age of 2 years, but became unpalpable at the age of 33 years. This postnatal regression of the testes may raise a possibility of potential role of DHX37 in postnatal maintenance of the testes. In the last part of my presentation, I will discuss the genetic etiologies of 46XX testicular ovotesticular DSD. Although SRY translocation is identified in more than 90% of cases of 46XX testicular DSD, it is extremely challenging to establish a diagnosis in SRY negative cases. Although variants in more than 10 genes have been reported, variants in each gene are extremely rare, leaving most cases undiagnosed. Among these variants, I will focus on 2 variants in SOX9 and NR5A1, both of which are laboratory contributed to the discovery. NR5A1 is expressed in the developing gonads, activates transcription of SOX9, and promotes testicular development in 46XY gonads. Disruption of NR5A1 was conventionally known to cause 46XY gonadal dysgenesis, but not 46XX ovotesticular DSD. However, in 2016 and 17, 3 research groups, including ours, independently reported that the alginine 92 tryptophan variant in NR5A1 leads to 46XX ovotesticular DSD. At least 2 mechanisms have been proposed to underlie this testicular formation caused by this variant. The first hypothesis was proposed by Bachamboux and colleagues from France. Wild-type NR5A1 is known to interact with beta-catenin to activate transcription of NR0B1, which in turn represses the expression of SOX9. Bachamboux and colleagues showed that the alginine 92 tryptophan variant had a reduced capacity to activate transcription of NR0B1, thereby allowing SOX9 to be expressed at levels sufficient to initiate testicular development. The second hypothesis was proposed by Igarashi and colleagues from our lab. Wild-type NR5A1 is known to activate expression of SOX9. This transactivation of NR5A1 is repressed by NR0B1 in a dose-dependent manner. However, Igarashi and colleagues showed that the alginine 92 tryptophan variant escapes these repressive effects. These findings suggest that this variant activates transcription of SOX9 even in the presence of NR0B1 and promote testicular development in 46XX gonads. Although these 2 hypotheses are intriguing, the precise mechanism underlying the testicular formation induced by this variant remains to be investigated. Next, we move to SOX9 variants. Duplication upstream of SOX9 is a well-known etiology of 46XX ovotesticular DSD. To date, more than 10 such cases have been reported. In contrast, single nucleotide variants in SOX9 are well-known etiologies in 46XY DSD, but not in 46XX ovotesticular DSD. However, in 2021, Ushijima and colleagues from our lab reported the glutamate 50 lysine variant in a patient with 46XX ovotesticular DSD. They showed that this variant had an increased transactivation function on mirroring testis-specific enhancer of SOX9. Considering that SOX9 can activate its own genes, this increased transactivation function may lead to upregulation of SOX9 and induce testicular development in 46XX gonads. Here is the summary of this presentation. Regarding 46XY DSD, the genetic diagnostic rates in disorders of androgen biosynthesis or action are relatively high, and common responsible genes are AR and SRD5A2. In contrast, the genetic etiologies in gonadal dysgenesis are heterogeneous, and its diagnostic rates are not so high, ranging from 30 to 40%. DHX37 is a novel important gene that is responsible for 46XY DSD, especially in individuals with absent or dysgenetic testes associated with Mullerian duct regression. Regarding 46XX testicular ovotesticular DSD, the etiologies of SRY negative cases are largely unknown, although several case reports have clarified the etiologies of limited number of patients. I would like to thank my colleagues and their collaborators for their hard work and their successful achievements. We are happy to collaborate internationally. If you have any undiagnosed case of DSD or other disorders associated with gonadal functions, please do not hesitate to contact us. And lastly, I would like to thank the conference organizers for giving me the opportunity to speak at this honorable symposium. Thank you for your attention. I'm happy to answer any questions.
Thank you, Dr. Hattori. Very clearly, you overviewed the genetics of DSD and also very insight into the recently identified DHX37 and also the very unique missense variant about the NR5A1 and SOX9. Also, sorry I forgot to introduce you briefly. He is one of the rising stars in our society. Japanese Society for Pediatric and Endocrinology, and he is now working at the Maki Fukami's lab. And so, yeah, thank you for your presentation.
Thank you very much.
And I also would like to inform you that the first two talks about the genetics of DSD and the latter two talks about genitoplasty of DSD and a little bit different. So if we have a time, I would like to have a discussion time after the first two talks. So thank you for your talk.
Thank you very much.
And I would like to move to the next talk. The Professor Girunda Saintov-Hoff from Thailand, and she is the chief division of endocrinology and the metabolism department of pediatrics and the faculty of medicine, Siraj Hospital, Manindal University. And she is contributed as EPS as a council from 2016. And her talk is genotype and phenotype correlation in DSD cases. Gerunda, could you start your talk, please?
Thank you very much, Kenichi, for your kind introduction, and good morning, everyone. Work at the Syrian Hospital, and we established the intersect care team since 2006. We did a review back in 2014. Among 191 cases of our patients, majority had 46XY DSD, and at least 40% of them, we did not have the definite diagnosis. So fortunately, since 2017, we were able to perform the targeted next generation sequencing using 47 genes, which the result is similar to the one that Dr. Hattori has shown to you, that the most common, two most common genes are AR and SID5A2. And also we have found mutations in WT1 and MAMLD1. So within my talk, I will focus on these 4 genes. So I'll start with the SRD5A2, which located in chromosome 2, and it's rather small gene comprised of only 5 exons. It encoded 5-alpha reductase type 2 enzyme, which is expressed in the prostate, seminal vesicle, epididymis, and liver, and it converts testosterone to DHT, which we all know that DHT is significant for the prostate gland growth and also for the differentiation of the male genitalia. This is the review paper by a team from Brazil, and it shows 121 variants in 451 cases of SRD5A2 from all over the world. And very interestingly, that they found that 70% of patients had homozygous mutation with the hotspot located in codon 196, 227, 235, and 246. However, among our patients, the hotspot is a little bit different. We found a hotspot in 227, 203, and codon 6, and compound heterozygous are much more common than the homozygous variant. All 3 variants that found in our cohort affect the enzyme activities from no enzyme activities to about the residual, about 40% of the normal. Majority of patients are were raised as male. And you can see that even with the same mutation, the phenotype can be variable. For example, with the compound heterozygous in the codon 203 and 227, the EMS score can range from 3 to 9. And also with the homozygous of variant in codon 227, the EMS score range from 3 to 7. However, there are certain variants, compound heterozygous, that have a little bit like my phenotype, which actually, I try to get the pointer, let's see, highlighter, laser, no, can you see it? Yeah. Pointer. I want, yeah, okay, thank you very much. I have been like talking without pointing anything. Sorry about that. So with the variant in intron 3 and the codon 227 seem to have milder phenotype with an EMS score of 7. Unfortunately for this patient, that he become more virilized when he entered puberty with the penile length increase from 3.7 to 7.5 centimeters. And all of our patients were assigned male sex. Only one patient that had an EMS score of 3 were assigned female. And the only reason is that at that time, we did not find mutations. I mean, we found only one variant in this patient initially. So he was not diagnosed as alpha reductase type 2 deficiency, and the decision was he should be raised as female according to the families. So the gonadectomy was done at 11 months old. However, this is such a classic case of alpha reductase type 2 deficiency that the gender dysphoria is very common, even though the gonadectomy was done very early on. And at 15, she came in and said that I don't want to be a girl. This is a reveal that try to look at the genotype and phenotype correlation. And the authors divide the type of mutation according to the function. You can see that the one that affect the testosterone binding domain seem to have the most severe phenotype with the EMS score range from 2 to 3. And also the one that affect the NADPH domain seem to have rather severe phenotype as well. However, the one that affect the enzymatic activities seem to have more phenotype variability with the EMS score range from 3 to 8. Here is the pictures of our siblings with compound heterozygous mutation with the nonsense mutation at codon 6 and missense mutation at codon 227. You can see even with the same mutation, there are a little bit of the difference in terms of the phenotype, one with a bifid scrotum, one without, but very small penis. Unfortunately, in Thailand, we do not have the DHT cream. So to increase the size of the penis in order for be able to perform the uretroplasty, we have to give a lot of testosterone depot injection, and both of them require at least 6 shots to increase the size. So why there is not a strong genotype-phenotype correlation in SRD5A2? Because there are possible explanation. First, there might be polymorphism in the AR gene in certain cases. And also they have been found that even in the same siblings, there are different in terms of the phenotype. And as we all know, the DHT can be generated by the androgen backdoor pathway. So if the patient have difference in terms of the enzymatic coding for the androgen backdoor pathway, that will affect the phenotypes as well. So AR gene is quite big and contain of 8 exon and located on the X chromosome. And up to date, there are more than 900 mutations found. With the androgen receptor variants, it can be classified as complete, partial, or mild androgen insensitivity syndrome, depending on the residual activities of the AR function. With the complete loss of the function, it results in complete AIS, and most of the mutation found are located in the ligand binding domain, followed by in the exon 1. For partial AIS, most of the mutation are found in the ligand binding domain. For my AIS, it's predominantly occur in the trans-activating unit 5 in the N-terminal domain. So what is the clinical presentation? For the complete AIS, usually they came in because of primary amenorrhea or inguinal hernia. They have normal breast development. And one thing that for the fellows should know about this, that when you look at the breast, it can be like 10-5, but when you look at the pubic hair, there's no pubic hair there or no axillary hair. So that's a classic phenotype of complete AIS. They have blind ending vagina without uterus. For the hormonal profile, in puberty, they will show age-appropriate normal plasma testosterone, normal or elevated LH, normal or elevated estradiols. For partial AIS, the phenotype can range from mild hypospadias or micropenis until normal-looking female exogenitalia with clitoromegaly. And it depends on the residual activities of the AR. Another thing is that in puberty, they develop gynecomastia and they don't have much of hairs. For the mild ARS, usually they do not have ambiguous genitalia as well, and they can be because of gynecomastia or male infertility. And it can be part of the diagnosis of Kennedy disease, which is bulbar and spinal muscular atrophy, which caused by the hyperexpansion of the CAG repeat at the level of exon 1 in the AR gene. This is the study from Cambridge looking at the correlation between genotype, phenotype, and sex of Rayleigh among 111 patients with partial AIS. And you can see that even with the same variant, the phenotype can be varied, like EMS score, like from 1 to 8. I'm going to show you a little bit of that. For example, the variant that affect the DNA binding domain can have very vary in terms of the phenotype. The one at codon 703 serine is changed to glycine, seem to have more severe phenotype and one report of the complete ARS. On the other hand, the mutation at codon 840, arginine is changed to cysteine. There are more phenotype variability, the IMS score ranging from 2 to 11. And you can see that even with the same family members, the sex of Rayleigh can be different as well. So what can cause the genotype-phenotype incongruence among the AR variants? There are many factors. It can be that the level of alpha reductase type 2 deficiency are different because of the polymorphisms. And in rare case, AR mutation can present as mosaicism. There might be other co-regulators that regulate the AR function. And also, as we all know, that the oligogenicity might definitely play a role in the phenotype variations. In our 16 patients, most of the variants are located in the ligand binding domain. There are 5 patients that have variants in the N-terminal domain or DNA binding domain, and 2 of them presented with complete ARS. The first one presented at 16 with primary amenorrhea. She had normal breast development, no axillary hair, and you can see that she had elevated testosterone level and LH levels, and she got a gonadectomy done at 17 years old. The others were raised, the other 3 patients had partial AIS. Okay, so another 11 patients with variants in the ligand binding domains. 2 patients presented with complete androgen insensitivity syndrome. 1 presented with primary amenorrhea and abdominal mass, and the other one presented with bilateral inguinal mass. In our cohort, all the partial androgen insensitive syndrome cases, except 1, were assigned male sex. Only 1 that had EMS score of 3 were assigned female sex. And when you look at the literature, I think there are quite big difference in terms of the sex of Rayleigh. It can be 50-50 or predominantly male. I think it depends on the ethnic and social cultures as well. One thing to be noted is that all of the male sex partial AIS cases, when they enter puberty, they came in with gynecomastia. And unfortunately, many of them still have very small size of penis, which is very frustrating for the patients. I just want to talk a little bit about this patient with complete ARS who came in at 49 years old with huge abdominal mass, and she had normal breast development, no pubic hair. She had primary amenorrhea. She got married and then consult the infertility unit because she couldn't have a kid. And turned out that she had 46XY, but then she lost to follow-up. And she came back again at the age of 49. And it turned out that she had large serous borderline tumor. Luckily, it wasn't gonadoblastoma. It's a tumor that arrived from paragonadal soft tissue. So, and I want you to look at her hormonal level. This is very typical for patient with complete AIS. Okay, so I have only 9 minutes left, another 2 genes to go. The WT1 is located on chromosome 11 and very important in regulated differentiation and survival of the cell in several organs, especially kidney, gonads, nervous system, and heart. And it contains 10 exons, and there are 2 alternative splicing sites. The splicing site 2, which encoded by exon 9, can give rise to the isoform with or without KTS. And this is very important because the isoform with the different ratio of the KTS positive or negative influence the gonadal development and the phenotypes. In terms of the phenotype of the gonadal development can range from normal testes to complete gonadal degenesis. And there are certain variants that probably have a very unique phenotype. For example, the Dennis-Drash syndrome, most of the variants are located in exon 8 and 9. And Dennis-Drash syndrome presented with congenital nephrotic syndrome or early onset rapidly progressive steroid-resistant nephrotic syndrome. If you do the renal biopsy, it shows diffuse mesangial sclerosis. They progress to end-stage kidney disease very rapidly. They are high risk of Wilms tumor. In terms of the gonads development, usually the patient have partial gonadal dysgenesis. And I want to show you one patient who came in with infantile nephrotic syndrome. However, her renal biopsy showed focal segmental glomululosclerosis. When she turned into end-stage renal disease at the age of 7, she received a cadaveric kidney transplant. And at 13 years of age, she was found to have a pelvic mass with elevated beta HCG. So it turned out that she got the gonadoblastoma with this germinoma. So what does she have? What is the diagnosis? So she got Fleischer syndrome. She had karyotype of 46XY, and she had normal external female genitalia. And the variant was found at the splicing site 2 in intron 9, which is one of the most common hotspots for Fleischer syndrome. Why this type of mutation causes Fleischer syndrome? Because the positive KTS isoform appear to be more efficient in activating the SRY promoter with the decrease in the expression of the KTS positive isoform. It affects the fertilized cell maturation and their ability to support the germ cell differentiation, so that might cause the risk of gonadoblastoma later on. And normally with the Fleischer syndrome, patients present with later onset of nephrotic syndrome and had slower progression into end-stage renal disease. However, our patient is quite different. So you can see that with WT1, there's broad spectrum of the phenotype and clinical presentation. Another patient that we have present with delayed puberty, and she had Wilms tumor at the age of 1.5. She had primary gonadal failure, and she was found to have variants in a nonsense mutation at codon 463. And when we look at the literature, we found that these variants are the hotspot for the non-syndromic Wilms tumor. So there are more varieties of the WT1 mutation than Dennis-Drash or Fleischer syndrome. It can cause non-syndromic Wilms tumor, And also it can cause just the 46XY DSD without the kidney problems. As I showed you here, that we found 3 novel heterozygous variants in 3 of our patients. All of them did not have Wilms tumor or kidney problems, but they presented with scrotal hypospadias, no micropregnant, and they had normal Leydig cell function to begin with, but one of them shows some degree of satellite dysfunction at the age of 15, and one had atrophic left testis, and the other one had one streak testis, so compatible with partial gonadal dysgenesis. My last gene that I'll focus will be MAMLD1. And MAMLD1 actually, we don't know much about the function of it, but it's predominantly expressed in the human fetal and adult testes and also in the ovaries. And it's possible has an important role in testicular function during the prenatal period and possible also in the afterbirth period. It has been shown that hemizygous pathogenic variants of MAMLD1 cause 46XY-DSD, and this slide shows the genomic structure and the gene found in MAMLD1. There are a wide range of the phenotype presentation, but probably the most common one is the isolated hypospadias. However, micropenis, bilateral undescended testes, or even complete gonadal dysgenesis have been reported. Majority of patients had normal testosterone production during the infancy or childhood and no mammalian duct derivatives. There are debates whether MAMLD1 really is the sole cause of DSD. Why is that? Because in many variants that have been reported, some of them show preserved trans-activating activities in the functional studies. And even with the same variants in the same family, they have different phenotypes. Some variants that has been shown to cause the disease have been found in general populations. So there's still debate about that. And there's a nice study done by Krista Fluke and her team. She did the whole exome sequencing in 746XY and 146XX patient with MAMLD1 and found another 55 variants in 41 DSD-related genes, and 23 of them interact with MAMLD1. So with these people, it showed that possibly that with the MAMLD1 variants, there are at least part of the oligogenicities from other genes that affect the phenotypes. So I just want to show you that our patient, the half sibling with the frameshift mutation of MAMLD1, both of them present with scrotal hypospadias, micropenis very tiny. One had only 0.8 centimeters at birth. No mammalian duct structures. We have normal testosterone production, and they enter puberty normally. And we have been following them up until now. They're about 18 years of age, and they haven't shown any sign of Leydig cell or satellite cell dysfunction. So in our case, since they are the same family members, it's possible that with this type of mutation might be the sole cause of their DSD. So in conclusion, there are no definite genotype-phenotype correlation in 46XY DSD caused by AR or SRD5A2. WT1 variants can cause varieties of phenotypes, and it's a very interesting gene to study. And some of them can have normal Leydig cell function initially, which might lead to a misdiagnosis as a DSD with normal Leydig cell function, and you might think that they might have the SRD5A2 or AIS. So in terms of diagnosis, the molecular diagnosis is really important to answer that question. And MAMLD1 is another etiology of 46XY DSD. and maybe the oligogenicity play a role in their phenotypes. So we don't know. I think there are some knowledge there that show that why there are incongruence between genotype and phenotype in certain genes, but we still need to have further study to understand more, because there might be other genes or other factors. Lastly, I would like to acknowledge all my intersect care team and the molecular analysis team at the Sierra Hospital, Faculty of Medicine, and for giving the funding to do all the next generation sequencing. And lastly, thank you very much for the PACE and ESPAIR scientific committee and the local committee for giving me the opportunity. And thank you for the wonderful hospitality. Thank you very much.
Thank you for Gerenda for your nice talk. And we are a little bit behind the schedule, but if it's possible, I'd like to take some small questions, one or two about the genetics talk by Dr. Hattori and Gerenda. Any questions or the comments about their talks? Yeah, Dr. Paul, please.
Thank you very much. Can I say they're both wonderful talks? Thank you. Very clear. Dr. Hattori,
yes.
You talk about over-testicular DST. The fact you get ovarian and testicular tissue in the same gonad, is that due to a change in the activity of SOX9 or of SR1 through the gonad, or is there a particular reason why you get a change from ovarian tissue to testicular tissue? Can you explain that for me?
Your question is why ovotestis occurs?
Exactly, rather than a split gonad or an ovary or a testis, why are you getting one end ovary when the other pole a testis? Is that related in your SOX9 case to increased activity at one end versus the other, or is there some other explanation? You know.
Thank you for your important question. It is my speculation, but the testis sex differentiation of gonads is stochastic event, so it can fluctuate, and SOX9 expression levels, if it exceed the levels of thresholds, it would be upregulate its own genes, so it can go either way, and it can fluctuate. So at some part of the gonads, it can go to the ovary, and the other part, it can go to testis. And that's why I think that's why ovarian tissues and testicular tissues can coexist in the same gonads.
Yeah, I think that the SOX9 regulation is a kind of positive regulation, positive feedback regulation. So some differences of SOX9 functional changes will cause a very fluctuated result, I think. So his answer may be like that.
Yeah,
that's correct?
Thank you very much.
Thank you. So next question, please.
Not a question really, but a comment. So I think both the talks were very, very useful. I'm Dr. Vandana Jain. I'm from All India Institute of Medical Sciences, Delhi. So we had also done genetic workup in a cohort of 150 children with 46XY DSD, mostly from northern part of the country, India. So we found that SRD5A2 was the commonest gene in 25 out of these 150 children with XYDSD. And in these 25, out of these 15 had one hotspot, which is R246Q. So you also showed it is one of the hotspots, but in India, yes. So it was like 60% of the children had this one particular hotspot, but there was no genotype-phenotype correlation at all. So the EMS score ranged from this children with the same hotspot from 0 to 8.5. So it was very variable. The other thing we found was that T to DHT ratio did not really discriminate between SRD5A2 and partial androgen insensitivity. So in almost all the cases of proven AR gene mutation also, the T to DHT...
Sorry, your question please more simple and briefly, it's okay.
For DHX37, so I think that is a very, very important presentation that you made, that in children without Müllerian structure and with gonadal dysgenesis, one should look for these. So I think if we have such children, we should look for that particular gene also. Thank you.
Okay, thank you. Yeah, comment. Thank you. Comments. Yeah.
Can I say something?
Okay,
it's very important that actually even in this Asia Pacific region, the hotspot can be varied. And I think I came up with your paper that the 246 is the hotspot in your cohort. But however, we did not find that in the Thai cohort at all. And we found the same similar things, that the testosterone to DHT ratio cannot be used. And there are varieties, there are more varieties. Yeah.
Okay, thank you, Jarinder. So we would like to move to the next talk. Thank you for Dr. Hattori and Jarinder.
It's for the next two talks, both bordering upon sex of rearing decisions. It's a pleasure to invite the first speaker, Professor Minu Bajpai. Professor Bajpai is the former head of department of the pediatric surgery department in All India Institute, Delhi. He's been a teacher to generations of pediatric surgeons who have trained in all the expertise which Dr. Bajpai has generated in his department. He also was the dean, academic dean in All India Institute, and in charge of international collaborations and many MOUs in All India Institute. He has made great contributions in pediatric surgery and pediatric urology, including in recent times minimal access surgery. In order to expedite patient recovery. Dr. Minu Bajpai will speak
Thank you.
on genitoplasty for CAH, management, sociocultural, and legal issues. I just want to mention that the second talk will come after Dr. Bajpai's talk, and then the question time will be a common question time. Please, Dr. Bajpai.
Thank you very much. Good morning. I would like to thank the organizing committee members, especially my esteemed colleagues, Professor Vijay Lakshmi and Professor Rajesh Khatgawat, for inviting me for this interesting talk. I would not talk about the surgical techniques to genitoplasty, but rather I would discuss the change paradigm of to how we approach the management of these children. So you can see the first slide shows the clinic in which we worked. I worked at Institute for 38 years. The data are from its inception in 1981. And I could see a preponderance of 46XY DSD, almost twice that of CAH, which is a departure from what you see from the data from West. And it reflects the social milieu of our countries. I can say for sure about India, Pakistan, Turkey, and many such countries around. The patients were drawn from the rest of the country, many states. Again, I can tell you that these states vary in their language, cuisine, climate, but their emotion for a child with DSD is uniformly almost the same. Good thing is it is slowly changing, and people are getting more enlightened and more careful about their kids. Now, as I mentioned, gender assignment and socio-cultural influences go hand in hand, where traditionally the gender assignment was based upon the influence from sex of rearing, and the treatment was dependent upon the size of the phallus. And it still holds true, not only in the villages and remote areas of our country, but also in the West. And these are the data from the German Intersex Support Group. It is now being increasingly realized that gender identity is a result of complex interaction between genes and environment, and it is hugely changing, especially more and more cases of gender dysphoria are now coming up, so which is again a notable change. And it is impossible with great certainty to predict what gender a child would later on come to identify with, and that's where gender dysphoria component. Now, there was a time in 80s when we discussed about the techniques of genitoplasty and the results. It is changing now. We discuss now the paradigm shift which has taken place, the approaches, the emotions which go when the parents see a child with that, and a group of very concerned people, advocacy group, which can also be shortly called as health activists, who are also equally concerned about the patients. So we have three stakeholders. There's an interaction between shared decision making between parents and the surgeons and the clinicians overall, with the backdrop of keeping in mind that we have other considerations also. So if we look at them one by one, parents' strong wish to surgically normalize their child's sexual anatomy. It has been traditionally there, it is still there. They view genital surgery as obvious and necessary to assure their child's positive psychosocial and psychosexual adaptation. Follow-up studies suggest predominantly favorable attitudes towards early feminizing genitoplasty, thanks to some of the wonderful studies, some of them I will quote soon, which have actually come to the rescue of these children who later on suffer. And therefore, some of these studies are seminal, and I'll discuss them in detail very soon. There is an interaction between parents and the healthcare providers who help interpret test results, anatomy and physiology, hormone production, hormone receptors, gross anatomy. They inform parents' decision about gender assignment. Individual cases are referred to institute subcommittee, ethics, main committee, and if there are difficulties in decision making, it goes to the family court. And this particular data has come from Australia. Huge, great work done by Dr. Gary Brown for years by working in many parts of our region. So surgeons look at the benefits the patients physically and psychosocially by surgery. So they have realized now that atypically developed genitalia affect physical appearance, body image, function of the urinary tract, gonads, and psychological and psychosexual development. So saying that therapeutic options only help in cosmetic improvement is not totally true, barring one condition which I'll come to. It affects the function, it affects overall milieu, the emotion, the development of the child. But surgery has an important role to play. It's just not a technique to be offered. Now, clitoroplasty is offered, and even the activists agree that there are emergency situations when it could be offered. For example, in CA, to create unobstructed outlets for urine. If you have a long urogenital sinus, there could be backwash, infection, and stasis. Therefore, that's one. Early clitoral reduction surgery, definitely, I was alluding to that earlier. Mild clitoromegaly could be classified as one where it's cosmetic surgery. And that's where we talk to parents about it, and that it is just a variation. And it has issues which may impinge upon their tissue sensitivity. Surgery is recommended for severe clitoromegaly. There have been a pendulum swung, but finally it has come to a more stationary state now. Clitoromegaly, which is severe, should be offered surgery. The main question is when to offer surgery. And for that, I was alluding to an article, which is a wonderful article. I'm going to come to that. So this activist platform has actually emerged out of things which happened when the data were analyzed that some kids were harmed. The sensitivity of the local tissues and some complications of surgery were blown out of proportion. And nevertheless, why should there be even one case which could go wrong? But that led to a ball sort of swinging down. So the concerns were parents seek to act before becoming fully informed of all the options. So there should be a shared decision making with deep dive into what all is the spectrum And that's where we have come to the understanding when we talk to our parents and children. Legal and ethical questions, patient autonomy, referral of decision, to what extent, to the legal age, and that's again has been answered by this study. Comparative outcome associated with performing surgery later in life versus early childhood. So which led to, unfortunately, a general moratorium. We all realize, and we have grown in medicine as students, as practitioners, there is nothing 100% in medicine. And so there are variation, and we deal with individual cases. We are now into the stage of personalized medicine using the technology of artificial intelligence and machine learning. So therefore, a moratorium is generally not accepted. Whether now this particular article, whether later surgery has better, poorer, or comparable physical, psychosocial, and psychosexual outcomes. So this particular study group, DSD Life, a multi-center cross-sectional clinical evaluation study with 16 partners, 14 recruiting centers across Europe and the UK, came out with some very important data. The group of patients were adolescents more than 16 years and adults with DSD, conforming to the Chicago Consensus of 2006. Interviews, retrospective charts, and medical examination was conducted. Patient-reported outcome questionnaire was given to them, and these questions were like this. Should there be a general postponement of surgical intervention until legal age? Half the patient disagreed with this statement. 25% agreed, 1/4 didn't know. What is the appropriate time for genital surgery? 46% agreed for infancy. And they were the adults. They were happy it was done in infancy. 20% between 4 and 12 years of age, all children. So almost 2/3 agreed it should be done in childhood. Should clitoral reduction be necessary in girls? 38% agreed, 14% disagreed, 18% undecided, 29% don't know. And obviously, this is very sensitive question, and we can see this variation of answer. Vaginoplasty in adolescence, adulthood, or infancy, 2/3 approved of surgery in infancy or childhood. So these were adults who had gone through this, and the data emerged from whether it should be done in early childhood or later on, and that's what we have now. So these data that congenital adrenal hyperplasia persons predominantly favor interventions in childhood. A moratorium, one for all solution is not justified. Case by case decision making is better suited. Efforts in improving information on long-term outcomes should be carried out. We learn every day. And therefore, we should continue to look for answers together. Shared decision making gives us answers and more questions also. So therefore, the three stakeholders, the advocates, the clinicians, and the parents, the data which emerges out of this interaction should be looked forward, and we should be more and more informed. And we should maintain contact with support groups. If there is considerable uncertainty which happens in day-to-day practice, we should motivate parents to postpone elective genital surgery. And we come across these situations, and we should not be very dogmatic. From the European Society for Pediatric Urology and the Society for Pediatric Urology standpoint, medical and surgical management aims at avoiding potential health hazards, anatomy and function of the urogenital tracts. We should meet parents' expectations. We should help individuals' future satisfactory sexual function, which should be consistent with their gender identity. Therefore, shared decision-making, a multidisciplinary approach. So in the clinician group, we have sub-specialists along with the advocates and the parents. We should provide explicit knowledge that a decision is required. Evidence concerning the risk and benefit of each option should be discussed in detail with the family. Process takes into account the patient's values and preferences, and these are socioeconomically, structurally, region-wise variations. A huge amount of input is required, and that's what shared decision-making is. So the steps are Inclusion of subspecialists, there are 6 steps. Involve parents in decision making. Parents need help addressing the emotional feeling. They get carried away. And then we should identify here is a family which is too much disturbed. We should give them enough time to come down by giving them proper data. Avoidance of terms referring to genitals. Providers should strive for objectivity, evidence-based information available, hard data to convince them, to show them, to understand. Parents should have received unbiased information, hopefully leading to a consensus based on trust and understanding. So we are facing this every day now with the changes which are happening. These paradigm shifts have led us to sit down and think what kind of surgery are going to be offering to these kids. It was not straightforward surgery. Now all this goes into this. There are legal issues. To ensure that the consent is truly informed, it has to be qualified and persistent. It should be in writing. The information provided must be complete. The parents must be informed about the dangers of current treatments, the possibility of delaying surgeries and giving adequate psychological support to child. The authorization must be given on several occasions. Give them enough time to understand. They come back. We ask them to come back after 6 months, even if they've understood, so that at least it seeps down and they may come back with the same answer. So reasonable time should be given to them. Thank you very much.
Thank you, Professor Vajpayee. You have please kindly, would you like to take your seat here while we invite Professor Kanishka Das? You have beautifully brought out the dilemmas which haunt us every day in our patient care. It's a privilege to introduce Professor Kanishka Das. He also started his career at All India Institute of Medical Sciences, but then moved south and spent a large part of his career in St. John's Medical College in Bangalore. And then recently he has moved to Eastern India. He's heading the Department of Pediatric Surgery in All India Institute, Bhubaneswar. Professor Das's area of expertise and interest are pediatric urology, Hirschsprung disease, and spinal dystrophism. We chose 2 eminent speakers bringing their thoughts from different parts of our diverse country. Professor Das will speak on surgical management of XY DSD and gonadal dysgenesis. Professor Das, please.
Thank you. It's a pleasure to speak in this forum before an august audience. I am grateful to the organizers giving us this opportunity, and I also represent the Society for Children with DSD. I'm the secretary of that society. My brief would be to go through this big burning question that is on across the world: early versus late surgery, if at all surgery in DSD. And I would restrict myself to 46XY DSD and gonadal dysgenesis. So to be or not to be is the question indeed. Yes, as Sir has already outlined, surgical intervention must benefit the child both physically and psychologically. And of course, in an utopic situation, that is what we look at. It should be not just cosmesis, but functionality and taking the psychosexual orientation and disposition into account. It's a very emotive aspect. Everyone, all the 3 stakeholders get agitated over this often, and many rounds of counseling are required to come to a point of concurrence where it should be done or not. Unfortunately, there's a very weak evidence base that we have, and you really can't hit at evidence-based medicine to go about discussing these points for surgery in DSD. And there is a lot that comes into play: questions of normality, personal experiences of the children, and the expectations that both the parents, child, and society have. Broadly, the surgical interventions are these: reconstruction of the external genital tissue. This is something which comes immediate, like a cordic correction in early childhood, or hypospadias repair, or noccidopexy, which has to be done to prevent problems with the abdominal testis and undescended testis. Repaired related to the obstruction of the Mullerian structures or its effects on obstructing the urinary tract, like a vaginostomy, which we do occasionally. Gonadal removal or pexy elsewhere, primary to eliminate the tumor risk and avoid contrasexual puberty, and others. Many of these are diagnostic before we move on to the more therapeutic procedures. But whatever it is, it requires an examination and anesthesia because in the OPD, we really can't make much of the anatomy that would lead us to plan a surgical intervention or not. So these are very carefully selected and scheduled so that they're clubbed together and we don't have much exposure to anesthesia and minimize anesthetic harm. A lot of diagnosis depends on endoscopy, genitoscopy, laparoscopy, and a gonadal biopsy in certain instances. The therapeutic procedures are those listed there related to the gonadopexy or gonadectomy, that is in sharp focus, as you would see later. Dealing with the Mullerian structure in dysgenesis or in ovotesticular DSD, either its division, its removal, or its preservation, depending on what we plan to have the treatment as. Dealing with the urogenital sinus remnant in 46XY DSD and genitoplasty. Breast surgery is something which is kept for the later part at puberty. So the surgery for XY DSD and gonadal dysgenesis is what we will move to now. Briefly, I will deal with the testosterone biosynthetic defects, the conversion defects. These are a special group of defects which must be recognized early because we know that these virilize at puberty and can cause a lot of problems if they are not detected early and managed early in the correct manner. We would avoid a lot of gender dysphoria in these children if they're detected early and suitably managed. Androgen insensitivity, which is again a big group, a heterogeneous group, the complete and the partial types, and the minimal type. Of course, here what is overriding is the what to do with the gonads. Can they be pexed? Can they be removed? Because we know that they have different rates of malignancy. Then the second group would be gonadal dysgenesis. The shades of gonadal dysgenesis, it can vary from the complete to the partial to the mixed being the commoner one that we see. And here dealing with the Mullerian remnant and dealing with the gonad, which has a much higher incidence of malignancy. The crux of the matter, what is it that we have against early surgery or the world has currently against early surgery? We are all very familiar with the um, voice of the American Medical Association, which says that you respect patient autonomy, bodily autonomy, and preserve all options till the child can decide. At the time that the child can decide is still in sharp focus, and we really do not know when that is. But of course, it fosters a shared decision making with all the three participants, the parents, the children, and the healthcare provider in tandem. And there is a certain shift from paternalism to a patient centered shared decision making with partial or full disclosure. So this right to an open future and a fluidity in gender choices is what the current thinking is about. And hence a moratorium from many advocacy groups to defer all major reconstructive surgery and irreversible surgical interventions to a later date. Of course, it is important to outline surgically what are the goals of the patient in surgical care. Not all of them would have the goals that we presume that they would have. For example, not all would want to have penetrative sexual intercourse. This has come out in the interviews with many of them when the surgical goals of the provider was different from that expectations of the patient. What else is against general early surgery? Does it really address the primary driving factors? Early surgery was touted that it would sort of take off the parental shame, anxiety. It would offer a quick fix to normalize the child's appearance. But then, does it really do that? Or is it that you're jumping into something without being fully informed about the risks and benefits? This is the argument that is put forth. And there are reports of unfavorable outcomes, complications like in any surgery. When you have early surgery, it's too early, and there is very little tissue for the surgeon to work on and reconstruct, especially in feminizing genitoplasty. If you dispose of tissue, you're left with little puberty to work on. Gonadectomy, of course, under the strong focus because you have not just loss of hormones, but also the fertility potential is thwarted. And of course, anesthetic harm. Is there a case for early surgery? There certainly is. There certainly is in many of our socio-cultural contexts. where we don't seem to have a cultural space for a third gender or a non-binary assignment. It is spread over the world, may not be so much in the West, in some countries, but certainly in a large part of the third world. People are yet to come to terms that you can have a childhood of ambiguous genital anatomy. Even if you have considerable parental support, social support is not always forthcoming. It is not just a question of somatic issues, question of standing up and voiding, not having a body, or not having a hydrometropulpose retained secretion hydronephrosis. It's not these immediate precipitant issues, but it is also social issues of prejudice, social reactions against the child, the family, how they have to meander through society, and often a cause of parental drift and divorce, especially in India. So they say that it's a social experiment to think so, and probably not reflective of what we should be doing in the third world. This is just a picture to remind us that there is such a variable anatomy, even with a similar sort of genotype or a biochemical assay, etc. And we know that you really can't move around in society. Many of them will not be able to move around in society with this unless some issues are addressed. Also, what else is for early surgery? Whatever psychologists say, they also agree that the gender identity, we do not know when it develops. We like to believe that it develops like 2 to 3 years or probably later, but maybe it requires a good sexual identity already priorized to be able to build on it. And what do we do about self-initiated gender assignment or reassignment? What answer do we have for that? Late surgery again leaves too little tissue for the age at puberty. And of course, advocacy groups are still quarreling amongst themselves whether, and they are not concurring on several points, including whether CH should be included at all as a DST or not. The literature that we have is old, it is heterogeneous, and you really can't, you do not have a solid research data there on many issues. Now, when can a child make decision about genital surgery? There are large gaps in our evidence that we have. There is no clear evidence base, and it adds to a condition where you have a rare condition, you have a heterogeneous condition, you do not have a registry, you do not have adequate follow-up. So what really are you backing on to make these strong statements? Several current studies also show a low sex reassignment rate, like the DSC Life study, which was quoted, and it seems that early surgery has worked well for those populations. So should adult patients who are dissatisfied really dictate terms? Going on to masculinizing genitoplasty, this is relatively uncomplicated and staged. It's done in a sequence: cordy correction, occipitopexy, urethroplasty, repair of penis total transposition, and so on. There is a clear timing in the first or second year of life. We know we don't leave the undescended testes high up, and so on. The question of gonadopexy and gonadectomy, we will come a little later. That is etiology specific, and breast surgery is done at puberty. Longitudinal follow-up shows that they're better satisfied, and there have been many content adolescents and young adults with early surgery. There have been problems like anejaculation, lower fertility outcomes, and so on. So just to illustrate, persistent Mullerian duct, which needs to be removed there, and the two intra-abdominal gonads, which need to be fixed. Now, genitoplasty, the urethroplasty in the proximal hypospadias is a technically demanding job, venous total transposition. We have gone through the DST life studies, so that is the range of the study, 150 patients, 84 hypospadias surgery, and they were all early childhood surgery. They were generally satisfied with function than cosmesis. Because PAIS is singled out as the single one where results were not so favorable, and that was a marker for poor results. Going to the androgen insensitivities, it's a common form as discussed earlier. Here the question is that there is a risk of tumors is negligible before puberty. Those are the general risks, 0.8 to 2%. So it is beneficial to resite it because there are popping gonads coming into the groin, and it can be left there for conversion and pubertal estrogen production, and it can be removed at puberty. That is the current consensus. Of course, there's extensive patient education which is required, and vaginal surgery for these is best postponed for puberty. Example of androgen insensitivity with the gonads being removed at puberty. Here there's already a vagina which mostly requires a dilatation and may not require a surgery. In partial androgen insensitivity, it is a little different. The gonads are in the groin, you have a greater genital ambiguity. There can be a problem with the vaginal pouchitis, it may need to be addressed. And the gynecomastia again would be treated at puberty. The ones which are read as females, an early gonadectomy is done to avert virilization and development of malignancy. The chances here are higher, it's 2 to 5%, and there are in situ changes which cannot be detected radiologically. And the neoplasms are a broad range from choriocarcinoma to Sertoli cell adenomas and Leydig cell tumors. So here the risks are different from complete androgen insensitivity. The most frightening group is, of course, the dysgenesis. It's a spectrum, a wide spectrum, the mixed gonadal dysgenesis being the prototype. They have varying secretory or generative function, so the gonads also cannot be judged at face value, but they have a significant malignant risk. And they need to be either removed early, or if they are retained, they have to be monitored very carefully. They can be relocated to the groin and the scrotal folds for monitoring. Very often we have a gonad which is streak on one side and probably normal on the other side, but this normal one also needs to be monitored. Bilateral streak gonads, which gonadoblastoma as early as the second year of life. The streak gonads can be very deceptive and they need to be carefully examined histopathologically. And the descended gonad also is kept under surveillance. The risk is prohibitively high, 30 to 50%, especially if the Y chromosome is there and it's intra-abdominal. There can be CIS right from the 3rd month of age, in situ, and mature to a germ cell tumor by a year of age. Risk increases, especially post-pubertal. Gonadal biopsy is a very tricky thing here, and the entire gonad has to be seen carefully. Just a simple biopsy may not help, and you might miss it. There's a mismatch between the macroscopy and the microscopy. And we have immunohistochemistry now with markers to particularly help us differentiate it from maturation delay and pick up the in situ lesions. Picture up panel is a picture of a gonadoblastoma, which has developed very early in a streak gonad. And the lower picture is a picture of many in situ lesions as early as the 1st year of life. The different tumor risk stratification, the highest being for gonadal dysgenesis and the lowest being for complete androgen insensitivity. So there is a stratification where you go in for dysgenesis, early gonadectomy, early or late. Kuhl believes that it is can be based on the EMS. In a female phenotype, an elective gonadectomy is advised. More undifferentiated gonad is more likely to harbor a tumor. The mild undervirilization, you can PEX and wait for surveillance. A similar thought is also expressed by Wolf and Buttel et al. Finally, it's hormone its secretion, a balance of that, compliance with surveillance and patient preference. This would be my last slide. So has already outlined the principles of deferred surgical management based on shared decision making. However, there is a lack of evidence base, and that is a hindrance to to a deferred surgical intervention. Yet, we are obliged to provide them with decision support tools. These are extremely important in a multidisciplinary clinic and careful surveillance and treatment planning. And we certainly need to develop new management algorithms to ensure the long-term health, not just of the genital tract, but also of the urinary tract and the safety of this retained gonads. Thank you.
Thank you, Professor Das. Yes, please take your seat with Professor Bajpai.
Jarinder?
Suchit, may we have some time for 2-3 questions?
Take a couple of questions.
Yes. So we can take up some questions for all the speakers. May I start off, please?
Take up the question. Can I ask a question to Dr. Hattori here?
Then you're eating into your own question time.
So this is not working. So
please pass on a mic, Suchit.
Yeah. So
Yes.
if there's any question,
Actually,
let us first handle that. Yeah.
Thank you. Am I so much?
Yes, Dr. Menon.
Dr. PSN Menon from New Delhi. Thank you, Professor Vajpayee and Professor Kanishka Das, for an interesting highlights about the current management protocols for both 46XX as well as 46XY DSD in your long experience. Despite the experience of the surgeons and the DSD teams managing these children, we are essentially under the control of the Government of India guidelines as recently as the June 2024 guidelines. And I think we are bound to follow these guidelines despite what is the considered opinion of the patient management committee or the medical board constituted by the ethics committee. There are many controversial situations that happens. So how do you decide that despite the advocates groups, because the advocate groups are essentially pointing towards late or postponing surgery as much as possible, whereas many parents are not on the advocate side. They want actually an early surgery before the child goes to a daycare center or the school, where the child has to independently manage passing urine or other activities. So how do you go ahead?
Yes, so we can pass on the question because your question is quite clear.
Professor Menon, my teacher at All India Institute of Medical Sciences, in fact, he started off endocrinology. Sir, you very rightly pointed out that despite all the regulations and everything, the moratorium part is weighing very heavily on us. It has a strong political overtones. This is very difficult to tide over. The only way to tide over this would be in the best interest of the children to collect enough data. The data that we were talking about through a very meticulous, prolonged, procrastinated effort by all stakeholders, recording data from the parents, the clinicians, and the involving support groups. I won't say activists. I mean, they are people who are advocates. They have got concerns. We have to provide them hard data, objective data to convince them. Therefore, it will be a long drawn process. And I don't want to make any off the cuff comment to say that recently there has been a sub judice matter, so I'm not going to detail. In Tamil Nadu, there was a moratorium. The pediatric surgeons there are running helter-skelter because we did everything right up to the government, as you said, sir. We could not change it. Therefore, these are difficult times. We have to be careful. We have to see case by case. And I'm sure when we discuss with the families, etc., we see civil virilization, we are able to offer. The difficulty is cases where we don't have much problem when you have surgical problems which can jeopardize urinary tract for that matter. We can go ahead, we can convince, document. But in between the gray zones, we have to see case by case. I think at this point, that's where we are.
Thank you, sir. Dr. Vajpayee, you said you had a question for Dr. Hattori. Please go ahead.
Thank you very much. So, Dr. Hattori, you mentioned a very interesting observation. And in pure gonadal dysgenesis, the incidence of malignancy is there when you have a Y line, not when there is no Y line. So, removal of that gonad depends heavily upon whether that Y line is present or not. And you mentioned that often it is difficult to get the Y line in over-testicular DST. So, this is a challenge. How do you overcome this? And I'm sure we won't have ready answers to this, but what are you doing to find it out?
The risk of
malignancy is very high. When the Y line is there in pure gonadal dysgenesis, there are two subvarieties: presence of Y line and non-presence of Y line. Y line has a very high incidence of malignancy. They should be removed. So you said that there is a challenge in getting the Y line detected in over testis. So what tools do you use to detect it? And if you don't, what all do you do? SRY.
translocation.
That's right.
And ovotestis.
You mentioned You mentioned, one of you mentioned.
I think he means that how to detect the SRY gene. But yeah, I think you can do the PCR.
It's a PCR of SRY is performed, and if the band is detected, the SRY is there. And another way to find it is G banding can fish. Fish is sometimes fish is a good way to find it, and also RACGH can be one of the options.
That's the only way.
Can I add something? At our institute, all the 46XX or testicular DSD or 46XX testicular DSD we will perform FISH for SRY first. And if we couldn't find that, so we go for other genes in the next generation sequencing.
Even in XY, you do that?
In XX, I mean, actually, we do next generation for all both XX and XY DSD. But for the XX over testicular DSD, we started with looking at is there any SRY translocation by performing a FISH FISH study for that.
Good, thank you.
Can I ask a quick question?
I'm afraid we have only time for one more question. That's what Suchit has indicated.
Good morning, I'm Dr. Subrata Dev from Kolkata, Apollo. I have a question to this esteemed panel. What happens with the XX severely virilized Prader 5 baby who later adopts a gender identity of male and refuses to play with his sisters and identifies himself as a male and plays with his brothers. Age 8, and the uterus was discovered after multiple MRIs much later. Is a CAH, which has been proven, both
Subrata,
biochemically.
Dr. Subrata, can you just be brief and just ask your question?
No, it's very important to give background, because the question is, what should we do now since the child is 8 years old, is genotypically a female, and will go into female puberty? Should we allow that to happen when the parents want this child to be raised as a male, and so does the child? What's your answer?
Well, I think we have to take into cognizance the sentiments of the child. Now he's an adult, or she, and the family. So we have to just respect that part of it. And the gender of rearing has been the predominant thing. We should just go by synchronizing everything which is there. You have no other option. It will have very devastating psychological impact if you want to do anything otherwise.
Thank you. So we should go ahead with a gonadectomy and a removal of Mullerian structures.
Whatever it comes.
Thank you. Thank you.
I'm afraid we have to stop this session. I myself want to ask some surgical questions, but I think all of us will interact with the speakers during the tea break. So thank you very, very much, all four of you, for wonderful talks. Over to Suchit.
Thank you, speakers and the esteemed chairperson, for such an informative and good discussion. I request Dr. Vijay Kumar and Dr. Ahila to facilitate the speakers and the chairperson at the selfie point. Also, I invite Dr. Nuri for providing the Kaichi Kanga best growth presentation.
So good morning, everyone. So now is the most awaited moment, that is we are going to announce the winners of the best presentations from the Kaiichi Kida session. It gives me great pleasure to introduce the award presentation for the best presentation winners from the presentations given yesterday in the Kaiichi Kida session. The top 5 scoring abstracts were selected for this session, and 5 judges scored based on criteria of scientific merit, communication style, originality of research, study design, methodology, results, and conclusions. And to present the award of the winners, I would first like to invite Dr. Nouri Kamba. Sir, please come onto the stage. Sir is the scientific program chair to present the awards for this Kaiichi Kida session. Thank you, sir.
Okay. I, as the scientific committee chair, would like to present the awards. There were some questions raised about the selection of the top 5 abstracts. So I would just like to explain that the top 5 abstracts that were chosen for the Kaiichi Kida session were the highest scoring abstracts. Initially, we had more diversity in the top 5 abstracts, but due to visa problems, some of the presenters could not come and could not be reached to present virtually in the session. And the SPC decided to have the next scoring abstract presented in the Kaiichi Kida session. So they are the top 5 that could be actually presented here. So I would like to present the awards to the winners. And firstly, I would like to acknowledge and thank the Human Growth Foundations for their generous support for the prize of $1,000 provided to the winner, supporting growth research in the Asia Pacific region. And I am delighted to announce the winner of the best growth presentation to be Dr. Nimisha Dange. And her presentation was bone health, body composition, and dynamic muscle function in Indian children born small for gestational age, a case control study. So, Dr. Dange, congratulations. So, best growth abstract and presentation, APIS and the Human Growth Foundation. Congratulations. Okay, now for the best presentation award. And HEPIS are delighted to support research in this region. And we also provide a $1,000 prize. And the winner is Dr. Devani Raisasta for her presentation, Development and Validation of DSD Interpreter, a mobile application-based tool for point-of-care evaluation of children with atypical genitalia. Congratulations. Please. Thank you. Dr. Devani Raisata, and you are the Kaiichi Kida Best Presentation Prize winner.
So please stay here. We would also like to recognize the other presenters in the session who were selected as one of the top 5 abstracts and invite them to the stage to collect a certificate of recognition for this achievement. Dr. Amrithendu Anuradhan. So Dr. Rakesh sir can come and collect. Okay, she's here. Okay. A big round of applause for her.
All the abstracts were very good. All their presentations were excellent, but we did have to choose, but your presentations were excellent.
Dr. Chiranta Posa. Congratulations, Dr. Chiranta.
Congratulations.
And finally, Dr. Sukanya Priyadarshini. Dr. Sukanya is not there. Dr. Vandana, you can come and collect the award on her behalf.
Congratulations.
Now we can all proceed for a cup of tea and we can reassemble and reconvene for the session at upstairs. We'll be having 2 concurrent sessions, oral presentations in the Parijat Hall and the Kesar Hall. So the sessions will start at 11. 11, 11, right. Okay.
Okay, so then none
less
of
than
them
10
was
nanograms, sorry.
No,
less
no.
than-
Is there any difference in the gross velocity if GH peak GH is less than 5 or less than 7 and
No,
less
sir,
than? Have
that
you
is-
divided in these three groups or
No,
no?
sir, no, sir.
Thank you.
Okay,
Thank you very
thank
much.
you.
Thank you.
Thank you. Let's proceed with the next presenter. Our next presenter is Dr. Nimisha Dange, who will be presenting on the comparison of the double burden of malnutrition in under 5 children using extended CIAF WHO 2006 growth standard versus 2019 Indian growth reference.
Good morning. I'm Dr. Nimisha Dange from Pune, India. Today, I will be presenting a study titled Comparison of Double Burden of Malnutrition in Under 5 Children Using Extended CIF on WHO growth standards versus Indian growth references. I will be discussing a novel concept to assess growth failure. Prevalence of double burden of malnutrition is quoted as high, 55.8% using Indian DHS data in under 5 Indian children, which is the highest among the South Asian region. Therefore, characterization of malnutrition using appropriate growth chart to include both under and overnutrition is critical. However, WHO growth standards have been reported to be a misfit in judging growth in under 5 children globally, and hence various countries have implemented local growth references. To implement national health policies directed towards malnutrition, CIAF has been proposed over traditional indicators. Composite index of anthropometric failure, I will repeat, composite index of anthropometric failure was originally devised by Nandi and Svedberg to include categories A to F and Y depending on stunting, wasting, and underweight. This concept was further extended by Kuiti and Bose by an additional line of overweight deflection to add additional categories group G and group H, stunting and overweight, and only overweight children respectively. Previously, in 2019, our group has published Indian growth references for 0 to 18-year-old children for over anthropometric records of around 46,000 children from North, South, East, West, and Central zone of India, belonging to middle and upper middle socioeconomic classes. In this paper, we have compared Team Cole's LMS method and synthetic references to compare height percentiles, weight percentiles, and BMI percentiles. Due to the increasing double burden of malnutrition reported from India, it is necessary to use appropriate growth references. The nutritional status of exclusively breastfed under 5 children is important in defining DBM. The wealth index may be used as a proxy to account for socio-economic status. Taken together, the objectives of the current study are to assess double burden of malnutrition in under 5 Indian children using extended CIF on WHO growth standards and Indian growth references, to study prevalence of DBM in predominantly breastfed subgroup and according to wealth index categories. This was the secondary analysis on NFHS 5 data. Standard deviation scores were calculated using WHO growth standards and Indian growth references LMS method. Complete anthropometric records for children between 0 to 59 months were included, and those at the extremes of weight for height, weight for age, and height for age were excluded. The final analysis was performed over 196,000 anthropometric records. WHO standards significantly underestimated the traditional indices like weight for height, height for age, and weight for age in comparison with Indian growth references. The prevalence of normal children in the category A was underestimated on WHO charts, while prevalence of under failure as well as over failure was overestimated on WHO standards in comparison with Indian references. The distribution of children in each category of extended CIF was significantly different on both the charts as per the McNemo's test. When assessed separately, males and females had significantly different distribution using both the charts for extended CIF. Across all age groups, WHO growth standards overestimated the prevalence of extended CIF. Category F included only stunted children, which is included in the definition of under failure. Category G included stunted with overweight, which is included in the definition of over failure. 4% children on WHO standards and 2.5% children on Indian references, therefore, found to be in the potential overlap of the definition of under failure and over failure. 31% normal children on Indian growth references were under failure on WHO standards. 5% undernourished children on Indian references were stunted on WHO. 11% overnourished children on Indian growth references were normal on WHO, while around 55% majority of overnourished children on Indian references were short normal or short obese on WHO. These short normal children were around 6.8% on WHO. The prevalence of normal children as well as under failure and over failure was similar in the predominantly breastfed subgroup as that of the overall prevalence using both the charts. The prevalence of normal children on WHO growth standards was seen to be consistently decreasing after the second year of life. While there was a dip in the prevalence of normal children on Indian growth references, this effect could be attributable to the shift of children from exclusive breastfeeding to weaning practices after first year of life. And this was complemented by a rise in the prevalence of underweight during second year of life, which was subsequently decreasing in the coming years of life. This implies that Indian growth references represent true nutritional status in the breastfed subgroup. According to wealth index categories, the prevalence of under failure was decreasing while prevalence of over failure was increasing on WHO growth standards. The prevalence of both under failure as well as over failure was higher in children belonging to poor households on Indian growth references. We explored the novel concept of extended CIF, and NFHS 5 data was analyzed, which is representative of the under 5 Indian children population. However, maternal nutrition and education needs to be assessed for double burden of malnutrition, and we require more longitudinal studies to understand the pattern of double burden of malnutrition over decades. To conclude, Indian growth references in comparison with WHO standards provide a realistic picture of double burden of malnutrition, which prevents further misclassification as either undernourished or overnourished. In comparison to WHO standards, Indian references represent true nutritional status in breastfed subgroup. In the context of impoverishment, Indian growth references show a higher prevalence of DBM when compared against WHO. Thank you.
Thank you, doctor.
I'm very glad that you have done the comparison both for under and over nutrition, because that's what is required from the chart and that's the need of the hour. And the best part is the WHO charts are very different from our Indian charts because they are the standard and their 50th percentile at the time of birth is 3.2 kg. And imagine our cohort as per NNF data is 2.750. So anyways, our cohort starts at a lower level. So therefore, you will get these deviations. So our Indian growth charts are important and WHO are just the standard charts which we are following. So that right from baseline, this difference is there. So that is what I wanted to clarify. Thank you.
Thank you. Yes, doctor.
Thank you. Wonderful analysis. NFHS 5 is predominantly tilted toward female in case of adults. 80% of NFHS 5 is adult female. Just wanted to know male-female distribution in pediatric age group. It's also tilted toward female or it's a normal distribution for Indian population?
I have analyzed data on under 5 children, 0
Yes.
to 59 months. And if I could show my slides once again. For the distribution.
Just give that information. That's all.
The
So just wanted to know.
It is not tilted to either of the gender. The distribution is almost equal.
Because we have worked on adult population, not this age group.
Yes.
So this was 70 to 80% females, predominantly females.
Yeah. As the
Thank
data is humongous, I don't precisely remember the numbers. I could show you through my slide.
Just ratio almost equal.
Almost equal.
Thank you.
Thank you.
Thank you. So now we'll move on to the next presentation by Dr. Nupur Wagasia, Reninoma, an unusual cause of growth failure.
Good morning, respectable seniors and friends. Unlike the previous studies, this is a case report of an unusual cause of growth failure. So, an 11-year-old girl presented to us with complaint of poor height gain over 1 year, along with complaint of continuous headache and occasional episodes of vomiting for the same duration. The headache was dull aching, diffuse, non-localizing, almost continuous, and only partly responsive to NSAIDs. There were very occasional episodes of vomiting, which, as per the description seemed by the parents, seemed to be non-projectile. Parents noticed that other girls of her age were outgrowing her in the height, and that was their main concern. There was no visual complaints, seizures, motor deficits, no history of any head injury or CNS infections, no history suggestive of hypothyroidism rickets, renal disease, or any malabsorption. She was born of non-consanguineous marriage, was full-term cephalic presentation, birth weight of 2.9 kgs. Her antenatal, perinatal, and developmental history was non-significant. There were no history of any childhood illnesses, and family history was non-contributory. Coming to the examination, her height was 135.5 centimeter and weight was 29.2 kgs. Although her height was within 2 standard deviation of mean for age, a review of her previous height records showed that she had always been on the 25th centile line. However, when she presented to us, the past 6 months had shown nearly no gain in the height, and this was accompanied by concomitant failure to gain in any weight. Her blood pressure was very high, 170 by 110 millimeters of mercury in the upper limb and 180 by 130 in the lower limb. Pulse rate was normal with no radioradial or radiofemoral delay, no pallor, edema, or icterus. There were no dysmorphic features or any syndromic features and no bony deformities. Her systemic examination was unremarkable and she was prepubertal. Coming to the lab evaluation, she had a normal blood count, liver function test, creatinine, urine routine microscopy. However, her venous blood gas analysis showed severe metabolic alkalosis. pH was 7.49, bicarb value was 29.5 millimoles per liter, and potassium was 2.9. She was euthyroid and her morning cortisol value was normal. Serum IGF-1 was low with a value of 63.5 nanogram per ml, and she had 46XX karyotype. For further evaluation for secondary causes of hypertension, aldosterone renin levels were tested. The direct renin concentration was found to be very high with a value of 858 microIUs per ml, and thus consequent serum aldosterone level of 36 nanogram per dl. She was started on treatment with amlodipine 5 milligram once daily, which resulted in normalization of blood pressure within 5 days, and she was given oral potassium supplementation. For further testing, a 2D echo was done which showed concentric left ventricular hypertrophy. Her bilateral renal arterial Doppler was normal. However, the renal ultrasound showed a well-defined homogeneously echogenic area in the upper pole of right kidney of size 1.3 centimeters. So, to further investigate, a CECT abdomen was done, which showed a 1.6 by 1.7 centimeter nodule in the upper pole of cortex of the right kidney with mild heterogeneous enhancement on the delayed phase. As the previous review of literature had shown poor specificity for the scanning in diagnosis of reninoma, we decided to proceed with a renal venous sampling for renin. We performed it on the protocol laid down by Wally et al. In 2015. So we found that the lateralization ratio was 1.74 to the right side. So for a cutoff of 1.5, the previous studies had shown a sensitivity of 56%, a specificity of 94% for correct lateralization. Thus, with the diagnosis of a right-sided reninoma, we proceeded with the surgery and a right open partial nephrectomy was done to remove the mass. The histopathological analysis of the removed specimen confirmed the diagnosis of reninoma with sheets of polygonal cells, well-defined borders, round uniform nuclei, and diffuse CD34 positivity. In the immediate post-operative period, her blood pressure normalized without the requirement for any hypertensives. Her headaches disappeared. And on post-operative day 3, the renin concentration was repeated, which fell from the value of 858 to 10.9 micro-IU per ml. Further follow-up at 6 months showed that her serum IGF-1 value improved from 63 at baseline to 179 nanogram per ml at the end of 6 months, and the same was reflected in the further height data. Over next 1 to 2 years, she showed a remarkable catch-up growth and regained her original height percentile. And over another 2 to 2.5 years of follow-up, she had almost achieved her target height in terms of mid-parental height. She had a spontaneous pubertal onset, menarche at the age of 14 years, and she continues to remain normotensive. Coming to discussion. In younger children, secondary causes of hypertension account for more than half of the cases, and thus these should always be investigated. Reninomas are functional tumors arising from modified smooth muscles of afferent arteriole of juxtaglomerular apparatus, and only about 200 case reports have been described so far across all the ages, with a female to male ratio of 2:1. Reninoma resulting in growth failure has not been described previously, likely due to the rarity of pediatric reninoma cases. The possible mechanisms that we could ascertain were in the previous studies of children with Bartter syndrome who have hyperaldosteronism and resultant hypokalemic alkalosis, growth failure was concluded to be due to electrolyte disturbance and poor feeding, resulting in the impaired growth hormone secretion. Experimental studies on rats have shown potassium depletion was associated with reduced growth hormone response to the GH releasing factor, with resultant fall in the IGF-1 levels. However, only hypokalemia cannot explain the growth failure, as achieving normokalemia in Bartter syndrome children, however, did not restore the growth. Other mechanisms that we could suggest are that chronic systemic hypertension can damage the endothelial lining and cause release of certain inflammatory cytokines, which cause relative GH deficiency, impairment of IGF binding proteins, downregulation of GH-IGF-1 receptors, and also impair the local GH and IGF-1 signaling pathways. So the take-home points from this case is that height deceleration rather than just an absolute value of height is an important indicator of underlying systemic illness. Wherever possible, the previous height records should always be compared. Growth hormone IGF-1 levels and action may be affected by many systemic illnesses, and many of which yet remain to be described. Removal of reninoma led to a rapid regain of height percentile in our case. Thus, evaluation for secondary causes and their appropriate treatment and timely management are important to achieve good height prognosis. Thank you.
Thank you, Doctor. Any questions?
Nobody is asking, then can I ask? Yeah. So not part of it's wonderfully worked up case, not part of your workup of reninoma. Did you check suppression of aldosterone in this case, saline suppression, which is seen in low renin hypertension? So you could have got more insight whether this aldosterone levels are suppressible or not. And could you check aldosterone level in your venous sampling? You checked DRC?
Sir, we just checked the renin concentration.
And not aldosterone. That could have given more information in unilateral production renin. Is there an increase in aldosterone level or not? But not required for your case.
Any other questions?
I think there's no more question. Thank you, Doctor. Let's proceed with the last presentation. So the last presentation will be optimizing growth hormone deficiency diagnosis in overweight obese children, a lower peak growth hormone cutoff for the insulin tolerance test, to be presented to us by Dr. Natakarn Numriskulkran. I hope that I pronounce it.
Yes, but thank you for your kind introduction. I'd like to begin my presentation by stating that I have no conflict of interest regarding this presentation. Okay. Well, we have known that obese children have lower basal and stimulated growth hormone levels compared to normal weight children. This is because obese child have higher leptin and free fatty acids, reduced ghrelin levels, that lead to increased somatostatin activity, suppression of growth hormone releasing hormone, and eventually it leads to decreased growth hormone production and secretion. However, the current diagnostic cutoff of growth hormone less than 7 nanogram per ml for diagnosis of growth hormone deficiency, which is currently used in many centers around the world, including our institute, does not account for BMI or obesity status. And this may result in overdiagnosis of growth hormone deficiency in obese children. To address this, we try to investigate whether a lower peak growth hormone cutoff from the insulin tolerance test or ITT can improve the accuracy in diagnosis of GHD in overweight or obese children. We retrospectively study the children under age of 18 with short stature or having growth failure who underwent the ITT for growth hormone deficiency evaluation at our hospital during 2018 to 2024. And we exclude the patient who has like some systemic illness to suppress growth hormone secretion, the patients with prior growth hormone treatment, and the patients with incomplete medical record. We collect data including demographics, anthropometries, IGF-1, IGF-BP3 levels, the bone age, ITT profile, and the final diagnosis. And we categorize the subject into two groups. The first one is the GHD and non-GHD group. We categorize by using the standard diagnostic criteria from Thai Society Pediatric Endocrinology. And in each group, we further divided them into the overweight or obese and non-overweight or obese group using the BMI criteria from the World Health Organization. Our institute used the standard ITT protocol. After fasting for 8 hours, we collect baseline blood sample, including glucose, growth hormone, cortisol, ACTH level. And after the insulin was injected, we serial measure the growth hormone, cortisol, and the glucose at each time point. And our institute used the chemiluminescent immunometric assay for growth hormone analysis. Our data follow normal distribution, and we use the following statistical method for the analysis. Out of 116 subjects, 52 have growth hormone deficiency. This group, 10 were overweight or obese, while the non-GHD group, only 3 has non-overweight or obese. And the mean age is around 9.6 years and 62.9% were male. Next, let's see deeper in the GHD group. We found no significant differences between the bone age, height, IGF-1, IGF-BP3 standard deviation score between overweight or obese and the other group. But we found significantly less delayed bone age in overweight or obese child with GHD, and also higher bone age to chronological age ratio and the bone age advancement in the overweight or obese GHD compared to the other group. And significantly, we found that the baseline growth hormone and the peak growth hormone from ITT in overweight or obese children is significantly lower than the non-overweight or obese GHD children. For non-GHD group, we found that the peak growth hormone from the ITT in overweight or obese children is lower than non-overweight or obese children, but the baseline were comparable. This is the ITT profile. I think it's quite the same in every ITT test. The peak, the nadir of the blood glucose occur at 15 to 30 minutes after the insulin injection, and growth hormone is peak at around 15 minutes to 30 minutes after the test. Okay, when we consider the sense and spec of different peak cutoff for diagnosis of growth hormone deficiency, Using the current cutoff of less than 7 nanogram per ml from all participants is used the scent and spec at around 96 and 70%. But if we consider in the overweight or obese group, the specificity is only like 66%. And if we consider using like maybe lower one, around 6 nanogram per ml is used scent and spec at around 100%. And even lower at 4 is used the scent and spec at 90 and 100%. Interestingly, we found no significant correlation between the peak growth hormone from the ITT and the chronological age, bone age, IGF-1, SDS, and IGF-BP3 standard deviation score. However, we found significantly negative correlation with the between the peak growth hormone from the ITT and the BMI standard deviation score, as you can see from the figure number 2. So let's go to the discussion. We found significantly less delay bone age in overweight or obese children with DHD compared to the non-overweight or obese one. This highlights the importance of like careful interpretation of the bone age, that the overweight or obese child with GHD may not exhibit like such delay in the bone age compared to the other. And BMI itself influenced the peak growth hormone levels in both GHD and non-GHD subjects with overweight or obese. And previous study and current research, our research confirmed a negative correlation between the peak growth hormone and BMI, suggesting that higher BMI can lead to growth hormone deficiency over diagnosis. The study proposed a lower peak growth hormone cutoff of less than 6 for overweight or obese children to improve the diagnostic accuracy and reduce overdiagnosis. However, I think we have to be mindful because the optimal peak growth hormone cutoff for diagnosis of growth hormone deficiency may vary across countries and may vary depends on the pretest likelihood of having growth hormone deficiency or clinical probability of each case, and also varies depend on the assay that used for growth hormone analysis. Our study also have the limitation, including the retrospective data collection and the small sample size, especially in the overweight and obese children. To conclusion, a lower peak growth hormone cutoff of less than 6 should be considered for diagnosis of growth hormone deficiency in this group of patients, maybe to lower to reduce the overdiagnosis and avoid unnecessary treatment. Thank you so much.
Thank you, doctor. Question?
Actually, it is not my question. It is my own personal experience to a case. I have an obese child, and on growth hormone estimation in all his samples, growth hormone was below 1, and the child grew normally as an adult. So BMI can have profound impact on growth hormone level. So it should be kept in mind.
Yeah, thank you so much for your comment.
A small, just, I want to ask, that we are talking in terms of 6.
Can we have?
Yeah.
Fine. Before doing growth hormone estimation test, if the child is growing within mid-parental height and obese, there is no need of doing growth hormone estimation. It will invariably be low.
Thank you for that comment, doctor. Can we have the question?
Yeah, the question is that, if you're having the patient, an obese patient, most of these obese will be stunted also, right? So that means you're talking GHD, it means stunted with along with the, bone age, we will be slightly more than normal for any other child of that same age who is non-obese. Okay, now what I'm trying to say that if we take a cutoff of 6 and we are maybe diagnosing more patients of GHD with the obesity. Overdiagnosis, no? Because if I take cutoff 7, Or if I take cutoff 8, it'll be easy. That means I will not be diagnosing the over cases of obesity. But if I take cutoff 6, I will be over diagnosing cases of obesity. I'm making more GHD with obesity, which is actually going in the opposite direction. I should be making less cases of GHD with obesity because I know the other obesity causes, BM causes changes in these factors. You understand what I'm trying to say?
I'm not quite sure that I
Rajesh,
understand
just try to.
or not. You mean that if we adjust the cutoff, we may result in
Over-diagnosing, over-treating many more and more patients because 6 is a lower level as compared to 7. So when you're taking GHD into consideration of 6 as a cutoff, you will be treating more patients, which actually may not be actually with GHD.
From my point of view, maybe, for example, if we cut, if the child maybe me 6.5 nanogram per ml, and we use the previous cutoff of 7, I might like consider having GHD. But if we lower the cut point to 6,
that is why when we treat obese children with the GHD, we always do it surface area. We never treat them on a basis of weight. So this.
Suggestion. When they train more larger.
Yeah.
Suggestion is very valid. You said there are many confounding
factors. Got it.
There are many confounding factors who is making GH low. And now you have make the cutoff again low. So you will be over diagnosis.
Did you excluded genetic or some causes of obesity?
Yes, we exclude the patient with, for example, Prader-Willi syndrome. We already exclude that.
Okay.
Yeah. Do you have like any suggestion? I want to hear from you.
Yeah, these cases have to be excluded for such a study.
Okay,
Yes,
so
thank you.
thank you very much. This wraps up our session. Thank you for attending this conference.
Thank you, chairpersons, and thank you, speakers, for the wonderful presentations. I request Professor Vanna Jain ma'am to come forward for facilitating our chairpersons. Thank you. Thank you very much. Now we can proceed for the AP's AGM. You can also have a look meanwhile in the posters, for the posters in the poster room. Thank you.
the box of the I was running team subclear complex skills. तुम्हें पता नहीं कैसे दिन से काम कर हालात में बैठे then the meeting and the tree हाँ something there actually it's kind of that here it's a match here ये तो रनिंग थी है ये लड़कियां भी पी सकती हैं मेरी ठीक है ओके हम कहेंगे क्या तो दिया फिर बाद की बात पिछले तो सब good good ये जब बच्चे आना क्या है हॉलिडे करती है हाँ परवाह पहले हॉल में पूरा दिन चलती है और मर्जी लगे पी ली पूरा दिन चलती है चलो मैं जा रही हूँ नहीं मैं जा रही हूँ अभी पी तुम लोग क्या करो तुम लोग को नहीं जा रहा कैसे दिल रहा इससे कुछ लगा मैं तो जाती कैसे आपका करती मानसी थी है ना मान लगा दी क्योंकि हम लोग मानती थे साथ में लेके चल के चल करे इससे पहले जीने बता दो तुम करो फिर बात बोलोगी ना मैं जाने नहीं दूंगी नाम कहते साठ रुपये गाना है Para kaya ko na no recognition. Thank
Good afternoon, everyone. Good afternoon, everyone. Please be seated.
Sirisha.
Dr. Javinder or someone could help with counting of heads, please. How many of we are here, ISPE members? Need to check for the quorum. Sirisha, how many members we are?
CT is what I always 20 minutes.
We need 90 members to be present for the quorum to be fulfilled. 90. But looks like including online. So the technical team, can you help us? How many online members are there? 4 and 37 in the hall. 39 in the hall plus 4, 43. So 2 more have entered in the hall, I can see.
Preeti has gone to the poster hall to announce.
So in that case, we are waiting for the quorum to be completed. Everyone, please be seated. How many numbers in the online meeting soon? 5 now?
50 here.
Okay. So we have completed half century in the hall. So this will be when not until that last meeting.
No, we have to wait for 10 minutes and then we wait for 5 more. Where's the 5? How? Meanwhile, you can do this. Your certificates of the
So we are waiting for the quorum to be fulfilled. We have waited for 5 minutes. We could wait for 10 minutes and actually then we can carry on. So we can utilize these 5 minutes to award the ISPE Clinical Training Fellowship to the first batch of 6 trainees who have completed ISPE Clinical Training Fellowship this year. This was the first batch and the exam was conducted last month at BJ Wadia Hospital, Mumbai. 6 candidates actually passed. I think it was 100% result, if I'm not wrong. Yeah. So Dr. Anurag, who is convener of the fellowship committee, would announce the names and the candidates. Can the ones who are present here could please come and receive their awards.
Thank you, Dr. Rakesh, and it was indeed a pleasure. And thanks for giving us so much support from the executive. I'll announce the name of people who are there first, and then there are other people who have delegated from there. We have got Dr. Shagun from Vijaywadia, Mumbai. I'll request Dr. Rakesh and Dr. Ahila to kindly hand over the certificates, please. Kavya. I think Dr. Kavya is not there, so you can take her certificate as well. Dr. Dr. Vibha. Dr. Vibha Yadav from Regency CDR Kanpur. Dr. Dhwani Raitheta from Regency CDR Kanpur. So we had this 2-year program. There was a common entry and common exit exam with a syllabus and other training as well. Dr. Jayashri. Dr. Jayashri is not there and she's requested Dr. Shaila on her part to collect it. She is from Davangere Bapuji Child Center. And the final candidate is Dr. Joivin Monterio. I think he's not there. He is from SRCC Mumbai. I think Abhishek is also not there. So we'll send him over post. So, and once again, I thank the entire ISPE executive for helping us through this fellowship committee, and the members of the committee, Professor Menon, Professor Raghupati, Dr. Shaila, Dr. Sudha Rao, Dr. Rajesh, they also helped a lot during the process. Thank you.
So I think we have waited sufficient time. So how many are online, please? 15 online? Okay. All right. Okay. So we have around 75, but I think we have waited at least 10 minutes post the scheduled time. So we can reconvene it and we can start with the proceedings. With the permission of chair, I'll start with the annual report to be presented for the year 23-24. So I think you're all knowing the council members, just to thank them all that whatever I'm presenting today, it's teamwork. And I have been ably supported by all the team members and guided by the advisors and patrons. So agenda, so the standard agenda of confirmation of the minutes of annual GBM, which was held last in Bangalore. Consideration and adoption of annual report of the society. Audit account statements, consideration and adoption. Executive committee elections, will be discussing in very brief about it. Appointment of auditors and fixation of their remuneration. Any other business if required. ISPE clinical training fellowship awards, which I think we have covered part of it. Honorary membership of ISPE to be conferred to, which we'll be announcing. And lastly, we'll be discussing in brief about memorandum of understanding to be signed with IAP, Central IAP. So can someone propose to accept the minutes of the last meeting, which we obviously circulated last year? So Dr. Shaila and Dr. Menon, I think they propose and second it. So we consider those minutes approved. Thank you. So these were the minutes. I think we can move on. So coming to website, Facebook and social media channels of ISPE. The team was Dr. Mahesh, Dr. Sirisha and Ayush. Thank you for working for the team. ISPE website has actually seen a lot of changes and has been quite dynamic over the last few years. So there are a lot of dedicated sections for trainees and for academics. So most of the members have updated their membership form online, and updated record is there for at least 556 members out of 900 total now. So we have easily accessible patient resources, professional guidelines available. So there are few added over the last 1 year, school resources for type 1 diabetes or other modules for school awareness and education in the school. And obviously we have up-to-date pediatric, up-to-date in the subject with sub-links to the journal, official journal of the society, Cape News, guidelines, all being there. So there are new subscribers to the ISPE YouTube channel, 631 new over the last 1 year. Facebook page has also have some new members, new followers. So update on ISPE membership. Dr. Sirisha, the Joint Secretary, had been the executive member in charge, looking for the memberships and completing the formalities. We can see here, this is the pie ratio between life and associate members. New members between November 2022 to October 2024. You can see actually up in the last 2 years, we have got new associate members more than the life members. The reason being the ideal courses and have been started where we are actually now giving more associate membership to the diabetes educators, dietitians, nutritionists, others. So over the year, the membership has been consistently increasing, and associate membership has increased more so in the last 2 years, as this graph shows. ISPE ACES program, it's academic and clinical education series. We call it ACES. It was started around 3 years back, 2021, 22. So Dr. Zalak is the EC member in charge who takes care of this program. And now we are having it every 3 months, usually where we have a foreign international expert, one national, and then junior trainees are also involved who usually present their cases. So we have had 4 of these in last 1 year. It's a 3-monthly activity. Pediatric endocrinology for postgraduates involving more of pediatric, general pediatric trainees. Dr. Amarnath is the EC member in charge, and we have had 2 such sessions in the last 1 year. Journal of Pediatric Endocrinology and Diabetes, the official journal of the society, which we launched in 2021. So it has been 3 years, nearing 3 years, and we have had 3 issues. Editor-in-chief being Professor Menon. We usually have 3 issues in a year, and slowly but steadily, it seems to be progressing, and we hope to have more submissions over the years. It's an open, freely available, freely downloadable articles. We don't have article processing charges. So we do have, we get over the time, obviously indexes would be calculated over the time. I'm not going into details for those. So these are total submissions over the last 3 years. They have been almost similar in the last 3 years. We are looking to improve and increase them as we go further. So these are the countries from where people are actually looking at our journal and downloading the articles. So ISPE Ideal, as you all know, Ideal is ISPE's diabetes education and learning program. So basically it's a capacity building sort of activity where we are trying to create more and more diabetes educators among the healthcare professionals who are taking care of children with type 1 diabetes. So these are the core committee members, and we have actually at least 70 faculty who are contributing to the program. And we strive to increase the numbers and maybe replace the older ones with the newer ones. We are always welcoming the new faculty who are willing, and they are basically volunteers. So we have, as you all already aware, that IDEAL was awarded at ISPAD as a innovation in the diabetes education. And now ISPAD has actually recognized it as, endorsed this program, and ISPAD plans to have it similar program for other countries around the world where we could replicate such program and help. So IDEAL is in fact a self-sustaining program as well. So whatever minimal nominal fee we have kept for the IDEAL trainees is being used for remuneration for the faculty as well. So ISPE is not actually gaining much out of it, obviously, and that's not the objective also. But just to say that finances are not an issue. Whatever nominal fee the idealites or the students or trainees pay, it covers for the expenses. So now this program has received ISPAD endorsement in 2024. ISPE Best is another program, basic education for the type 1 diabetes. So this is targeted to the parents of children with type 1 diabetes or caregivers or anyone who needs just basic knowledge about managing type 1 diabetes. So it's a smaller course lasting for around 6 weeks with 2 weekly sessions. Again, it's a virtual program. So we have trained 8 batches so far, 3 batches in a year in last 2 years, and at least 230 participants have been trained. Coming to academic meetings by the ISPE members. So there have been many CME or workshops, around 15 of them. Diabetes awareness activities pan-India by the ISPE members. So we collect this information through our Cape News and whatever information the organizers are sending us to the ISPE office. So these are the activities. I mean, ISPE members have been quite active over the last few years. The last year as well as been in the last few years. So these are few of the important or major events which I have listed here. First one was International Prader-Willi Syndrome Scientific and Family Oriented Conference in 2023 at Bangalore. Advanced Pediatric Endocrine Workshop at Jahangir Hospital, Pune by Dr. Khadilkar and team. CME on growth disorders on 1st May 2024 at Chennai, Mehta Hospital. Pediatric Onco-Endocrinology meeting, POEM at 2024 at Apollo Children's Hospital, Chennai. Coming to ISPE Observership Awards, these are the award. It's a small financial support which is given to the younger members who wish to do an observership of say 3 to 6 months or even less than that at a center where there is formal pediatric endocrinology training running, just to help them initiate in the field. So we actually give small support or grant of around 50,000 to each applicant, and usually we support 2 applicants every year. Unfortunately, no one has applied for this year as yet. So looks like we'll have to re-advertise it and maybe seeking more applications. Charity awards for this financial year, again, we have received 1 application. So charity amount we have increased to 1 lakh per year. So this charity is basically for supporting patients, whatever ISPE members are supporting to their patients in their clinic or doing whatever charity work, they can submit their bills and we can reimburse them. The charity committee obviously decides which ones are to be reimbursed. Or ISPE Pediatric Endocrine Fellowship, that's what we just awarded for. So this is ISPE Fellowship Core Committee, which Dr. Anurag just alluded to. So these were the members of the committee. And it's common entrance, uniform syllabus and 2-year duration. So these were the prerequisites of this, and it's a common exit. So first common exit exam was in September this year. And it started obviously the first batch in February 2022. So the first batch exit exam was concluded last month. And these are the centers where these fellowships are being conducted, training fellowships. So at least 7 centers as of date. So the exit exam, this was the standard pattern, theory, long cases, table viva. The examiners this year, this was the first exit exam, and these were the examiners. And these were the students who actually passed out. There are, I think there's a problem with the alignment there, but there are 6 trainees who passed. Coming to Fellowship of National Board in Pediatric Endocrinology, many of our team members were actually pursuing it. We know that FNB has been approved in pediatric endocrinology, has been approved, but how the centers will be selected, what will be the further micro details is being still discussed upon. Dr. Anurag, I think wants to add something. Yeah. Your mic is not working. Yeah.
Okay, so this was actually approved by the NB, and this is a 2-year program, and they have specific criteria which have been set in with regards to the pediatric expert or the adult expert as well. And already we had the first inspection in Wadia Children's Hospital, which has been done. So, and few centers have already applied. So hopefully by next year it should be part of the exam. So it's already been approved and the centers are being selected there. And the last date of application is October 30th. So the next batch that they are assessing has to apply by, the centers have to apply by October 30th.
So that's important information
So
for
if
all of us.
somebody wants to apply this
Yeah.
once, they can do that.
By 30th October, the centers who want to be part of this and wants to run FNB courses at their centers. Yeah. Okay. Thank you. Thank you, Dr. Anurag. So important project of Dr. Ahila and the team this year was ISPE Childhood Diabetes Registry. The new EC, this year's EC, when we took up the job 2 years back in January 2023, this was one of our pet projects, and we have actually successfully launched it, I would say, by the end of our tenure. So ISPE Childhood Diabetes Registry, it's called IPDR. So ispediabetesregistry.com. You can go on the website right now. It's there live. We have actually some of the centers on pilot basis. We had chosen around 10 centers to start entering their data to get the feedback and see if there are any issues. So we have, I think, received data of at least 500 records already and successfully entered, and it is running smooth as of now. So this is how it would be looking like. Basically, we have one form for a new patient to be entered, and other form is the follow-up. So even follow-up data for each patient can actually be. So we have taken care of any duplicacy. A patient going from north to south cannot be re-entered. We have tried to take care of those duplicacy issues. So if someone wants to start using it, the process is that you have to write to the IPDR Registry Core Committee, and we will be approving that center or that team to start using it. We will be just checking their basic credentials and give them username, passwords, etc., so that they can log in on the website and start using it. So obviously each center's data, they can analyze their own data. That is not an issue. But if we want to analyze data for whole of the registry, then we will be taking consent from all the different centers. So your center's data, no one else can have access apart from a national analysis when we do. Okay, so I think I'll just quickly. So this is how the form looks like. This is a follow-up sheet. So when you start entering data, any feedbacks would be most welcome. So another program of ISPE.
Rakesh,
yeah.
if you can just mention the email ID to which they have to write to so that they get the approval for entering.
I hope it's written.
Anyway, or else we can send a mail later.
We can send the mail now. So now we can officially open it. Yeah. Okay. So pediatric endocrinology for practicing pediatricians. This is another program started actually this year. Dr. Ravindra is the executive member who was steering it. So usually it consists of case presentation by the general pediatricians, I would say, or practicing pediatricians. So it is in association with IAP on digital IAP platform, and usually accompanied by talk by an expert. And obviously, I mean, it's catered to the general pediatricians or practicing pediatricians. So we have had, I think, 3 of these as of now, 5 of these already done. Another program or project was taken up again by this CC was pediatric endocrine modules for pediatricians. So the common disorders like type 1 diabetes, growth, and thyroid. So we have started with these 3 first, and we have made modules. There were contributors already decided and mentors, and we have finished after the peer review as well. So we have finalized these modules now, and we'll be launching it by the end of our tenure.
Yeah, this will be uploaded on the website, and any ISPE member who wants to conduct this as a program for local pediatricians can access it by special permission of the EC. And we will also try to find a sponsor for you to run the program.
So basically, these are designed in such a way that they could be part of a half-day CME also. So type 1 diabetes, we have divided into, for example, type 1 into three sets, I would say. Diagnosis, then evaluation and treatment, something like that. And in between, you can add the practical demonstration and small workshop can be done for the practicing pediatricians. So yeah, so ISPE wants to support this in terms of maybe providing a faculty if someone wants to do it, and some logistic support. So awards and recognition to ISPE members. So last year's ISPE, which was in Bangalore. So these were the paper winners. I mean, I'll skip it. They were announced there. So 2 of our young pediatric endocrinology trainees were selected for APS 2023 at Vietnam. Dr. Anil Kumar Vedwal received Excellence in Diabetes Healthcare Trophy from Delhi. He's from Delhi. Dr. Manoj Agarwal is part of his Spare Genius group. Dr. Swati Padmanabhan, consultant, Rainbow Children's Hospital, has received the International Scholar Award by Pediatric Endocrine Society 2024. Cape News. Yes, Dr. Ganesh.
I think Lakshmi is a member, associate member, Lakshmi Narayan.
Yeah.
So he's featured in diabetology. I think that is his story has featured in diabetology.
ISPAD website.
He has been recently awarded ISPAD Hero.
Yeah, just wanted to add that.
Yes, a very recent development. Actually, we missed that. Yeah. Thank you.
Revision for all of you. Okay. So no way is actually. Okay, so Cape News update. The Cape News continue to be important publication of the society and a source of information for all the ISPE members, and ably led by Dr. Ashima for the last 2 years. There have been some books and publication by the ISPE members. Honorary life membership of ISPE. So I would ask Dr. Ahila to come over.
Good afternoon, everyone. It's been a fantastic 2 years being the president, and I consider it a privilege to have been the president of ISPE with such a wonderful ISPE council, and Dr. Rakesh, Dr. Sirisha, and all our members. And we take it, we consider it a huge privilege to be able to award the honorary fellow membership of ISPE to Professor Wayne Cutfield. I thought I'll write a
Wow. Multiple layers. Yeah. Layers of light. Oh, wow. Yes, yes. You can sit by feet.
ISPE considers it a deep honor and a privilege to award honorary membership to Professor Wayne Cutfield. He's an empathetic physician, an astute clinician, and a teacher par excellence, and a dedicated researcher with decades of unwavering commitment to the development of pediatric endocrinology. And I think several people in this audience would acknowledge his contribution to the field of pediatric endocrinology in India too. The Indian Society for Pediatric and Adolescent Endocrinology considers it a privilege to acknowledge the contribution of Professor Cutfield to various aspects of endocrinology and present him the award of honorary membership of ISPE. He completed his initial training from University of Auckland and Otago. He has published more than 300 peer-reviewed articles, and he's been awarded several awards, including the Norman Wettenhall Medal for Research and Innovation, the Gluckman Medal for Research, the Howard Williams Medal for Health Leadership and Research, and he's the current director of A Better Start, a government-funded national science challenges with a nationwide network of more than 80 researchers in New Zealand. He has been practicing as a pediatric endocrinologist at Starship Children's Hospital in Auckland since 1990. His current focus of research are the role of gut microbiome in health and disease and the effect of early life events on later childhood metabolism, and understanding the epidemiology of childhood obesity and investigating interventions that could prevent or treat obesity. He is a friend of ISPE and has visited India several times as faculty at ISPE meetings and ISPE PET. Several Indian pediatric endocrinologists have trained under Professor Wayne Cutfield, and ISPE looks forward to continuing this friendship in future and takes great pride in honoring Professor Wayne Cutfield with his honorary membership.
I'd just like to say a few words and I'll come and join you, but the privilege is all mine, not yours. And I have to say, from a distance, and a distance is in New Zealand, so it's a long distance, it's interesting looking at the evolution of ISPE. And I remember watching the beginning of ISPE and then the growth of ISPE. And in Indian pediatric endocrinology, the formation of ISPE has probably been one of the most profound things that has happened in this country in pediatric endocrinology, because what it seems to have done is it's galvanized pediatric endocrinologists across hospitals, across cities, across states, across the country. And the one thing I would say is that you bear a lot of responsibility. And I say that because ISPE is probably the largest national pediatric endocrine society in the world. You're responsible for the endocrine disorders and diabetes for 460 million children. So the expectations of your country are huge. And because you are now such a large player on the world stage, the expectations internationally are also huge. So continue doing the great good work you're doing, which we've been hearing about during your presentation. And I wish ISPE all the success for the future. Thank you. So for the younger members, we usually have this tradition of inviting honorary member from the abroad. Professor Paul Hoffman, Professor Margaret is there. So they are the previous one who are sitting here in the hall as honorary members. It's really honor for us to have them here. Thank you. So coming to the money matters, which I don't understand actually, but I'll try to give you a bit of a glimpse. So space, again, I would say the main source of income has to be the conferences and whatever surplus is there from the conferences. Of late, yeah, obviously membership is also one of the important income group, if I could say. So membership has obviously significantly increased over last few years. We revised membership charges 1 year back. That also was approved by the GB. So right now we have this so-called healthy balance of around 50 lakhs, plus there is some amount in FDs. So this is this year's actually balance sheet. I don't know, I can go through this one by one, but yeah, just to say that, so this amount of 1 crore something is actually sum of all the accounts which are linked to ISPE, the previous conferences account using ISPE's PAN. So they are all actually slated here. So this is what it actually shows, but ISPE's account actually has what I showed in the previous slide is around 47 lakhs or so. So this is actually income and expenditure again. So if you can see the major income sources, this is here. Is it working? So on the right hand side. Okay, so I can skip that. So I have shared and circulated this. If someone wants to add something about it, that would be fine. So appointment of auditor for ISPE for the next financial year. So Mr. Manoj Bhatnagar at Lucknow has been our auditor or CA for many, many years, and he obviously does a great job, and we have continued with him. So this year he has, as expected, his charges or fee was same for last 5 years, but this year actually he has increased it by around 15 to 20%. So if I can show, this is what rate or invoice he has given this time. So he shared this with me yesterday only. So he has shown this charges of audit fee of 40,000 per annum plus GST. And in the financial year, when we usually have a conference, so another account is attached to it. So in that case, he will add 20,000 per annum plus GST for that year. So alternate year practically, if ISPE's PAN is used for that conference account. So this is his charges. If House approves, we can continue with him, or we will have to look for another CA to appoint. So how do we go about it?
No, the audience,
Any
members of
comments?
ISPE, if they agree and if somebody can propose and somebody can second, then we can agree with Mr. Manoj Bhatnagar speaking.
Sir, can you come on the mic? Yeah, mic. Yeah.
I think we should agree to this because he's doing the work so many years and are doing so well. Everywhere the charge is increasing. For you also, we are to our CA, he also saying the same thing. So I think we should agree. I don't know what the other.
Yeah, until unless charges are sky high, and if we can find someone with lesser.
Approved. To find another one, we don't know how he'll be, so it's difficult. So I think approved.
Okay, seconded and approved. Thank you. Last but not the least, but so as you, if I can give a bit of background. So Central IAP has been pushing us to sign a agreement with them or memorandum of understanding. As of now, we are working as ISPE, as a separate society registered, as well as chapter of IAP. But we are not officially, or I should say legally, the chapter of IAP because we don't have this agreement signed with IAP. So they have been asking this for many years now, but we have been sort of delaying it because there was many clauses in that MOU which were not suiting ISPE. So this time they have actually come with a revised MOU, which is very, very significantly changed. And we in the EC felt that it looks okay to be signed and going ahead. If I have highlighted some of the important aspects here. So we will be called as, if we sign this, we will be called as a collaborator or maybe offshoot of IAP. And we would be permitted to have our own constitution. And such constitution should actually be in line with the constitution of IAP as well. So So we'll need to chalk out what are the differences in our constitution when we compare with central IAP, which I mean, on cursory look, I thought it's not significantly deviating from that. The basic bylaws are practically similar, but we need to sit and I think analyze that. And obviously we as a society or chapter of IAP would enjoy all the rights and privileges which are enjoyed by any other IAP specialty group or subchapter. And IAP reserves the right to dissociate from us if we are not doing the way they want us to do, something like that. But yeah, so but the other way around, we can dissociate from them is not actually mentioned here. So, but I don't foresee any reason that we will be dissociating from central IAP for any issues. So positive in this particular MOU, we have been actually the 3-4 versions of this MOU have been in round in last 4-5 years. So this is the latest one. So here it looks like ISPE can have own bylaws, which we already have. And there is no clause which earlier was there that they can have control over assets. All our publications, all our activities will be actually by written as IAP's publications or assets or whatever you say. Negatives here is that, yeah, ISPE doesn't have a right to dissociate as per this MOU. Yeah, Dr.
IAP
Ranju.
also insists usually that IAP membership is mandatory for all chapter members, and that may not happen because we have adults who won't be interested in. We should have the right to dissociate. It should be equal. And I think you shouldn't be suggesting this till you've gone over clause by clause to see where we can get into trouble, because in the past, it's been a somewhat unequal relationship. IAP has much more strength. And so, you know, we should be in a position to guard ourselves before we say yes, or even maybe.
Thank you.
I second Dr. Anju Urmani. Once we are under the clutches of IAP, it's going to be very difficult. There are many other subspecialties who feel that. I won't personally quote that, but there are other subspecialties which are aligned with IAP, find it very difficult to function in the way that they want to. Since we have been an independent society, I think we can collaborate with them, but it's better not to be under the clutches of IAP.
Thank you, ma'am. Sir, please. You also second the same thought?
Just this Indian Academy of Pediatrics has been pushing us for a long time to sign this MOU. Actually, for the national conference at Hyderabad, they did not give us any chapter symposium because we and the nephrology chapter have not signed the MOU yet. But then this time they've actually changed a lot of clauses and it's much better. But as Dr. Anju said, we have to put our safeguards in place so that we also have equal rights to step away if we feel that they are stepping on our but they said the associate membership is not a issue because they have other chapters which have nutritionists and other associate members, and even in neonatology they said so. But I think we can always go back and ask them and then write to all ISPE members about what they've given us clarification, Rakesh, before we go through with this.
And I also want to add that there is a separate, IAP is conducting a common entrance exam for fellowship courses. So this.
So those obviously are not listed here in the MOU. So that will be different understanding. So it's not mandatory that we.
Nephrology, ICU, and
neonatology.
Everything is through common allocation, even hemato-oncology.
Yeah, I agree with that because as Dr. Anju and Anna and Divya said, they will just get us to sign this and then they will say all the rules are there in the IAP and if we don't follow, we might be actually.
Okay.
I think many of us are actually members of IAP.
All of
us. They are also members of ISPE. There are other associate members, regular members, probably adult endocrinology people are regular members in the society. They are members of the ESI. I am also a member of ESI. I am a member of ISPAD. I am a member of IAP. I function in IAP like any other things. So it is for us to decide whether we can independently function in each. We need not be all together. Each society has its own aims and suggestions. I am very concerned about the fellowship and other things that are offered by IAP. IAP has come out with a big advertisement about the fellowship for IAP members to pursue careers. Endocrinology is not part of it, number one. I looked at that advertisement. There are several other subspecialty groups which are not part. For example, there is no fellowship for cardiology, neurology, and several other specialties. Whereas some fellowships like critical care, there are multiple. So that just because we are part of the IAP, we will get a fellowship. Then who will conduct the right to conduct that examination, entry, and selection of colleges? It will go out of our hand. Number one. Number two, IAP also has what is called IAP college. For that is some major thing that is going to come, which is almost going to be something like National Board of Examination, and they will be independent society conducting examinations like fellowships, and then they will not allow independent organizations to have their own fellowship. It's accepted. We have got this type of Medical Council of India also has the same thing. So there are plus points of joining IAP and there are negative points. But I think if you look, we have grown up as a society over a period of time. We have like-minded people all working and meeting together. We have much more openness to work for 3 days together in a conference here. We may get 1 hour, 1.5 hour symposium and a pre-conference or a post-conference workshop along with a pedicon. Of course, we can also ask for it, but I think giving up our freedom and liberty to join, to be under the organization of IAP is something we should think seriously, especially the younger members, before we accept that.
Thank you so much, sir. I think we've taken everybody's notes into consideration. We'll go through. We will not sign for now, and we'll wait and take a decision later after again checking with all the members on how they think about it.
Yeah.
Ashima wants to say something.
Review committee which can see the clauses one by one.
Actually, this looks very simple, but that one clause which says you'll have to align by all the rules of IAP will actually pull you under. That's one place where
We can like invite volunteers who can actually
we,
do this work.
as Dr. Anju nods her head, I can say any number of years this has been going on, and that one clause can take care of it. Can just pull ISPE under if you agree to follow all their rules. Then ISPE may not be able to enforce any of its bylaws. And though you say you have your own bylaws, but once you agree to follow everything, and if they think this is in conflict with what they have, then you cannot function. So that's why it needs a lot of thinking. And all through these years, all the presidents and the previous secretaries also have gone through the same discussions. And it's always been a huge dilemma on whether to sign or not.
Yeah, Dr. Ganesh.
If the scenario is only loss of chapter symposium, losing chapter symposium is not only ISPE's loss, it is also IAP's and pediatricians' loss. So they can't blackmail us by saying that we are not giving you chapter symposium. That is one thing. I mean, there might be pros and cons. I mean, this document looks very simple to look at, and there may be nothing. And that point that you have mentioned is very, very important, that we also need to have. Secondly, I wonder about the legal validity of our bylaw is also a legal document, whereas this is also going to be a thing. So there should not be any conflict between these two legal documents and their validity. I mean, is it a document, supposing today some executive committee feels that this is correct, and the second executive committee that comes who feels that this is, or the thinking of general body changes. So, I mean, all these points probably need to be taken into consideration. So the other flip side of that is, like, once you decide to exist as a separate entity, then the IP will also be free to have some other people forming a chapter or something like that. So that is a cons of this particular thing.
Very valid point. 2 years back when IP started this IP college, at that time I think Anupam Mrs. Day was there. When new people came, they said, no, this is not the correct thing. So he's right. So today, if we join them, next time they said change these bylaws, and the next the president, and they said, no, they have to work under us.
So what do we do? So they postpone it for a time. Okay?
So if we decide to exist as a IAP chapter along with ISPE both, then we'll have to tread this thing with great caution. And I mean, we'll have to have some, I mean, as of now, our strategy seems to be delaying it as far as possible.
Yeah, several years we've been just keeping on returning the document, and so I think we'll go on to the next step. Yeah.
So last comment from Dr. Mahesh. So he's very hands in gloves with IAP, is it?
So I think as an EC member, I was also given the responsibility to go through with the IAP constitution at the same time and the SPA constitution. So I just gone through with both the constitution, and what the actual IAP constitution is saying, this MOU is comparatively much better, which Dr. Shaila and we started discussing, Dr. Ganesh, from last 4 years. So I think this MOU is comparatively better, but the main IAP constitution at one of the point is saying any society can have an MOU with an whatever the dissociation they are having, whatever the points where they are deviating from their own constitution, they need to mention that in the MOU. So if those points can be mentioned in that MOU, and then it can be signed. So those points is already mentioned in that MOU, then probably there should not be any harm, because any society grow when there comes in agreement with some other society or some other universities and all those things. So that is actually a growing part. So my personal opinion is that we should put, this is only a single document. So this single document is okay, just like you said that space right to dissociate is not there. Similarly, there are many points, just like our council formation. We are not having a council as per the zonal constitution. So we are having our council also different. We are having a president in a different way. We elect president, treasurer just now elected. So probably those deviation we need to put in this MOU, and then this MOU should be sent to the IAP, and then let their reply come, and then probably again the wise people can sit down and then they can decide that what should be the right way. But in personal opinion, because whatever I am knowing about the IAP also a little bit, they also probably in the thought process to start the pediatric endocrinology chapter. There are few people who started this part, and I think they contacted many of us who are there. So there may be an unnecessary and we are working in coordination with them, since I think sir and these people are started this space society.
Thank you. Okay, Dr. Mahesh. Thank you. We'll have to carry on. So space interest has to be the prime. I think that's one thing. Second, we need legal opinion, and I think we need to hire a lawyer to look at all these aspects, and then maybe we'll have to take a concerted call. Obviously, the just EC cannot decide on this. Thank you. So anything more, Dr. Ahila, you wanted to have? Okay. ISPE elections, the invitations are already out. So maybe we will have to extend the date. Most of us were busy with the conference, and we'll have to extend the date, and please participate in big numbers and update your membership records or details on the website. So that's how the online voting will actually be useful. 11th October is the last date, is it?
Of October is the date for submission of forms. So maybe I think there is no need to extend the date. If I will not get any applications till 11th, then maybe we will extend the date.
Thank you so much, Rakesh. We want to thank
about the election only. I think the rules say that if you do not have sufficient applications, it has happened in the past. For example, for a particular post, there are no applications. The number of executive members, we have not got difficult number. Then a second advertisement circular is sent to general body for the remaining posts. That normal way it will proceed. And if there is a need, you can always recirculate the election notice. That is what I feel.
Let us say that if we have 11th October as a date of final date of submission of applications, and there are not enough applications for the post till 11th of October, and then you extend the date, and then you get more number of applications. But I feel that it is unfair for people who have applied till 11th of October they should be selected by default and then rest of. But I don't know what others feel. But if whether an election should be conducted for the remaining post or what.
No, Dr. Menon sir was very clear. What he said was the same. You select or elect the people who already applied. For the posts that are vacant, you will advertise.
If there is no applicant for particular
post.
For example, this happens typically for executive council members that let us say there are 7 posts and you get 5 applications and you extend, and then in the extension you get 11 applicants. So those 5 who had applied in the given date ideally deserve to be like elected unopposed, and only for the remaining 2 posts there should be election.
I think your point is well taken. The election, our rules clearly say they are selected for the remaining post. It is written. So the 5 people need not contest along with the 2 or the 4 people or the X number of people who are contesting. Those who are given application in the limited period, notified period, they are automatically selected for a vacant post. Suppose for the joint secretary, nobody has applied. You have 7 posts of EC members. Only 5 has applied. For the remaining posts, only the notification has to come. I think we don't have to postpone the elections for that.
Thank you so much for such a wonderful participation and very good AGM run by Rakesh. Rakesh,
One point I need to, sir, in continuation with sir, I think I just gone through the SPA bylaws also. So at that point of time, probably there is no re-election. So there will be nomination for those 2 posts by the Executive Council approved by the GB. So it will not be re-election, or the election notification will be extended for those 2 posts. That will be nominated by the Executive Council. I think that should be the.
That was the original notification. Yeah. Now we opened up in 1 or 2 sessions. This has happened that we said that instead of it being prerogative or the office bearers or the elected executive nominate somebody, it will be better to have those filled by open general body members applying for it. So that's it. It is for that, I think we don't have such a severe fighting canvassing election. We are much more cohesive approving group. So let us continue. I think let us not have infighting for all these things.
Thank you so much.
So I have nothing about election, but about, sorry.
Since you pointed out that it was written nomination, then it has to be, the rule has to be changed by special GBM and all that. That formality has to be done, sir.
You will leave that to the next PC.
Yeah, we actually looking forward to
I think
handing in a lot of whatever unfinished work we've left. We will give it to the new EC and we'll hand it out with a lot of happiness and pride, and see to that they also have something to do further in their tenure. Thank you so much for such a wonderful interaction.
I have one comment, Dr. Ahila. I think I want to tell all the members, I think our Executive Council members, especially all 3 of you are very well aware. Our society is a society which actually do not pay. We are exempt from several rules of the income tax authority of the government of India, because it is a society which is functioning for the purpose of patient care, other related services, educational purposes. And we have to show in our annual report that these things are happening. The conducting of the workshop, training for all these workshops are part of it. One of the major participation of that is the charity activities of the society, as clearly mentioned in our constitution. So it is very sad that you are all doing charity activities, but it is not represented. When we advertised or circulated, we have only 1 applicant till now for 12,000 rupees. So I think maybe many of your institutions are doing it already, but those of you younger members who are conducting, for example, diabetic camps or educational camps for a particular disease in your own local area, you can get a part of that expenditure that you are incurring for conducting or inviting patients or preparing patient-related materials. All those things you can ask for up to a limit of 50,000. You can ask provided by supporting bills and documents. because it has to be audited by the auditor. So if you do that, you will get it funded, reimbursed by the ISPE. So please do apply when this. I think it is very sad that out of our 600 members, only one has applied for clarity.
They were all busy with the conference, so they will apply now.
With the conference apply.
Yeah. Thank you so much. It has been a wonderful 2 years with the current Executive Council. I had an amazing time. I had a brilliant secretary, Dr. Rakesh. I think I can't owe a bigger thanks to Rakesh. He's been working tirelessly, both as the secretary and also as the organizing secretary of the meeting. And Sirisha has been, I have no words to express my thanks to both of them for the amount of work they've done. And all my executive members, I actually have to thank each of them. Ayush, I think, called sometime at 10 o'clock and said, Ayush, can you help? Mahesh, I don't think I've ever respected anybody for their time or their busy schedule. Just call without any shame and say, please, can you do this? Can you do this? And all of them have obliged and been so very helpful. Zalak, and then Chetan, then Amarnath. I think all of them are here. Oh, okay, Amarnath is here. And then Ravindra, sir. I think I just call and say, sir, what has happened? We've not moved. Where are we? And I think he's actually taken all that abuse also quite well from me. I think, have I left out any of our AC members? Jaivinder. He's been like a rock. He's actually a very cool person who stands without any emotion, but does his work so well. And I think Rakesh can vouch for the amount of help Jaivinder has given to him. So I'm very, very pleased and we are very proud to have worked together as a team. And we, as a ISPE Executive Council, we owe a deep round of thanks to this organizing committee of this fantastic meeting. We are really thankful to Professor Rajesh Kadgewad. Sir, thank you so much. And for the amount of effort and work. And Professor Anju Seth, madam, we are really thankful to madam for all the, I think all of them have not slept for several days and weeks and months, I think. And then Rakesh, and then Ravindra sir, and Jaivinder, 5 of you, I think like Pancha Pantavar, you've been really hardworking and you put together such a wonderful conference, and the whole Executive Council and the ISPE members are deeply thankful to you for this wonderful conference. And I'm really thankful to all the ISPE members for supporting our executive all through this. And we hope and we wish the next team the best as they come in. Thank you so much.
Thank you. Thank you, everyone. Next, yeah, so next ISPE biennial meeting is in Nagpur. Next ISPE biennial meeting is in Nagpur and early bird registration has already started. You will be getting flyers and you can actually register if you want right now. All EC members, if they can actually assemble near the stage, we'll have a group photo. All EC members of ISPE, the present EC members. Yeah, so next session is management sessions. In the same hall, it will be hypogonadotropic hypogonadism, I think, and the other 2 on the level 2. And at 5 o'clock, there is a sponsored symposia by Novo. We request all of you to, they are our gold sponsors, and I request all of you to attend the session. Next conference again. Please register for the next conference, Space Biennial Meeting at Nagpur.
I don't know what people
अभी concurrent section है
Current session. Current session. So here is the mega. Is that help not play? Thank you. Welcome. TV for TV. You never. I just figure that. But don't know. So I just looked at them. It was like तुम्हारा ये सब हो गया देखा एक बार टिकट में नजर मारी है कुछ लगवाने नहीं पड़ा तो टिकट को काम तो लगता है कुछ काम करते हैं मैं चल के कमी बस भारत में अब तो ये चला जाएगा एक सेकंड में मेरा मोमेंटो फाइनल हो गया पता नहीं वहां में नीचे नहीं और यहाँ तो बचा इधर तो अंदर करेगा मैं खर्चे का चिंता आगे ज्यादा है कम है ये बताता हाँ बताएं
अच्छा
Sorry. अब आप बात लिख सकते हैं ना टाइम टेबल भी तो मेरी नंबर हाँ हम तुम सेवा ज्यादा मत बात करते हैं तब दोनों को साथ में टाइम वहाँ तो मिल जाएगी Thank you. Luigi? You might this is very important. हमारे ऑनलाइन में कोई का एक कॉम्पिटिटिव हुआ था कोई पेपर ले गए और ये हम और बात बचे थे इसमें तो ये भी जानते हैं कि करके अब पूरे आपके जो डिमांड इस को कवर करते हैं एक मिनट तो ये करते हैं अभी यहाँ वाले जो मोमेंटो है वो रेडी नहीं है तो फिर थोड़ा एक भाषा देना चाहिए को नहीं है तो सीधी कर रहे हैं हाँ नहीं जा पाए अपने ऑलरेडी आगे करा लिया छोड़ दो ये इधर हाँ हाँ नहीं वो एक्चुअली मैम ने वहाँ कुछ चेंजेस हुए थे तो हम दोबारा रिव्यू के लिए पूछा हाँ 2 मिनट आ रहे हैं आई नो आई मैम एक्चुअली अभी ऑन स्पॉट चेंज करवाए हैं तो वो डिग्री वाला
What is session called? MT. Hello. Good afternoon, everyone. I welcome you all to this MTE session on hypogonadotrophic hypogonadism.
So let me introduce you first.
That's what I was thinking.
Yeah, so we have Dr. Subrata Day, Senior Consultant Pediatric Endocrinologist at Apollo Multispeciality Hospital, Kolkata, and he's going to introduce our speakers, and we're going to have a wonderful session on management of hypogonadotropic hypogonadism. Yes, sir, all yours.
Thank you for that timely reminder. So welcome back, all the ISPE and other members. Let me not waste any time. Dr. Nalini Shah needs no introduction. and I think she spoke yesterday as well. But essentially, she was the president of the Indian Society. ISPE. She has 220 publications, and my association goes back to 1985 with her when she was in CMC Vellore, where I was a DCA student and she was young faculty. So welcome to the show. We also have now Dr. Manjari Karlekar, Assistant Professor, Department of Endocrinology, GS Medical College, and KEM Hospital. Welcome to the show. So with these words, let's start. Go ahead.
Yeah, thank you, Subrata Day. And ladies and gentlemen, thank you for being here in this hall. I know there has been sort of a meeting which has just got over, but all the same, let's begin with approach to management for patients with hypogonadotropic hypogonadism. What Manjari and I have tried to do is that we've just tried to collate our experience that we've garnered in our department, and I've tried to make this a very, very clinically orientated kind of a scenario. And I do realize in the audience we have some big wigs, so we're going to have some help from Paul and Margaret as well. And um, so please do help us out, all of you. So let's begin here. The whole session is divided first into diagnostic approach, then we get on to the representative case scenarios, and then we get on to the management in terms of its principles, and again represented with our relevant case scenarios. So if I just talk about this particular child who is 14 years old and who presents with delayed secondary sexual characteristics, this is a very common referral, and this is the typical age group at which this referral really comes. And the question then comes up is, how does one clinically approach them, and what are the relevant test parameters that one would use? What are the cautions in interpreting these test parameters, and the performance of these tests? How do they fare in different clinical scenarios? Does one really need to fall back upon genotyping these individuals, and what kind of yield is this genotyping going to hold? And finally, what we are most interested as clinicians, and of course as a family member for those patients, is how do we really manage them? So we know that puberty goes through these multiple phases, starting from early fetal life, where it is completely governed by maternal HCG, which in turn sort of governs the functions of Sertoli cells, the Leydig cells, and we have the complete formation of genitals, which is taken over then by about 15 weeks of gestation by the HPG axis of the fetus. The mini puberty begins somewhere at just before the birth and sort of continues in a male child till maybe about 3 months to 6 months. And then we have typical events of puberty which really follow, which is governed by all the central parameters, the hypothalamo-pituitary axis, which in turn governs the testicular functions, namely the Sertoli cell function and the Leydig cell function, respectively. We do understand and realize the cutoff, or sort of a working definition of who should really be called as delayed puberty, but we understand the flexibility of this definition. We don't want to wait till 14 years of age. We are more than happy, even in a young infant, to call and make a diagnosis of hypogonadotropic hypogonadism. And it works across the whole span, right from birth to puberty. So 14 years is not a sacrosanct event, but till 14, if there are no beginning or no signs of puberty, it definitely sets off a kind of concern in the mind of parents and the physicians alike. Representation of delayed puberty or its manifestation varies across the lifespan of an individual, starting with micropenis and cryptorchidism at birth itself, to just a partial or complete absence of puberty. It can even be complete development of puberty, which presents only with infertility, or just a physiological delay in a start and tempo of puberty, like constitutional delay. It could be truly a state of delayed puberty which reverses itself spontaneously or under the influence of sex steroids, as it is known to be. Or it could be an adult who's fully sexually mature or even could be fertile, who kind of reverses the entire cycle to become hypogonadotropic hypogonadism, which is also well described phenomenon. Hypothalamic amenorrhea is also sort of put together under the same spectrum of differential presentation of delayed or arrested puberty in an individual. These are the four common group of causes that we deal with. The two central causes, the delayed puberty, which is self-limited delayed puberty, or permanent state of hypogonadotropic hypogonadism, which works as a closest differential diagnosis. And as a clinician, it is our sort of job description to try and differentiate between the two, because that's what is going to be the governing factor in terms of prognosticating and, of course, putting together the management as well. Hypergonadotropic hypogonadism is relatively less difficult in a clinical scenario to kind of put together as concern or as a diagnostic challenges. And when we talk about these etiology and its relevance in terms of commonness, it's the constitutional delay of growth and puberty, which can account for nearly 60 to 70% of individuals who present with delayed onset of puberty. So the first part of the entire assessment needs to rest on either a systemic or an underlying metabolic event which is leading to functional state of hypogonadotropic hypogonadism. And we always try to work together towards a general assessment of the child and these basic set of investigations to make sure that it is not systemically driven cause which is giving a delayed onset of puberty, which is something which is really, really well known. And we have encountered that even in patients with CKD presenting as delayed onset of puberty. So it's something which
they may have, little knowledge of what their glucose levels are actually doing. All of a sudden, you've got 24/7, all the glucose levels and all the information that goes with it. So here is someone I saw recently. She's a 16-year-old girl, once again on MDI with an HbA1c of 8%. And when she started CGM, it created a lot of conflict in the family, particularly between her and mum, because basically mum thought she should have a flat trace of CGM. And every time her glucose levels went high, she phoned the daughter. You can imagine the embarrassment that caused the daughter. In fact, the daughter became quite overwhelmed and ashamed with that. She was very keen to switch to a reader. So if you're not familiar, basically when you wear CGM in real time, you can choose for it to go to a reader, which is a standalone device, or to the phone. Now, the good thing about a reader is that you can't follow live. So many teenagers or people that are worried about Big Brother or people watching their glucose levels may actually choose a reader instead of their phone. And one thing that the girl is really distressed about is, why do my glucose levels go up when I'm not even eating? Mum keeps phoning me. I'm trying my best, and the distress that came along with that. So in terms of basically tips to try and reduce that, I think what's really important right from the get-go, and this is why it's great if the diabetes team can be prescribing CGM, or at least starting that conversation about CGM, is setting clear and realistic expectations for both the person with diabetes, but also all their followers. In fact, with the newer models, the number of followers can go up and up. In fact, some people may have 10 to 20 people following their glucose levels. And it's about also making sure that they're aware, not to cause distress for the person themselves. I think it's really important to know what a normal CGM trace looks like. Out of interest in this room, how many people have worn a CGM themselves? Get one? Yep. So it is something which I really encourage all healthcare professionals to do. Hopefully you don't find out you've got diabetes. But I think, for example, myself, I'm lucky enough not to have diabetes. It doesn't matter what I do for breakfast. It can be a little tiny thing. It could be a big meal. I will go up into double figures. I'm only there for a few minutes before I shoot back down. I stay at 5 pretty much millimole per liter for the rest of the day. I have a bit of fun and try and challenge a whole lot of carbs throughout, for dinner. I won't go above 7. And then overnight, I'll frequently drop down sort of between 3.2 to 4 millimole per liter. And that's normal. I think CGM is actually going to redefine what normal glucose levels are. And I know that many centres already have chosen to go down for that lower limit of glucose down to 3.5 millimole per liter. But this is showing the evolution, and I'll show you what a normal CGM trace looks like. I concentrate on time out of range. Now, I know that may sound like an oxymoron or a misnomer, but we're aiming for our target time and range for most is greater than 70%. What that means is that you can put it the other way around to people and say you can actually spend 6 hours out of the day with high glucose levels. That's completely normal. You can still reach target. You don't have to be hard upon yourself if your glucose levels have gone high for a few hours each day. And just focusing at that round, psychologically, is a lot more acceptable than the other way around in terms of saying you've got to stay between 3.9 to 10. The other way also do that is, every 1% time and range, you can say that's an extra 15%. Oh, sorry, there's an extra 15 minutes each day that you've spent in target glucose levels. So even a 1% rise, you can put it, it's an extra 15 minutes. That is significant. This is something else I'm really big on. It's really emphasizing the importance of lifestyle ruling diabetes and not vice versa. It's about doing everything that you normally would and then altering the management to allow people to reach their targets. And what many people do when they start CGM is all of a sudden they change all their behaviors. That may be some good stuff that's changing, but often, you can get a lot of that distress because they won't exercise because they're worried about going low. Or you may get actually disordered eating and malnourishment because they're not having the intake because they're worried about the high glucose levels. And it's very much about living a normal life first and then adjusting the management around that. Was spoken about customizing the alarms, particularly the upper threshold alarm. And I think it's also what the data on CGM means, and then how you use that data, how often you review that data to then make changes. And just remembering that people with diabetes probably spend at least 99.9% of their lives out of contact with their diabetes team. It's really about how can you set them up to make changes to their insulin and, in between appointments and just not relying on the diabetes team. And the good thing about time and range is that it will change each week. And many of our families have been very used to HbA1c. It takes a full 3 months to change. It can get quite depressing having to wait that long to see any positive feedback on behaviour. But actually reviewing time and range, I do say, why don't, as a family, you sit down, for 5 to 10 minutes in the weekend, have a look at time and range, have a look at the patterns, and then make changes based on that from what you need. Another thing I'm also very big on is making sure that every person has a treatment plan. Because they may not know what to do when their glucose levels are necessarily high, or you want to prevent stacking of insulin, for example, if they're correcting. And how can they make changes to their mealtime doses, their insulin to carbohydrate ratios, to make sure that they can get themselves down to target. And part of that is when to check blood glucose levels. Now, because you will, pretty much all the marketing around CGM is that it replaces blood glucose levels 100% of the time, which I talk to my families about. That's not true. There are certain times when you do want to check blood glucose levels. Now, the lag between blood glucose levels and interstitial glucose levels to blood glucose levels is a lot less. Now, it's often only a few minutes at best. But there are times where, particularly if there's a mismatch between what the CGM shows and what the symptoms are, that it is a time to check blood glucose levels. For example, if the CGM was reading 3 and the person was asymptomatic, I wouldn't necessarily jump into treatment. That is a time that you would check blood glucose levels to make sure that they are low before treating. At the same time, if the CGM read 3 and that was symptomatic, I'll definitely be treating you. You're not waiting. The other part of that is also explaining why blood glucose levels may be different. Now, I can tell you the New Zealand experience is that we only have one funded glucometer, and that tends to read higher than venous glucose, whereas our CGM tends to read lower than venous glucose. Both are well within that 10% margin, but when you start comparing the two, there is a difference there. And it's just letting people understand that that is normal. Both are right, but you go with the one that you trust. But if you are in doubt, go off the blood glucose levels. Otherwise, the CGM is generally fine. Here is an example of a normal CGM trace on Libre. So please note you can get big spikes after meals. People will drive themselves nuts if they try and get a flat line. It is virtually impossible. It's also common to go into the 3s for people not on insulin sulfonylureas. And I'll talk a wee bit more about that, including compression lows later on. But I think if everyone knows what a normal CGM trace is, and I do show people my trace, I find it a really powerful thing, saying, look, this is what my glucose levels do. Yours will do the same. It's completely normal. This is straight off the Diatribe website, but there are many things which affect glucose levels, far more than just food and glucose. And, for example, I will have, they are teenagers and not necessarily children, but I have many which will give themselves a bolus insulin for a coffee, for example, or soft drink just to counteract the effects of caffeine. Particularly around the menstrual cycle, there's lots of changes in insulin requirements, and these are it's just not food and glucose, food and insulin, and it's just trying to get that message across as well. So I'm going to come on to separate now. So, are there any questions about that at all? No. Please feel free to sing out anytime if you do. This next part's going to be on diabetes team distress. So, because we know that it can cause distress for the person and their family, but it can also cause distress for your team. Now, we've been very lucky that on Tuesday in New Zealand, CGM finally became funded for the first time. It has taken years of long battle, but with the funding, it's actually come along with a whole lot of stress for diabetes teams about what do we do with these reports. And I really encourage you to keep fighting in all your countries. I know that most countries at this meeting do not have funded CGM, and it's about continuing that battle. We've only got it for type 1 diabetes, but it's a start, as it has been in every country. And a big part of my last month I had a lot of colleagues, both in secondary care within the clinic and in primary care, just completely overwhelmed by CGM reports. Common thoughts were, I do not have time to look at the 15 and 20-page reports. I don't know what I'm looking at. This is so much information. What are the best things to look at? What can I skip? I understood HbA1c, but I don't understand CGM. And how can we make that easy for our people? This is a way I teach. I'm not saying it's a perfect way, but I basically explain to everyone, I think you can easily interpret CGM within 1 to 2 minutes. You often don't need to go any further past the first 2 pages of the report. I'm going to show you now how to do that. It's just providing the education and confidence to do so. So there's only 5 steps. The first step is there enough data? to make management decisions. Now, this is really relevant for those on intermittently scanned CGM, which I know you do have the Freestyle Libre 1 as a mainstay here in India, for example. International consensus is basically if you've got more than 70% of sensor usage, that's deemed adequate. Now, sometimes I think you can make clear decisions on less data, but that really relies on data at the same time every day. Because maybe, look, they only scan once a day, and you can use that 8 hours worth of data to make changes at that time. I have had plenty of teenagers that wore the Freestyle Libre 1 for their parents and never scanned. And that's the hard part as well. You're trying to at least get that, using the data you've got to make decisions. The next bit is knowing what other targets that we're looking for on CGM are our people reaching it. Now, for most people, we're aiming for at least 70% time and range. So that's glucose levels between 3.9 to 10 millimole per litre, or between 70 to 180 milligram per deciliter if you use those units. Now, that is obviously customizable, but that is the mainstay. Time and tight target range is becoming increasingly more commonly used. So that's aiming for at least half glucose levels between 3.9 to 7.8 millimole per litre. It's also, it's great in adults. It's the same target range we use in pregnancy, but we're aiming for greater than 70% in pregnancy. Now, one thing our colleagues and our families are very used to is the glucose management indicator. So that's a calculated HbA1c off the CGM. And so for most, it may be less than 53 or 48 millimole per mole, or less than 6.5 to 7%. Now, if you take 60 days, or at least 60 days of CGM data, that marries very well to laboratory HbA1c. In fact, for my people on CGM who are using it reliably, I don't measure HbA1c anymore. Most of the time, in fact, this is particularly more true for older adults, you find all the limitations of HbA1c that you had. I mean, HbA1c is only as good as hemoglobin. And if you've got altered hemoglobin turnover for whatever reason, you will have a falsely low or high HbA1c. And that's often when the GMI is a very useful marker in that situation. But it is something which families are very used to, and it may be to start off with, they actually look at the GMI, because that will also change from week to week as well. And the third step, ask yourself, is there any time below range? Or is there any hypoglycemia? And it's thought up to 4% of time in mild hypoglycemia is satisfactory, but obviously you're aiming for no glucose levels less than 3, and definitely no symptomatic episodes of significant hypoglycemia. And that's the first 3 steps. I thought I'd show you what it looks like on some common platforms. The good news is, for almost all the sensors, they all look very similar. There's some minor nuances from brand to brand, but they're all the same. But here's Libre View. The first one that you're looking for is, what's my sensor usage? Remember, that's the first step. Here is someone that's on the Libre 1. They're not doing too bad at the time, but remember, we are aiming for greater than 70% if we can, but they're at 65%. Your second step is, are they reaching targets? And you can see that they've only got 22% time and range, and the equivalent GMI of 9.4%, or 79 millimole per mole. And your third one is, do they have any time below range or hypoglycemia? And that's 0. So all of a sudden, you don't have to go any further. You know this person needs escalation of therapy, and you can do so, without necessarily any risk of making any hypoglycemia worse. You're obviously going to go through that, but you know from this, you don't have to go necessarily any further before knowing what you have to do when you look at the subsequent pages. Here's what it looks like on Clarity. You can see sensor usage up there on the right, it's 100%. That is one benefit of real time, as you're probably all very familiar with. You do often get very good sensor usage. So that they're doing well from that point of view. They're also doing very well in terms of reaching their targets. 76% time and range, an HbA1c of 6.8%, and only mild time in mild, or very small amount of time, mild hypoglycemia. Saying that, you may still choose to de-escalate therapy in this person if you're worried about hypos, but it'll give you it lets you know to the subsequent pages, what am I thinking? What do I need to do as next steps of management? So we're going to go now to our fourth step, and this is looking at the ambulatory glucose profile, which shows the daily pattern of glucose levels. This is on the second page of the report. I've just shown you the first page. This is the second page, and I often think this contains all the information that you need. Often you don't, probably say at least 95% of the time, for example, I don't go past the second page of the report for CGM, and that's how you can make it quick. And I'll show you why in a second. But then you've looked at the ambulatory glucose profile, and then you're adjusting management as required. As a basic rule of thumb, I say fix hypoglycemia first, then you fix hyperglycemia. And then you can check the daily glucose patterns to say, are the changes I made going to be safe and effective? And that's the process. Basically, it is a process I go through for every person. So for those who aren't familiar with an AGP, this is what it looks like. You've basically got the daily pattern for that time period, starting at midnight, going through across the day to midnight. The dark line has the median glucose levels. The darker shading is between the 25th to 75th percentile, and then the lighter shading between the 95th to the 5th percentile. So you can see there, all of a sudden, you've got the glucose levels all across there the whole day. And the good thing is on the AGP, you'll also get a mini version of the daily profiles below it. And this is where you can see what's going on from day to day. And you can see what is working, what isn't working. This will be true probably for most of my people in my practice. Most are probably on too much basal insulin and not enough prandial or mealtime insulin. And there's multiple reasons for that. But you can see you've identified that overnight as the potential period of hypoglycemia. You can see that's happened on Sunday and Wednesday in particular, which may thinking about, the extra activity and what was the story then. So for this person, for example, I'll be very tempted to reduce their nighttime basal insulin and then increase their mealtime insulin across the day. But that's just showing how you can make those changes just on the first two pages without going any further. And I think it can be a really useful approach for those that do get overwhelmed. So is there any questions about that? Very quiet, very well behaved. Right. Our next case is on around adherence issues. It's all very well and good getting the sensor and wearing the sensor, but it needs to stay in. And this can be a common issue. So this is someone actually saw the week before I came here. It was a 15-year-old girl with a G7 and with a tandem pump and control IQ. So using automated insulin delivery. The major issue is that her sensors are only lasting 1 to 2 days at best. So she had only 30% sensor usage. And even when the sensors were in, she was often out of connectivity. So her time and automation was only about 25% at best. As a result, her HbA1c was around that 9%. And I think it's really important when we think about, basically, ideally, we'd have almost everybody that wants automated insulin delivery on automated insulin delivery. We don't need to be worried. For those on non-sensor augmented pump therapy, we do worry about their safety, in terms of monitoring glucose levels, carb counting, etc. We don't necessarily need to worry about that with automated insulin delivery. But the biggest safeguard with that is actually wearing the CGM. If they're not wearing the CGM and then there's no monitoring of glucose levels, there's probably no monitoring of ketone levels, that is a time when you do get a little bit more nervous. So keeping sensors in is really, really important. And particularly if people are self-funding, they're a lot of money. If it falls out, they probably only have the money to restart again in a week's time, not immediately. I will say that in a lot of countries, the suppliers are really good at replacing sensors that fall out, but I know that is not true in every country. But it is something that's worth trying. I'm to start off with. Now, for her, she tried multiple adhesive products, both underneath and over top, with limited success. And she was actually really keen to return to the G6 because for her, it was bigger, it actually adhered better, and she had better connectivity and greater time and automation. And just think about how would you approach this in your practice as well, because this is a really common clinical scenario. So we're going to go through some tips on that. These are all very common sense, but sometimes it's good to point out common sense. The first one is choosing sites that aren't going to get knocked. Now, just being aware the Libre is only approved for the outer arm and not any other site on the body. Saying that, we've done some small studies in New Zealand. We've tried the Libre on other sites such as the chest, the leg, the abdomen. It actually seems to work very well, but they're very small ends, like 20 patients on each site. I wouldn't be recommending it, but what I would say is I do have many patients that wear the Libre not on the arm, but I do say please make sure you check your blood glucose levels for each sensor to make sure that it correlates well. If so, then it's probably safe to go off that. But you are practicing off-label when you do use other sites on the arm. And if you're lucky enough to have a choice of sensors in your country, that may be one reason to say, look, I'm going to choose Dexcom instead of the Libre because I can use it on the abdomen and in the buttocks. You do go back to basics in terms of around that insertion technique, particularly dry skin. Some people do not wait for the alcohol wipe, etc., or the nasal spray, and I'll talk a bit more about that, to dry, and so the sensor doesn't stick as well. One thing I think is really useful about wearing a sensor is know how to care for it, because if you do wear tight clothing, and particularly when you dry yourself after swimming and shower, it can be a bit of an art wearing a sensor to make sure that it stays in. So it is making sure you take care with that. I do recommend checking the sensor every day, even if it's just for 3 seconds. Make sure that is all the adhesive, is it still stuck down? If anything's coming up, can you stick it down? Do you put on an adhesive at that stage? Many of my people, I get them to go to the supermarket to buy an 80 to 100 rupee bandage and put that over top, and that will often do the job for the rest of the sensor life. It doesn't necessarily have to be expensive adhesives to keep the sensor going. Use whatever works is a good take-home message. There are products, though, that you can use to make the skin more tacky or sticky, and this will vary from country to country as well, what you have available. I do find them useful in some situations. Often the supplier of the sensors may have a stock as well, and you may find that as a useful adjunct to keeping the sensors in. But it's about, often you need to try every step for those really difficult ones, but changing sites is probably one of the biggest ones. And toddlers can be a big challenge here, in terms of stopping them to rip out the sensor. And it may be, for example, that you do put that on the leg and bandage it up on the back where they can't reach it. Usually sleeping on it's absolutely fine if you're worried about that, but that's some of the things we can talk about in discussion. Yes, so, yep, go for it. Yep. Yeah, I think whichever works for them. Lots of people do different types of exercises at the gym. I've found that still often on the arm works very well. I do say the back of the arm though, because that's the site less likely to be knocked. We're lucky in New Zealand that heat isn't an issue. To be honest, we probably don't go above 30 degrees 99% of the time. Now, so sweat isn't that much of an issue, whereas I imagine in India, particularly in summer, that it is. And you may choose a site that doesn't sweat as much, particularly for those that do exercise and gym work, and that may be something that influences your decision around that. But that will be, I talk to people about trying different sites as well. But yeah, for those, I've found the arm still works very well.
Apart from the arm, what are the other sites that you would advise?
Mainly the arm and abdomen are the main ones. But I'll be honest, I don't deal with young children. So I imagine young children like the upper outer buttocks might be useful as well, or you may choose other sites. I do have some people that choose the legs. The other thing, which is probably also more apparent in India than at home, is that people get more worried about their appearance because it's showing. And that may be something which influences people, to change the site. And it may be that they choose to wear it on the chest, for example, where it's under clothing. But if it was the Libre, that is one time I would be saying, please do check your blood glucose levels. I say do that with every sensor.
Thank you.
Yeah, that's okay. Yeah, so, yeah.
I mean, Libre, I'm asking.
Oh, for abdomen for...
Abdomen.
Yeah, I find many of my people, particularly with Dexcom and Guardian, use the abdomen. That's their main site for using CGM. It works well. One thing I've always worried about with particularly the little kids is they don't have much skin real estate, so to speak. So, and they might be wearing a pump and CGM and keep moving it around. But the abdomen it works very well.
And sir, this, the skin hairs, not a very hairy child, but, I mean, the presence of hairs on the arm, is it going to like cause, the adhesion to come out or?
Yeah, it can do. It can also irritate the skin too, which I'm actually going to come to in this part. Which I might go on and talk about that.
No, I'm not asking about skin reactions because of the hair in the skin.
Yep.
I mean, is it like,
Yes,
can it cause, to come out like, the not adhesing well?
Yeah, no, I do talk about people about shaving because that will, I think that is important in terms, again, that sensor to stick well and also reduce the chance of skin reactions, which aren't uncommon. And it also hurts a lot less when you rip it off. Which little kids do worry about.
Sir, and I have one more question.
Yeah, sure, go for it.
Sir, the glycemic variability in the case 3 that you have mentioned, like how do you actually suggest? I mean, like what do you suggest? Because the 25th to 75th percentile of the variation seems to be more, that too in the middle of the night.
Yeah.
So would you suggest it could be the one thing is that like the meal and what is generally thought is that the meal and insulin mismatch is usually there, but middle of the night, what will be like nocturnal, there is so much variability is there, no?
Yeah, it is. So, I mean, a lot of that nocturnal variability comes from the evening before, but it is something, it's right. So I didn't actually put glycemic variability up here at all in terms of a metric. It is very well linked. And coming more and more data on the link between glycemic variability itself and complications of diabetes. So it is something we look at. Personally, I don't make any changes based on the glycemic variability alone, but I do look at the profiles and say, look, this is what we need to change to reduce that variability and smooth out your glycemia. So it is something I look at, but it's it's an important variability. And that's where both the ambulatory glucose profile and the daily glucose profiles below becomes useful to look at both. Because it may be that, hey, it's only 2 days a week that's causing that significant variability in that profile across the whole week, if that makes sense. And what's different on those 2 days, for example, that we need to change. And that may be, maybe that's the weekend, when they're not doing any exercise or anything like that, and that's the time they need more insulin. It's about trying to see where in your life is that variability so we can make those changes. Does that make sense? Yep. Okay, so any other questions before we move on to skin reaction? Yeah.
Have some impact on the glucose variability?
I'll come to that. I'll talk about compression lows. That is a good point. It is a big fear, but to be honest, most of the time with the adhesives, a bandage is absolutely fine. You're not going to necessarily get any variability, but if you do get too much compression, and generally that's from positioning and lying or pressing up against something, you can get compression lows. But I'll talk about that in a few slides' time. Well, we might move on to skin reactions. Here's a case, a 14-year-old Maori boy. So Maori are the indigenous people of New Zealand. He is struggling, HbA1c of 12%. Unfortunately, it's not a too uncommon story. So he started the Freestyle Libre 1 on the outer arm, and almost immediately started developing pain and itchiness underneath the center. He hated it. He wanted it off immediately. Now, this isn't the exact photo, but it was actually worse than this, but just showing you an example of a common type of reaction that you can get under a CGM sensor. So in terms of around skin reactions, so thankfully severe skin reactions are rare, but mild to moderate reactions are still really common. In fact, they're reported up to 30%, and it's often due to irritant or allergic contact dermatitis, either from the sensor itself or potentially from the adhesive over top of the sensor. In fact, the pattern you get on the skin is often really useful for determining it. Is it the sensor or is it the adhesive or potentially both? But it can cause pain, it can cause distress. In fact, people may choose not to wear CGM as a result, which is obviously what you do not want, and it is almost always preventable. And I think that's the important part, and I'll talk about that. One thing that is also really useful to know, and one reason why I hope that like newer models of CGM keeps coming out in India and all other countries, is that the rate of skin reactions is actually a lot lower. So it's the acrylates and the sensors which seem to be causing most of the issues around the dermatitis. Now, for example, Freestyle Libre dropped isobornyl acrylate, which is the major irritant after the Libre 1. So Libre 2, 3, and 3 Plus have far, far less skin reactions as a result. So if you can minimize the acrylate content, that will go well. But in terms of preventing, and often this is common sense too, but you're rotating the insertion sites and you're trying to choose sites which have no skin irritation already. If you do put a sensor on top of skin that's already irritable, that does greatly increase your chance of a site reaction. So you may need to shave, as we spoke about. The other thing is often you will switch, if you're wearing the Libre, for example, you will switch arms. So you might, left arm, one sensor, right arm, the next sensor, back and forth, not always the same site. I do recommend not putting on any lotions or oils within the preceding 12 hours. Absolutely fine everywhere else in the body, but just at that sensor site, I would be avoiding it, just because you're more likely to cause irritation. Washing hands and cleaning the area still remains important. If you're still getting issues despite that, often a barrier cream can be really effective. And then once again, there are a number of brands available depending on which country that you're in. The barrier creams often also do make the skin a bit more tacky and sticky to help with adherence themselves. So I use quite a lot of barrier cream. The other thing which I find really useful is fluticasone nasal spray. So the nasal spray used for hay fever, just at a very low dose, 1 to 2 puffs on the insertion site, let that dry for a minute and then put the sensor in. And to be honest, that probably stops at least 98% of skin reactions from happening. So you still have the 2%ers, and they're the ones that think about switching CGMs, because they may not get the same reaction with a different CGM, trialing different adhesives. You may need to think about referring to dermatology colleagues for skin or patch testing to work out what the exact irritant is. But I will have probably at least 500 people on CGM now, and I will have, I do have 2, it's out of the whole lot, who wear a non-allergent tape that they then put the sensor through the tape, and that prevents the skin reactions. But everyone else has been able to wear it without. And we have quite an atopic population in New Zealand. We've got a lot of hay fever, even asthma and dermatitis. So just to let you know, this may not be an issue in your practice, but there are tricks of the trade to avoid any skin reactions from happening. Just a couple of other areas. So we're talking about the compression lows. So this is a big fear, and I've seen basically compression lows not being recognised and then inappropriate changes in management taken, and also vice versa as well. Now, the biggest time that you worry about compression lows is if you see a rapid drop on CGM, the person's not symptomatic, and then you have the change position, you get that rapid increase back up to baseline. That is very stereotypical, classical of a compression low. If you get that slow drop overnight in glucose levels, that's not a compression low, that's probably real. and I would be reducing the insulin in that situation, but I would not be worried about changing insulin at all with a compression low. And so it is, you may think about changing the sensor site in that situation. Many people, for example, will lie on the same arm every night for sleeping. So that may come into it. But it's just being aware, please look for that sudden drop off for it to be a real compression low, because otherwise it may be real. This is a first world problem, but it is something, as more and more people use CGM, just to be aware of, because when the new models of phones and smartwatches come out, just by default, the paired apps with CGM will always lag behind those models. For example, people got excited about CGM being funded in New Zealand, so they went and bought out the latest iPhone 16, only to realise that it wasn't compatible with the CGM that we've got. So all of a sudden you've got, a new flash phone. It may not be the best. The other thing to be aware of is you also have people, if they have automatic updates on the phone, on the operating system, that may also lead to loss of compatibility. So you may actually think about, just having one phone that stays in old operating system just for using with CGM, and that's the way that does. And in fact, the different compatibility may actually be a strong influence on which CGM they choose. So our two main CGMs that we've got funded in New Zealand now, the Freestyle Libre 2 and the Dexcom ONE Plus. Now, the Dexcom ONE Plus will only go to Apple Watches. It won't go to any other watches. It will only go for a very narrow range of Android and iOS or Apple compatibility, whereas the Freestyle Libre actually gives a whole lot more options. It will go to Fitbits and Samsung Galaxy watches, for example, and Android 8 to 14 systems. So it is about checking the compatibility, and that's usually the suppliers are very good at that and pointing it in the right direction. But I think it's also really good that, even though we may not be technology experts, that diabetes teams are aware, or at least can point people in the right direction where to go to check that. And also when people just knowing that, when people, for example, have Dexcom, where actually the G6, the G7, the ONE Plus, Clarity and Follow are all different apps. It's just not just one app fits all. It's also about knowing which app goes with which sensor as well. So in terms of switching between CGM systems, I think this is going to become increasingly popular, and often that's for very good reasons. What is great is that there's now more and more interoperability between CGM and pumps. And what I mean by that is, we used to only have one sensor with one pump, and that was your system. But now, for example, our two funded pumps in New Zealand are the Ipso and Tandem, and they will both work with the Freestyle Libre 3 Plus and our Dexcom G6, G7. So it doesn't matter what sensor you're wearing, it'll work with both pumps. So we're getting closer to our dream of that people are able to choose their sensor that's best for them, their pump that works best for them, and their algorithm that works best for them for their automated insulin delivery. So we are getting there. What has been really good in New Zealand, other countries, we've had some competition for the traditional CGM. So we have people like Adix and Lynx come in and offer CGM a lot cheaper prices, which then drove down the prices of Libre and Dexcom, and hopefully that happens more. There's many free trials of CGM that you can get. It's increasing funding for that. And there's more and more data saying that ideally CGM should be started in hospital. If you have access to it, when they come in for their diagnosed with diabetes, we're starting it straight away. They know what CGM is, they know what normal is, and how to go from there. This is lucky enough if you do have the choice. I think it's great that people with diabetes choose a sensor that works best for them. And there are little nuances between the sensors. I've spoken about getting closer to our dream. And I'll just last point is I think in an ideal world is us as diabetes teams being that main source of information for people with diabetes and their families. I don't know what it's like in your country, but it was really problematic in New Zealand when people got their CGM sensors from the supplier and not from their diabetes team. For example, in continental Europe, you still need to get prescribed your CGM by your diabetes team. That's how you get your CGM. You can't buy it over the internet that way. So because putting in CGM is CGM is much more than a sensor. It's everything. It's all that information that goes with it to maximize that benefit and minimize the distress. But I hope you found that very useful. I hope it wasn't teaching you to suck eggs too much. I know many of you are very familiar with CGM, but happy to take any other questions if you have any.
Any questions?
Yeah, that's a good question. So with, I always talk to people. It all depends on what the reasoning is for that. One big one's pain, but I always say that I think inserting a sensor hurts about 10 times less than a finger prick, and most people can relate to the pain of a finger prick. And just knowing that is often enough, perhaps, to get over that first barrier. It may be that they don't want their friends to necessarily know that they've got diabetes, or other people, because it's visible on the outer arm. That's maybe when you choose a site that's not visible. Another part of it may be that they don't, phones are banned in schools, so they don't necessarily have a phone in school and cause that. We had a big campaign last month in New Zealand, for example, about making sure that all schools were aware that basically kids with diabetes need phones on them, and trying to get over that barrier and reduce that. So we had a whole lot of information go out to schools. So, teachers weren't being necessarily nasty or reacting to the kids wearing sensors and getting over that barrier. And then it's just trying to see if that hasn't worked, seeing what other issues there necessarily are in terms of helping work with the sensors, and just trying to find a solution that works. Other part of it, I talk about technology as well. It's also okay to have a holiday off technology. It may be that 80% of the time you do wear a sensor and a pump, but you may choose, you may be going on a beach holiday, or you may be, going away somewhere where you choose not to wear a sensor. Often that's the time where a sensor would be great, but it's also about just being realistic and what works for people as well. I will say that everyone's different, and just trying to work out what works best in that situation for your family.
You might have answered this, but maybe I wasn't paying attention. Sorry.
That's right.
Are there any other sites that we can put the sensor beside the back of the arm?
Yeah.
That's what do you suggest for the younger kids who doesn't like it on the arms?
Yep. So if it is the Libre, I do say that it's absolutely fine. I've had people wear CGM everywhere on the body. It seems to work well. I do say check blood glucose levels if you're not wearing it for the Libre, not wearing it on the arm, just to make sure that it does correlate well with what the CGM is showing. If it's the Dexcom, for example, they're also approved for the abdomen and the buttocks. But saying that, some people may choose to wear it on the legs. And in that situation, I do say make sure you check blood glucose levels if you're wearing it on the legs too. So, but not wearing on the arm, maybe say, look, actually, we're not going to use the Libre for you. We use the Dexcom, so you can wear it on the abdomen, so no one can see it. It will work well then. So, yeah, there are small studies basically showing that it's fine anywhere. I do get worried though if there is edema under the skin or anything else which may make the reading unreliable. It's much more of an issue in older adults than it is in children. It's just thinking about, as long as there's some skin and normal interstitial tissue there, it should be fine.
I have a problem whether you can solve it for me.
Yep.
So it's a young child with mild autism who doesn't like the thing sticking on hips. Any other way you think we could help? Do you have any adult patients with autism who?
Oh no, I was going to say, my young adults with autism generally do very well with diabetes. They're so structured in their routine that they actually find CGM really useful and build that into their routine really well. Often getting it in the first time, I will say, is the hardest part. Most people have found that once they've had their first 2 sensors in, they're absolutely fine. It's just getting over that first step. If it really is the pain of insertion, it's a big one, then do think about distraction or ice or other things to help around insertion. But there will still be some people that won't wear it. And in the younger kids, it can be easy that you put it in and just really wrap it up so they can't take it out. And that can be, one strategy of getting around it, and they realize it's not so bad. But you probably will still have, a few patients that won't wear it no matter what you try. I've got no magic wand for them, unfortunately. But I'd just suggest just keep on trying. They are useful. That's when I use my clinical psychologist a lot, to try and actually get down to what the actual issue is and to help build strategies around that. As we often don't have necessarily the time in our clinic appointments to do so, but the psychologist, if you're lucky enough to have one, may have that time to work with the family. That's fine. Yep.
CGM placement on abdomen in an obese person, does it work well?
Yeah, it seems to work absolutely fine. I anecdotally haven't found any issues at all.
No dislodgement.
No, I guess if you have really morbid obesity, it may be an issue, but in most people, it's been absolutely fine, with no issues whatsoever. I guess if they sweat a lot, that may become an issue there, and you may choose the arm then. But it's about, basically CGM seems to work well in most places where you put it. It's just about finding a site that works best for your person with diabetes.
So are you putting CGM to every age group?
Yes, so now we have funding, and because the biggest issue before was people couldn't afford it, and it was a real difference between those that had money and those that didn't have money. So now that it's funded, we're trying to put on everyone.
Neonatal diabetes as well.
Oh, so we're only funded for type 1 diabetes, and pancreatic diabetes. We're funded for that too. But basically, in that group, we're trying to get everyone to use CGM. We've still got no funding for type 2 diabetes. There are some groups that will still clearly benefit with type 2 diabetes. I'll talk more about that tomorrow. But I mean, I think ideally that everyone would have CGM. That would be the dream. Anyone that wants it would have CGM. And it's such a powerful tool that we can use, improving glycemia.
Any experience of using CGM in hyperinsulinism, congenital hyperinsulinism children?
Short answer would be no. Not congenital hyperinsulinemia. I use it a lot in people with type 2 diabetes. I've got a few with insulin resistance, but not necessarily like monogenic insulin resistance, but not necessarily congenital, not from birth. Yep.
The adhesive of the CGM, and on the top of it, if we apply a bandage, there is some, color change or like the darkening that happens when we remove it.
Right.
And that doesn't go away for a long time, like 6 months or so. It still remains that circle, that darkening kind of, maybe dirt or whatever, but it doesn't leave also.
Yeah, I must admit, I haven't had that issue myself. It is one thing, if you thought it was a skin reaction.
No, it's not a skin reaction, sir. I think most of us must have faced.
Like a circular mark.
It's a circle mark, probably a dirt or like whatever, but it doesn't go also, even after washing with antiseptic.
Doesn't go.
Yeah.
Probably most likely the sticky tape, because it's just like around just the exact shape of your sensor.
Have you faced any
area? Yeah, so I've got no easy answer for that. Unfortunately, I don't know whether we have different sensors, and that's why we don't have that issue.
Or probably it's our skin.
It might well be the skin, yeah.
Reacts to it.
I don't know whether trying those strategies to reduce skin reactions makes any change at all to the skin color. I think if people are getting really distressed about this change in skin color, you could try some of those things I spoke about to see whether that makes a difference. If it didn't make a difference, I wouldn't bother continuing with it. But yeah, just give it a go.
Thank you.
Yep. Sorry.
Actually, I would like to ask if there's a presence of public funding among the young diabetes type 1 in children. Would you foresee there's a reduction of blood glucose checking because maybe some parents would be using that reading to come to a decision for treatment? Would you foresee?
Yeah, it makes, I can't underestimate how powerful CGM can be in terms of improving management. Up until now, this is an example, up until now in New Zealand, we had separate government funding for children with diabetes. So we had about 99% of our children with type 1 diabetes were using CGM, but there was no funding for adults. So unfortunately, as soon as they turned 16, our use of CGM went from about 98% down to about 20%. And I know it's not the best time of life because that's often the hardest time in terms of glycemia, but there's just a massive increase in glucose levels as a result. If you look at the studies which show that they've put, doesn't matter which age group you use actually, but including children, if you start children on CGM, you see the reduction in glucose levels. If you take CGM away, you see the glucose levels go back up. It's just, yeah, it is. I mean, I'll be campaigning for funding for everyone. We had, I'll show some data tomorrow which helped convince our funding body to actually fund CGM in New Zealand because we've literally been fighting for at least the last 10 years to do so. And a lot was because we showed that all of those people who had high glucose, a lot was based on socioeconomic deprivation and on ethnicity. And if we gave them CGM, it took away all inequities. Basically, it brought all those top groups down to where everyone that could afford CGM was. And that's why I wish everyone could have access to CGM. Because it doesn't matter, what ethnicity, what income, you can still get people doing a lot better than what they're doing at the moment.
Thank you very, very much it was an excellent talk, and I think we had quite a good discussion. Thank you very much, Professor.
Thank you, sir. Thank you, ma'am, for chairing the session. May I request Dr. Divya Lakshmi to please felicitate the chairperson. Ma'am, please come. Thank you. Sir, please come for the photo, group photo. Yeah. Ma'am, group photo. Yeah, he just.
Thank you. Very good.
That's okay. I'm not having you up on the slides. That's absolutely fine. So I pitched it the right level. Didn't know there were 2 days that were 70.
Just spot on that we do every day.
Yeah.
It's fine. I did ask a question. How about patients try to long
Yes.
How long would you? They say 14 days and then like, but it's still working. It's still working. They prolong it. They do another app and then they do it for another 14 days.
I didn't talk about it all about those.
Yeah. But there's like off license.
And then you don't consider the accuracy.
Exactly, that's the trouble.
And
in mind that no one will actually give you that 7 times volume when it comes to once a week injection. Yeah, it's still a small needle, which is suitable for the use of a pen device. So for that matter, I'm going to call upon Prof. Vaman to talk to us on somapasitan in children with growth hormone deficiency insights from REAL 3 and REAL 4. Vaman.
Thank you, Professor Jalaluddin. Good evening, everyone. And I'm here to tell you about the REAL 3 and REAL 4 somapasitan clinical trials. Now, these are my disclosures. So I work at Jahangir Hospital and I have been involved with the research trials as principal investigator for Novo Nordisk, Pfizer, Sun Pharma, Eli Lilly and company. And I have received honorarium from Novo Nordisk, Pfizer and Sun Pharma over last few years. So coming to long-acting growth hormone, and many of us in India have started using some long-acting growth hormone in the recent times. But there are mainly 4 types of methods to prolong life of growth hormone in the human body. So you can either have pegylation, you can have depot, you can have fusion molecules, and you can have albumin binding. And the one that we are going to talk about today is the albumin bound molecule. Now, this is the structure of the somapasitan molecule. And this is a time-tested method that Novo Nordisk has been using to prolong the life of their other molecules such as insulin. And I won't go into great details of this because Professor Bradley Miller will cover some of it in his lecture. But primarily what you're looking at is that there is an amino acid substitution which is not in the GH receptor binding domain. And then you have got a hydrophilic spacer and an albumin binding moiety. That's the structure of somapasitan molecule. I would now be telling you about phase 3 and phase 4 clinical trials. Now, those which are shown here in light blue color are the ones which are already completed, and those in dark blue color are the ones which are ongoing. So REAL 3 is concluded. REAL 4, 5 and 8 are the trials in which I am involved at Jahangir Hospital in Pune. And REAL 6 is not there in India. It was meant for China. Now, REAL 3 trial is a phase 2 trial. And the design of this study was, it was a multinational randomized open label dose finding trial. So this was a dose finding trial, and there was a 26 weeks main period and 26 weeks extension, and then a 6-year safety extension. Now this was done on children, boys and girls, pre-pubertal, growth hormone deficient children without any prior exposure to growth hormone therapy or IGF treatment, who had a height standard deviation score below -2 SD for the local standards. And the objective was this study was to find out what is the optimal dose of depot growth hormone. And they, on one arm, they received daily growth hormone, and on the other, there were 3 dosages of somapasitan: 0.04, 0.08, and 0.16 milligram per kilogram per week. Now, this is the design of the trial, where, as I said, that at the onset, you have got one arm which is daily injections, and then you have 3 dose determining arms. So 0.04, 0.08, and 0.16. That's a 26 weeks main phase and 26 week extension phase. And then all those who were on varying dosages in the subsequent extension have gone on to a single dose, which is 0.16 milligram per kilogram per week of somapacitan, and continued to have the same dose of daily growth hormone, which was 0.034 milligram per kg per day. And in the long-term safety extension, they were all on 0.16 milligram per kilo of somapacitan. Now, sustained efficacy and safety were demonstrated for somapacitan up to 4 years of treatment. And what you see here on your left-hand side in the graph is the height velocity at 52 weeks in 3 differing dosages of somapacitan, versus the last column that you see is the daily dose of growth hormone. And as you can see, the response is dose dependent, with the maximum response being at 0.16 milligram per kilogram. So at 52 weeks, significantly greater height velocity was seen with somapacitan at 0.16 milligram per kilogram per week. Average IGF-1 for somapacitan at 0.16 milligram per kg per week matched the daily growth hormone injection arm. And following 4 years of treatment, efficacy was maintained. Now, this is the sustained efficacy and safety that was demonstrated for somapacitan up to 4 years of treatment. And as you can see here, after 1 year of therapy, the distribution of adverse event for somapacitan was comparable to that of daily growth hormone. It was well tolerated at all 3 dosages, and no new safety concerns, signs, signals, or tolerability issues were identified at 4 years, including in patients who switched from daily growth hormone to weekly growth hormone. And no neutralizing anti-human growth hormone antibodies or anti-somapacitan antibodies were detected. So that was REAL 3 trial. Now moving on to REAL 4 trial. Now this is a phase 3 trial, and the design of the trial was, it's again a multinational randomized active control open label double blind 52 weeks trial plus 3 years safety extension. The participants were again boys and girls prepubertal with growth hormone deficiency, no prior exposure to growth hormone treatment or IGF-1 treatment, with a height Z score below -2 STS. And the objective here was not dose finding, but to look at efficacy and safety of somapacitan. And again, there were 2 arms, somapacitan and daily growth hormone. And this was the design of the trial. As you can see, 200 prepubertal children. There were 2 arms, daily 0.34 milligram per kilogram per day versus somapacitan 0.16 milligram per kilogram per day. That was the main trial for 52 weeks, followed by only somapacitan 0.16 milligram per kg per week for up to 3 years. Now, if you look at the baseline characteristic of the patients enrolled, somapacitan obviously had the larger number of 132, and daily growth hormone was 68. There were 75% boys in both groups. That's the distribution of different ethnic groups. Mean age was 6.4 years in both groups. Height was comparable. But height standard deviation score in the daily growth hormone group was lower than that in the somapacitan. IGF-1 was comparable, and the peak GH was also comparable. Now, this slide shows you that somapacitan shows non-inferiority as compared to daily growth hormone. And on the left side, what you see is the annualized height velocity in centimeter per year. So it's comparable to daily growth hormone, and there was no statistical difference. And similarly, if you look on your right-hand side, you see that at 0, 13, 26, 39, and 52 weeks, there is very marginal difference between the 2 treatment arms. They're comparable. Now, secondary height endpoints supported the same results as earlier from the primary endpoint. And here on your left-hand side, what you see is height velocity standard deviation score change from the baseline. And on the right side, it is the height SDS change from the baseline. And again, non-inferiority of somapacitan can be appreciated. This slide speaks of the IGF-1 data, and I probably won't go into the details of this because Professor Miller is going to cover this in his talk. But what it shows here is, once again, there is non-inferiority or the comparable. The rise in IGF hasn't gone beyond +2 ST, and both treatment modalities are comparable. Somapacitan efficacy was maintained at 3 years. So for those who were on somapacitan, those who were on daily, and those who switched, if you look at their data at week 0, 52, 104, and 156 weeks, they are very comparable. So similar height velocity between group was observed during 3-year treatment period. Now looking at the safety data now. So if you looked at adverse events at 52 weeks, both groups, both arms had very similar SAEs, and they resolved most of them, and they were considered to be unlikely related to the trial products. Adverse event, again, if you see, the events are separated out here as headache, nasopharyngitis, pyrexia, pain in the extremity, bronchitis, and vomiting. And in both groups, they are similar, and there's no difference. Antibodies. Whenever you have a new product, especially related to a protein molecule, you're very interested in knowing the antibody data. And here, as you can see, somapacitan was very comparable to daily GH. If you look at visit 4 and visit 7, which is week 13 and week 52, in the somapacitan column, there were 2 cross-reacting antibodies at 13 weeks and 4 at week 52, and there were none in daily growth hormone arm. And patients who had 2 consecutive positive antibodies were 2. So out of those 4 at 52 weeks, 2 of them were positive, as you saw at 13 weeks as well. Injection site reactions. So at week 52, the data shows that in both the groups, the injection site reactions, which consist of mild bruising, site pain, injection site hematoma, hypersensitivity, and swelling, were comparable in both groups. Somapacitan thus was well tolerated in children with growth hormone deficiency at year 3. So during year 3, a low proportion of the participant reported injection site reactions. No neutralizing antibodies were detected, and I think that's very important. There were no clinically relevant findings related to glucose metabolism, that is change in fasting sugar or HbA1c, and mean IGF-1 SDS values, about which you will hear more in Professor Miller's talk, were within normal range. Now, observer reported outcomes. So what was reported by the caretaker as well as by the observer has been shown here. And to simplify this, the first 4 deep blue boxes and whiskers, you can say, are the observer reported, and the one at the bottom are the parent reported outcomes. And in both cases, you can see that it favors somapacitan. It favors somapacitan, whether it is reported by the parent or by the observer. So patient preference questionnaire showed that at 56 weeks, caregiver for subjects switching from daily to weekly said that 90% of those would prefer to have a weekly growth hormone injection. So to summarize from phase real 3 and real 4 trials, which I just showed you, long-acting growth hormone preparations include molecular changes to the weight and ionic changes, as well as the binding to other molecules. Primary and secondary endpoints show similar efficacy between somapacitan and daily growth hormone in real trials 3 and 4, which I showed you. Patient-related outcome shows a reduced treatment burden and somapacitan compared to daily growth hormone. Somapacitan was preferred by parents and caregivers when a child switched from daily to weekly growth hormone. An overall safety profile of somapacitan was similar to the well-known safety profile of GH and was considered to be non-inferior. So with that summary, I would like to end my talk and would hand it over to the chairperson.
Thank you, Prof. Warman. That's very interesting, very clear presentation and introduction on the weekly growth hormone. And so I would like to remind all of you, if you do have questions, as you wish, you can also go to the microphone later after our second talk, or we also have Slido if you don't like to go to the phone to speak. I would like to move on to our second presenter, Professor Bradley Miller, who's going to talk to us on the optimizing the somapacitan, basically looking more on the IGF-1 response. Prof. Miller.
Thank you. Well, I'd like to thank the organizers for inviting me and Novo Nordisk for making this possible. So I'll be talking about optimizing somapacitan for pediatric growth hormone deficiency, focusing on the IGF-1 response, dosing, and monitoring. These are my disclosures, and as Professor Yazid and Professor Vaman said, I was an investigator in REAL 3, or I'm sorry, in REAL 4, and was the lead author of the publication, but also was an investigator in clinical trials for other long-acting growth hormone products. Vaman talked a little bit about the somapacitan structure, how it's been modified to have a long fatty acid chain that will bind to albumin to make it be able to last in the body longer, to allow for a once-weekly administration. And this is the same method of protraction that has been used in other molecules, including the insulins, as was mentioned. This is a cartoon showing the somapacitan mechanism of action. So essentially, it's a reversible binding of somapacitan with albumin. And then it's an interaction of somapacitan with the growth hormone receptor to activate the intracellular signaling. And that may happen with the albumin attached or without the albumin attached. And then we have the intracellular IGF-1 signaling, and we'll talk a little bit about how the profile of that IGF-1 changes in the daily versus the once-weekly somapacitan. The other important thing that I wanted to show was some of the data showing that somapacitan will actually bind at the local level and can get into the target tissue. And so what we can see in the upper left of, or upper right of the slide is looking at areas where somapacitan in red is present at the growth plate in the bottom part, right where you want it to do its job. And so it's a key that the somapacitan is actually getting to where it needs to go. And then in the bottom panel, you can see actually activation through phosphorylation analysis to show that the somapacitan was actually activating downstream signaling of the growth hormone receptor to get to that target. So there are some unique characteristics or concerns that arise when we think about a long-acting growth hormone. So anytime we change a molecule, we want to think about the immunogenicity. And Professor Vaman talked about the lack of neutralizing antibodies. We want to think about the ability of the molecule to get to the target tissue, and whether some of the molecules, because they're larger, might have difficulty getting into the tissue and activating the signaling that we're looking for. Are there fusion protein specific effects? Could there be a larger injection volume because of the molecule being larger and not being able to be concentrated? The next is the lack of experience of providers with the new therapy. And then I'm going to focus today on the lack of knowledge of dose adjustments necessary for individualization of therapy. In the clinical trial, there was very specific guidance on how we adjust the dose of growth hormone in children receiving the medication. But as we start to use the medication, we have to decide for our patients, what's that going to look like? And the key thing that I'll focus on today is how do we interpret the IGF-1 values? So I want to highlight that this is, already an art in terms of how we use the IGF-1 to guide our practice with daily growth hormone. But interestingly, because of the pharmacokinetics, IGF-1 monitoring and long-acting growth hormone is actually going to require specific knowledge of timing of the injection, timing of the dosing, and some information about what is the pharmacokinetics and pharmacodynamic profile. So big questions come up is when, after a long-acting growth hormone injection, should we actually draw those samples? What time point is best to represent a peak or an average IGF-1 response, or to guide our dose adjustment? And what do we do if a patient doesn't show up when they're supposed to? And that's the key for me, because my clinic is on Thursday or Tuesday. If the patient takes their medicine on Sunday, then it's not always going to line up with a day 4 draw or a day 5 draw or whatever day we would like it to be. So to develop the models to try and help us understand this, there was clinical data from phase 1, the phase 2 REAL 3 trial, and the phase 3 REAL 4 trial that was taken together from 210 children with growth hormone deficiency. And then a PK/PD analysis was made to develop a support for clinical guidance on dosing and monitoring using this model. So these are the same clinical trials that Professor Vaman talked about, with REAL 3 being the phase 2 clinical trial, REAL 4 being the phase 3 clinical trial in children with growth hormone deficiency. And to just highlight that in this phase 2 REAL 3 trial, it was a dose finding study, as the professor mentioned, where there were 3 different doses of the once weekly somapacitan compared to a daily dose of growth hormone. And I wanted to focus here on the IGF-1 levels. And these are average IGF-1 levels that were estimated using the model that we're describing. And so we can see on the left that the somapacitan trough, those are the actual values measured. And we can see the dose response of the 3 different doses. At the peak, we see a much more consistent dose response from the 0.04, 0.08 to 0.16. And then using the model to derive an average, we can see the same sort of dose increment. In the far right panel, you can see the daily growth hormone values, which are staying steady. And in the 0.16 milligram per kilogram per week, you can see that you're achieving IGF-1s near the mean and similar to what the daily values are. So now switching gears to the REAL 4 clinical trial. This is the phase 3 pivotal trial for registration. And in this trial, as Vaman said, Professor Vaman said 200 prepubertal children randomized 2-to-1 to receive somapacitan 0.16 milligram per kilogram per week or daily nortotropin. And one of the key things that I want to focus on here are the endpoints, which the professor mentioned the height velocity endpoint as the primary endpoint, but I'll focus on the IGF-1 standard deviation score values. So here on the left panel, we can see the baseline values before they start growth hormone therapy of any sort. On the left, we see minus 2.03 in the children who receive somapacitan and minus 2.33 in the children receiving daily. And then at the end of the 52 weeks, we have the 0.28 for the once weekly somapacitan and the 0.1 for daily. And in the right panel, we can see that because at different clinical trial visits, we either obtained a peak or a trough value or a day 4 to 6 value. And so we can see at different times the peaks and valleys. You see with daily growth hormone that you quickly rise to a level and then you slowly go up over the course of the year. And then with the once weekly somapacitan, because we're measuring a peak value at that first measurement, you can see you get up to levels pretty quickly, and then you hover around that value. And it's those numbers that were actually used to derive the model that helps us estimate the average. And the estimated average is going to ultimately be that day 4 to 6 blood draw that we'll talk about a little bit more. So as was mentioned by Professor Vaman, the clinical trial, REAL4 phase 3 clinical trial showed non-inferiority of somapacitan versus daily norditropin for the primary endpoint of height velocity at week 52. That was confirmed. The IGF-1 standard deviation levels were similar between the weekly somapacitan and the daily norditropin treatment groups at week 52, and the means were within the normal range of -2 to +2 standard deviation scores. And so I think it's very important that we're looking at replacement dosing, and we saw that the majority of those values were in the normal range. And the overall safety profile of somapacitan was similar to the well-known safety profile of daily growth hormone. So now I want to focus on this diagram to talk about that pharmacodynamic model. On the left-hand panel, you have a cartoon depicting how IGF-1 varies very minimally as you proceed through the week with daily growth hormone. And that's what we're used to. We can draw a level anytime somebody comes to the clinic, as long as they're taking their medicine consistently, it'll be a good estimate of their average IGF-1. Usually after about a month of therapy, we can start to see that they've achieved a reasonable average. But with weekly somapacitan, you're always going to have this peak and valley. And so number one there shows the maximum IGF-1 levels that occur around day 2. Number 2 at day 4 shows the weekly average IGF-1 levels. And then day 7 is the trough. And interestingly, they showed very similar weekly IGF-1 average standard deviation scores, as I mentioned, despite that very different profile of that IGF-1 pharmacodynamic profile. So using the models, we derived I'm not a statistician or a pharmacodynamic modeler. The team derived the values for calculation tables to predict the average IGF-1, depending upon the day that it was obtained. And so essentially, if you have a patient come in and they've took their dose on a Monday and they're in your office on a Friday, that's day 4, you're exactly at the average and you don't need to adjust anything. But if they draw it on day 2 or day 5 or day 6, then you have a calculator where you can add or subtract from the standard deviation score value to get the value that you need to use as your estimated average IGF-1. It's also, if you're not, if you don't have standard deviations available, there's also a ratio available for concentration values. And because this is just looking at the pharmacodynamic model, it should work for any assay because it's describing the change over time in the IGF-1. So it doesn't matter what your assay is, it's going to have the same sort of profile. And I think that's a key question. And this just depicts on the right the fact that we're using that mean value in the middle to try and subtract or add depending upon what time of the profile you're at to get to that average IGF-1 value for using that chart. So I wanted to throw in a case presentation. This is a patient of mine who's a 12-and-a-half-year-old female who was diagnosed at age 2 with growth hormone deficiency due to an ectopic posterior pituitary gland and stalk interruption. She's currently Tanner 5 and is on estrogen replacement therapy. And when she was on daily growth hormone at a dose of 0.3 milligrams per kilogram per week, she was missing about a dose per week. So we offered the once weekly growth hormone to them. And as she made the switch, her daily growth hormone IGF-1 was 314 nanograms per deciliter or minus 0.4 SDS in our assay. However, when she started once weekly growth hormone, her IGF-1 was 336 nanograms per deciliter. She was slightly older, so it had moved a little bit in terms of the SD score. But it was 40 hours after the injection, it was minus 0.5 SDS. So if we just looked at the IGF-1 that day, we'd have said, it's actually not in a bad range, it's probably okay. But she actually had the lab drawn close to the peak. And so essentially this was overestimating her value. So when we take her estimated average IGF-1, we have a minus 0.5, but because she's at the peak, we have to subtract minus 0.8 SDS. Her average is actually minus 1.3, showing that she's currently being underdosed. So due to her low IGF-1 and her pubertal status on estrogen supplementation, the somapacitan dose was increased to 0.19 milligram per kilogram per week. And then her repeated IGF-1 using that dose was essentially right at the mean. And we've seen this in adults receiving estrogen replacement therapy with daily and once weekly growth hormone, that you need a higher dose to get the same IGF-1 effect. So the last part of the talk, I'd like to just talk about the flexibility of the dosing. So because the half-life of the growth hormone molecule and the half-life of the IGF-1 profile actually differ, there are different impacts on how taking a medication early or late will impact the profile. And so on the left-hand panel, we can see if we administer the dose 2 days before the regular dosing level, we actually have a slightly higher peak and a lower trough. And then we get actually back to steady state rather quickly. The same administration 3 days after the regular dose, you have a deeper trough and a slightly lower peak. But when you give that second dose, then you have a bigger peak after it. And it's actually not as big a shift as we would have thought because of the half-life difference of the daily growth hormone. So it's actually been labeled as saying that you can give the dose early or give the dose late and still be within a safe range. It's not recommended as a regular practice. You know, we want everybody to be consistent, but that if the dose is missed, that there's actually a window where we can still safely give that dose. Or if we're trying to switch, we're on a Monday consistently, we now want to do it on a Thursday. There are similar ways to adjust our dose without having a significant excursion of the IGF-1 values. So the last part that I want to talk about is our need for long-term safety and efficacy data. There's still some questions we have about daily growth hormone that we would like to continue to analyze in the long-acting growth hormone era. We also want to know, is adherence better on the treatment? Are our height outcomes better because adherence is better? Is there some other reason that we get better outcomes with once weekly compared to once daily? And so I was the Pediatric Endocrine Society representative on the consortium developing GlobeReg, and Professor Yazid was the APAS representative as well. And so this was a group that was coming together to have a investigator-initiated registry for children on growth hormone therapy. It's been live now for about 2 years. So you can be an investigator in this. You just have to reach out. Currently, we're gathering data on children on daily growth hormone, as well as some children on long-acting growth hormone therapy. There are different working groups that are developing different areas. So the adult growth hormone deficiency is ready to be launched, the Noonan syndrome as well, and very soon Prader-Willi syndrome is going to be launched. And then there are specific scientific studies, which I'll mention the somapacitan study here. So somapacitan registry was actually built to be part of this GlobeReg, where children that are receiving somapacitan in the countries where it's been approved are gathering data specifically for a 3-year recruitment and a 7-year follow-up for long-term safety in children with growth hormone deficiency, as well as to try and look at some of the other safety and clinical parameters that are available during clinical practice, because our real world practice is always different than what we see in the daily, in the clinical trials. So I'd like to summarize by saying the ideal day to measure an IGF-1 is on day 4 to get that average value. However, an average IGF-1 can be measured from a blood sample taken at any time during the somapacitan dose using the published model. Due to the pharmacokinetics of somapacitan, there's actually flexibility in the timing of administration. We want it to be consistent weekly, but if there is a need to shift it for a sport outing or a vacation, there are those opportunities. I think it's going to be really important to collect long-term safety and efficacy data for somapacitan, and GlobeReg is an independent registry intended to capture that data both for safety, efficacy, and in the future, patient-reported outcomes for children receiving both daily and long-acting growth hormone. And there is a specific somapacitan module available in GlobeReg for that purpose. So again, thank you for your attention, and I look forward to questions at the very end of the process.
Thank you, Prof. Miller. So I'm opening the floor for any questions. Yep, please.
Very nice presentation by all the three. So my first question is to Professor Miller. There are a lot of troughs with when you use long acting. In the past we had one long acting, which was provided by I think this company in Korea. So we have a lot of troughs we used to see with the patients in this IGF-1 troughs and all that. So what do you think there'll be any problem in the future with this such troughs occurring, so much of troughs as compared to the daily growth hormone?
So, thank you. So I do think that with the long-acting, that the average IGF-1 is going to be the best predictor of both efficacy and safety with the IGF-1. So I don't think we're going to have there is some excursion, but it's not going into ranges that I think that we're going to be worried about. I think gathering the data in the GlobeReg or other registries that will do that is going to be really important to answer your question of, because we're having this less physiologic profile of IGF-1, are we seeing new side effects that we didn't see with daily? We know daily is not physiologic to begin with, but we know the weekly is even less so. And so I think it's gathering that data long-term is going to be key to answering your question. But in my experience and in the clinical trials so far, that change hasn't had a negative effect.
Okay, second question is that, this is for GHD, right? So there are so many causes of GHD. You have GHD, isolated growth hormone deficiency, you have multiplicity growth hormone deficiency, you have GHD, postcranial pharyngioma operated. Are we going to use all these patients with GHD, or is it only for isolated growth hormone deficiency?
So it is approved for any child with growth hormone deficiency, and so any of the ones that you mentioned would be candidates for that therapy. There in the guidelines, there's been some questions as to whether cancer survivors of any type should be treated with more caution. And I think we already treat them with more caution with daily growth hormone. So I think I would love to have studies to show that safety in those populations. I actually treat a number of cancer survivors in my practice and have started to treat a small number of them who are very far out from their cancers, but have very severe growth hormone deficiency with once-weekly therapy.
No, why I ask this question? Because the Growth Hormone Research Society has changed the guidelines on the starting of growth hormone in patients of craniopharyngioma.
Yes.
So they say wait 6 months, before it was 2 years, 1 year, now 9 months. So I think we should be very cautious in using the long-acting growth hormone in these patients of craniopharyngioma, which we know recurrence can occur.
So I think we need the data to answer that question, and I think Professor Mueller gave an excellent lecture yesterday about craniopharyngioma, and there's a lot of questions as to whether growth hormone therapy, replacement therapy, not pharmacologic therapy, has any negative impact on the tumors. And I think caution is 100% appropriate, but I think there's still a question there. I work in our cancer oncology clinic every Tuesday afternoon with the oncologists, and we talk a lot about when and if we should be treating children with growth hormone for each diagnosis, including craniopharyngioma.
So what about patient PWS?
So Prader-Willi syndrome, children have growth hormone deficiency with Prader-Willi syndrome, could be candidates. I think, I don't know if there will be registration trials specifically for Prader-Willi from any of the companies. I don't know if that's a plan. I have offered it to some of my patients with Prader-Willi syndrome, but I haven't yet started in any of them. And I would love something like GlobeReg to capture the data for physicians who are treating children with Prader-Willi. They are growth hormone deficient, so I think that's if they're growth hormone deficient, they would be appropriate for that category.
Thank you.
You're welcome.
All right, that's very good questions that we have. Yes, please, before I move on to the slide though. Yeah.
Thank you, Mohammed. So you just showed that in real poor study, I mean, in long-acting growth hormone, there is a severe side effect in 3% of the cases, while in daily it is just 1.5% of the cases. So what are those serious side effects? Because that has to be eliminated. And this is possibly because, you know, number of cases in that cohort was much more than 132. And if we look at the daily, there was just, I think, 56 or that much.
Yeah, I think they all come under the category of serious adverse events, but none of them are life-threatening. We had shown a split of that as well, and if you notice, there were that was the essays. Yes.
I thought serious means
No,
severe means-
none of them had to be admitted or went into ICUs or anything, and no life-threatening events.
Thank you, sir.
I have just question about the cartoon. Growth hormone binding with albumin and then induction the intracellular elements to produce IGF-1. Then how the action is prolonged? If it binds with the albumin or if it doesn't bind, the same thing will be produced. Binding would this allow it to engage with the induction element so that the action will be pronounced.
So it's an excellent question. And so the ability of the growth hormone to bind to the albumin is what prolongs its half-life so that it stays around longer. The affinity for the albumin is quite high, but it can leave the albumin molecule and go to the growth hormone receptor. If it does that, it's likely internalized and pulled out of the system. So just like any growth hormone from daily, if it sits on the receptor, it gets pulled in and destroyed. So it's only the ones that are, you know, would normally be cleared by the kidney and by other things that are being prolonged by the albumin binding so that it can stay around and have its chance to get to the receptor. So that's the mechanism that is working to prolong it.
What is being shown that it binds with the albumin and then the bound form is then bound with the induction element.
So there's actually been shown both that that the albumin growth hormone somapacitan combination can bind to the receptor, but it doesn't have to be attached. So if it's in a smaller tissue where albumin is being excluded, the growth hormone somapacitan molecule, just like I showed on the receptors at the growth plate, they're getting to the growth plate. They're leaving albumin behind because albumin is too big to leave the blood and go to the growth plate. So we know it has to leave the molecule to get to those target tissues.
Thank
you. Yeah, very important question. Thank you. And to answer the other question from the audience, I think whenever a child is in ICU, we recommend discontinuing or pausing on the growth hormone therapy. So just to emphasize that.
There are a few questions here on slide though. I'm just gonna take a few of them. Okay, thank you for the talk. Are there any medications that would affect the IGF-1 readings if given concordantly? Do we know?
So the amount of binding to the albumin, it doesn't appear that there's any interaction with other albumin binding medications affecting the IGF-1 or growth hormone levels.
Okay. Then this question for Dr. Verman. And injection site pain is difficult to manage. Pragmatically, how do you mitigate?
Right. Amongst the patients that we have enrolled in our center, injection site pain was a little more common in the somapacitan group, but I don't think we ever had to use any local medications or painkillers for that. It subsides on its own. So although it's reported to be more severe than the daily, I don't think it's a management issue really.
I would agree. In my experience, the same.
The other question on the how long after adjusting, increasing or reducing the long-acting to assess back the IGF-1 level in case the clinician is concerned?
So typically I do it a month later, but based upon the pharmacokinetics, I think it can be a week or two because the steady state is actually achieved quite quickly.
All right, I have two more questions here. So when are we going to have this molecule in India? I think the little bird has whispered to me that you're going to get it by the end of the year. So much earlier than in Malaysia. So
The end of which year?
2024, end of this year, not next year. Okay. So yes, it's going to come very soon. I think thanks to Prof. Varman and some of you who actually does the study in India, I think that's really helpful because currently in Malaysia, we are running the Real 8 and Real 9 for the non-growth hormone deficient patients. Yeah. All right, there's one question that just come in. Do we still ask the child to inject long-acting growth hormone at night, or could it be injected in daytime?
I don't think it's going to matter because it has got a prolonged action. But I would still say that if they maintain consistency in the timing, whichever is suitable to them, it's probably not advisable to take it once in the evening. But yes, it could be given at any time of the day. Sorry?
Sorry, what's he saying? Can you use that?
So the window period is 3 days.
Yeah.
So
Yes.
whether you give in the morning, the evening, extra will not
Yeah.
make a difference. So why should we talk that morning and evening stuff?
Agreed.
It's 3-day window period. Yeah.
I just like to know when they did it to help me estimate the IGF-1. So if they did it in the morning or they did it at night, it's just helpful to know that answer. I don't care which, just that I know.
Sorry, I got the wrong info. So the little bird gave me wrong info. It's for the other things that's going to come to India by the end of year 2024, but not somapacitan. But I believe it's going to come very soon because it's already there.
I think the bird doesn't know when it's going to come.
Yep, you got me. All right, there's one question here which is I think quite I'm not sure it is very sensitive or not, but the cost, whether is there a lot of difference between daily and weekly, and I think the medical people here may not know about it. Yeah, when the time comes, then we got to know about it. Yeah. All right, so we have all the questions. I'm just going to open one more time. Yes, please.
I have a question for you, actually. And the question is, have you had any patients on whom you had to reduce the dose because the IGF-1 was going too high?
I have. And so that definitely has happened. And it's been particularly in younger children with more severe growth hormone deficiency. And so my colleagues have said that some of their children, as they enter puberty, have actually needed to reduce their doses as well. Counterintuitive to what we have done in the past or thought in the past that you actually need more growth hormone during puberty. They've actually seen dose reductions. I haven't had, I gave the example of the one young woman who's on estrogen therapy that we had to increase the dose, but I haven't had many pubertal children, but yes, have had to
So
decrease
does
it.
it growth hormone stimulation test, the results are good on if the child is, GH is as 2 or whether it's 5 or 6 or 7, just cut off of 7. So does it make a difference in the response with your molecule?
So we actually have a paper coming out that is answering that question very soon from the clinical trial data, and we used thresholds of 3 and less, 3 to 7, and 7 and above, because this trial did include people internationally, some that were between 7 and 10. We could see a difference between the children who were 3 and below from the other two groups. We couldn't tell the difference between 3 and 7 or 7 and 10. So definitely the 3 and below, difference in growth response compared to the people 3 and above.
It's like daily growth hormone, almost similar to daily growth hormone.
Agree. I don't think it's a difference compared to daily. I agree.
All right, that's one question here. I'm really I mean, it's for me. Okay, tomorrow that we will have a transition talk, and there's nothing about growth hormone treatment. So, do you think there's any need for us to use the long-acting for the adolescents during the transition?
So I think that is an important conversation, and I hope that at some point we can have clinical trials or capture data from GlobeReg or other registries to answer that. I do think that children in transition, there is one long-acting that it's approved in adults that we can transition them to as well. So I think it's a long-term need.
All right, I think we had a very good talk from both Prof. Varman and Prof. Miller. Give them a big applause. Thank you so much for that. Yes, I hope that also gives us an idea of what is long-acting growth hormone and how we use it, what are the possible side effects, how effective it is, the safety profile and all that. I believe when it comes to the need of patient, we would go for the best medication that is available with the least problems, I would say, in terms of safety or even pain, because these are all about injections. 365 injections per year versus 52, and I'm sure everyone will opt for the smaller number, right? So thank you very much to both of you. Yeah. Okay, so we need to move on. I'm just gonna go back there. So it is my great pleasure to introduce our next speaker, who's gonna talk to us on managing type 1 diabetes with the new generations of insulins. He's none other than Dr. Archana Arya. So she has been doing pediatric endocrinology for more than 25 years. I was surprised to see her just like she looks so young with the spectacle, but yeah, there she is. A lot of work that has been done. She does a lot of work on diabetes, and she has been in the professional membership in ESPE, Endocrine Society in the US. She also had executive roles in member of the editorial board of Asia Pacific Journal of Endocrinology. A lot of publications, a lot of research. I think I've read somewhere that she has been the honorary secretary or treasurer in society in ISPE. So yeah, today she's going to talk to us on managing type 1 diabetes with new generation insulins, and I would love to hear from her, of Dr. Arya, please.
Thank you so much for the kind introduction. And I think this is a big switch in the topic. And today, now we're talking about what's actually available over here. And these are my disclosures over here. So today I'm talking about the new generation insulins and their use in type 1 diabetes. And I think you all, being pediatric endocrinologists are well aware that there are a lot of difficulties in managing type 1 diabetes in children. Their lifestyle is different from adults, very variable routines. Sometimes they have exams, holidays, some are into sports. So every day is a different day for them. And usually they avoid frequent blood glucose monitoring. There is less use of sensors. Difficulty in injecting and monitoring in school is a big problem in our country, at least. It's a little better in other countries. And of course, the non-physiologic insulin preparations have been a problem in the past, and this is improving now, and that's what I'm going to talk about. So we all know that the risk of progression of microvascular complications increases tremendously with poor control. As the HbA1c rises above 7%, you can, which is the pointer here? Can I use it? Yes. So you can see there is a rise in the microvascular complication, and this was well documented in the diabetes control and complications trial. So glycemic targets were set for these children to cut down on the risk of these complications. And these are the targets which are recommended by various societies, and the SPAD recommends that for those who are monitoring with finger stick, the blood glucose should be between 70 to 180 milligram per deciliter, and lower. The fasting should be from 70 to 144, and the HbA1c should be maintained between 6 to 7%. I think the newer guidelines are bringing it down to 6.5% if they're on automated insulin delivery system and with sensors. And for those who are on CGM, it is recommended that more than 70% of the readings should be in this range of 70 to 180, which what we call as time in range. Now, all these this well documents that intensive therapy is more beneficial than conventional therapy, but initially this was at the cost of increased risk of hypoglycemia, and it was a problem to actually achieve these targets. But now this has become simpler to achieve these targets because of superior technology for blood glucose monitoring, that is the CGMS. The insulin delivery systems have improved. We know with insulin, the new insulin pumps are much easier to use, and they bring about better control and physiological insulin preparation, which is most important, because at the end of the day, it's the insulin that is controlling the diabetes. So today I'll be focusing on the first generation basal insulins. What were the pros and cons, and what were the lacunae which needed to be filled? And then we talk about the new generation insulins, which are taking care of the problem we face with the old generation insulin, that is the ultra long insulin and the ultra fast insulin. So starting with the first generation basal insulin, I think you all know glargine was the first basal insulin that became available, the first generation analog, and maybe some people in this audience never use the NPH insulin, which we used to use for managing diabetes prior to this. But when we did our fellowship and started work, we used to use NPH and regular insulin all the time, and the control was very poor. There were a lot of problems with the NPH insulin. So the basal analogs changed the management of diabetes. Now, insulin glargine U100, the structure is by substituting the glycine for asparagine at A21, and 2 arginines are added to the carboxy terminal of the B chain. So basically, it's a change in the structure of natural insulin to prolong the action. And this precipitates as microcrystals. This is a subcutaneous injection, and it is at an acidic pH of 4, and this causes a little burning while injecting. It gets precipitated at the pH of 7.4 in the subcutaneous tissue, and then there is a slow dissolution of free glargine hexamers, which results in a protracted action of glargine. Then the next insulin that became available was the insulin detamere, again a first generation analog. Here, a fatty acid, myristic acid, is bound to lysine amino acid at position B29, and this is a neutral pH insulin. And one of the mechanism of protraction besides self-association is extensive albumin binding. As Dr. Vaman just mentioned, that albumin binding is a very good technique to prolong the action of various drugs. So with these first generation analogs, the response was way better compared to the NPH insulin, which was being used prior to this. And there was a risk reduction of hypoglycemia by 20 to 46%, as you can see. So it actually changed the lives of patients. Initially, they were very apprehensive. I remember to take 4 shots because we used to combine regular insulin with NPH in the same syringe and give it those days. And to tell them to switch to 4 doses was a very tough task for me. But once they tried it, nobody went back to the old regime because it was so much better. Also, there was lower day-to-day glucose variability compared to NPH. This is NPH and glargine, and this is detamir. So that also improved the results. But still, there was some problem with these first generation analogs. First of all, they were not truly once daily because unfortunately, none of them lasted for a very long time. We thought it would work for 24 hours, but that was not the case. Most of them lost their effect by 18 to 20 hours. So the children had to take them at a fixed time to make sure there is no delay. Secondly, it was not truly peakless either. It used to have a slight peak and leading to high nocturnal hypoglycemia. So the initial recommendation was to give it at bedtime, and most of the patients came back with lows when we started them on glargine. And then we had to change the timing of the insulin in these children. I used to give it in the evening or afternoon so that there was no nocturnal hypoglycemia. And there was some amount of variability present. So the new generation analog that we have now, the ultra long insulin that is being used very often, I'm going to discuss that. That is insulin degludec. So this has zinc and phenol attached to it, and it's injected in a dihexamer formation. As soon as it's injected, it loses phenol, and this phenol depletion after the injection results in multi-hexamer chains formation. The zinc in the molecule diffuses slowly, and it causes individual hexamers to disassemble and releases dimers and then monomers. And these monomers are absorbed from the soluble depot into the circulation. So if we compare the basal analogs, basal insulins, here we have NPH, glargine 100, detamir, and degludec. You can see that the onset of action is the earliest compared to the rest. It is 30 to 90 minutes. The peak is minimal, and the duration of action is more than 42 hours. There is lower within day variability versus the glargine. You can see degludec has a lower within day variability as well as a lower day-to-day variability. You can see over here. Coming to the efficacy and safety of degludec in children with type 1 diabetes. The summary of the young one trial, which was done before it was approved, they had seen the HbA1c, fasting glucose, confirmed hypoglycemia and hyperglycemia with ketosis. And they found that degludec achieved equivalent long-term glycemic control with similar rates of hypoglycemia, but hyperglycemia with ketosis was significantly reduced in these patients. And the reason for that was because of the longer duration of action. So if people would forget to take their dose or they would get delayed, the chances of hyperglycemia and ketosis were much lower. So that was the biggest advantage of this insulin. So this is a very short case that I have of a 9-year-old girl, Tanner 2, who had a body weight of 36 kgs, and she was diagnosed with the type 1 diabetes about 6 months ago. And she was on a basal bolus regime with a total daily dose of 40 units. She was getting glargine 17 units at bedtime and 7 to 8 units of aspart before each meal. She was on a fixed carb diet. So you can see her readings here. Her blood glucose was very high before dinner. Her post lunch was good, but before dinner was high. And 3 a.m. at 3 a.m. she was getting hypoglycemia, and of course she would take something sweet, and then the fasting blood glucose would run high every day. So we switched her to degludec. We lowered the dose a little because you need slightly lower doses with degludec, and you can see that the effect, the blood glucose improved tremendously because it was the hyperglycemia was being caused because of the wearing off of the glargine, and the nocturnal hypoglycemia also improved because that was because of the slight peak that glargine had, and obviously all the readings became better and the control improved. So just to comparing the three basal insulin analogs, degludec has the longest duration, 42 hours. Flexibility of timing is there. The delay doesn't affect the blood glucose level. Lower doses are needed. It reduces hyperglycemia or ketosis due to the missed dose, and it can be mixed with other insulins. What happened here? Yeah, okay. So let's take a quick look at the ultra-fast insulins in children. So we have been using regular human insulin over the years, which was the closest, the most physiological insulin we thought years ago. But if we compare it to the normal insulin secretion from the pancreas, there is a huge difference. The onset of action is much later. It has to be taken before meals. The peak is not as good. And the offset is also after a long time. Now, following this, some fast-acting insulins like Aspart and Lispro were available, which had a faster onset of action, a better peak, and a faster offset. But still, it was not close enough to the normal insulin secretion. And following this, now we have an ultra-fast insulin, which is probably the closest to the physiologic secretion of insulin from the pancreas. So, faster acting Aspart is the name of the insulin, and this is a relatively new formulation, but it is the same old molecule of insulin Aspart. They have added niacinamide to modify the absorption, and arginine is added for stability to improve the action of the insulin. Sorry. As you can see over here, that in faster Aspart, the early monomer fraction is far more than it was in Aspart or in the human insulin. So that is why there is a quick onset of action. So compared with the insulin Aspart, it has twice as fast onset of appearance in the bloodstream, twofold higher insulin exposure within the first 30 minutes, and 74% greater insulin action in the first 30 minutes. The trial for this is the Onset 7 trial, where they had used the faster Aspart at mealtime and post-meal also. So in young toddlers, we like to use insulin post-meal because we don't know how much they're going to eat, or they eat very slowly. And all the same is true for children with eating disorders. So both the timings of faster Aspart were compared with insulin Aspart. And you can see in terms of the results of this trial that the mealtime faster Aspart provided superior HbA1c control compared to the Aspart insulin, and the post-meal was non-inferior to the, it did not improve the A1C, but it was non-inferior. So we can use it post-meal in children. They also found that there was an improvement in the time and range in children who were on multiple daily injections, and in adolescents, they also found an improvement in the time and range, as well as a reduction in the time above range. And in those who were on a sensor augmented insulin pump, they found there was an increase in the time and range, and the time above range also decreased. And most patients were very happy using it and wanted to continue using this insulin in the pump. Sorry. The Aspart statement on use of faster Aspart in the pump is that the concentration is tripled when we administer it via the insulin pump CSII, and this pronounced effect may be due to the continuous influx of niacinamide by the basal insulin rate. So adaptations have to be made when you switch over to this insulin in a child who's on the insulin pump in the basal rate as well as the bolus type, because it works much faster than the other insulin. And just a last short look at how the profile of one of my patients was. A very obsessive parent who kept scanning the CGMS constantly. Thanks to the CGMS, people start worrying about that little peak which comes after the meal. And people will keep, when they started using it, they would keep calling to say, oh, the blood sugar is running so high. It takes so much time for it to come down. Isn't that dangerous? When you educate them well, they're worried all the time. So you can see how often this patient was scanning, and they would keep scanning the CGM till the blood glucose normalized in this child. So he was on degludec and aspart. So we shifted him to the faster aspart, and you can see that the curve was flatter. And the immediate post-meal hyperglycemia improved, and his time in range improved, and so did the scanning. Didn't change too much, I can see, despite that. So they're still the same after so many years. They keep doing that all the time. But it just shows that we have a quicker action, and it does cut down, improve the time in range. So just to summarize the benefits of faster and faster aspart, I've already mentioned most of the things. Flexible timing, 2 minutes before to 20 minutes after the start of meal. Convenient for children who don't have the patience to wait for their meals after taking their shot. Useful for those who need post-meal dosing. It reduces the risk of hypoglycemia due to delayed meals, because sometimes they take the shot and the meal gets delayed. So it cuts down on the risk of hypos over there. Improves the post-meal spike, and also prevents late hypoglycemia, which can be a problem with the regular insulin at least. And a rapid decrease in blood glucose in cases of hyperglycemia with ketosis. If a child has ketosis and we are worried about decay, it will bring down the blood glucose more rapidly. More precise calculation of dose can be made based on the carbohydrates consumed. Those can be repeated for snacks in between meals without worrying about insulin on board because of the quick offset. But additional doses may be required for snacking because it doesn't last for very long. For children who want late snacks, they have to take another shot, and it's approved from the age of 1 year. And I think I'll summarize. I've said most of the things that ultra-long basal insulins do provide: better glycemic control, less hypoglycemia, and flexibility of administration, and improved coverage throughout with reduced within day and day-to-day variability. And in the control trials and real-world data, we saw faster aspart includes the lower time above range and increases the time in range, and results in effective control of HbA1c, postprandial glucose, and comparable rates of confirmed hypoglycemia. Thank you.
Thank you.
Sorry, I went a little fast, I know.
That's fine.
But
Thank
we're
you.
running late, I know.
Yeah, thank you very much, Dr. Arya. I think that's a very informative talk, and I think I also like to thank you for sharing. Yeah, I think that's very important. When you look at the real world, what happened to our patients? Yeah, the use of ultra long and ultra fast acting do give them some flexibility and also improve in terms of their metabolic control. Just like to open the floor for any questions that anyone has. Nope, no questions from the floor. Just want to ask you a bit on this. I mean, I know that you have mentioned about the use for certain group of patients avoiding nocturnal hypoglycemia, and those who you give the injection after they have finished their eating. So in practicality, how difficult, I mean, how many of our patients having that kind of issues, and how does this work with them?
Yeah.
Mostly toddlers, mostly the young kids, they take a long time to eat also. First they're unpredictable, of course, we all know that. But I would say a 2 to 3 year old child will take at least 30 to 40 minutes to finish his meal. That's how they're fed here, with somebody feeding them. So if we inject just before the meal, then the insulin will peak before the child has probably had even half his or her meal. So we recommend that you give it after the meal, but if they're taking too long, if it's like 40-50 minutes, then it may be a good idea to give it somewhere in between. Otherwise, again, we lose the benefit of the insulin. So, again, it varies. I think the insulin regime has to be tailored based on the child's lifestyle. Every child is different, has a different lifestyle, and whatever insulin goes best with their lifestyle is what we need to choose.
I think the use of the long-acting insulin, that really helps. I know you put it there is 42 hours of work, but I believe there's just no recommendation to use every other day, right?
No, so there was a trial with every other day where they found that it was well maintained, but it's still not a recommendation. I think there was just one study, and that's the first question when I tell people that it's long acting. So the first thing is, if it lasts so long, can we give it every other day? But we tell them, no, you can be a few hours here or there late, that's fine, but try to stay with the same timing, because here if you say, okay, 2 hours late is okay, they'll probably give it 5 hours later, So, but yeah, the weekly ones will be coming, and hopefully if they're good and they get approved, we could use them.
I think that's also I mean, from using the previous long acting, usually you tell them before bed, or if you want to use it in the morning. I saw that you actually give your patient in the afternoon.
Yeah, because when they come from school, first thing is I tell them to give 2 together, so that you're not injecting them 4 tests. Still 4 injections, but at least you don't have to inject them 4 times in a day. It kind of cuts down on the hassle of the parents as well as the child. And then, if they get delayed or they forget at night, so most kids, when they come home from school, they'll have their lunch, and it's just easier to do it that way, I feel.
I think when we talk about insulin injections, a lot got to do on how we manage and how the parents accept what we discuss with them, right? It's more of the real world kind of situation rather than just the one that you see in the study. It differ.
Absolutely. Absolutely.
Yes. So any more question or any remarks from anyone? And I believe this is the real the little bird telling us that it's gonna be here, right? The Fayaz is gonna be in India. It's already here. Yes. Okay. I'm that's why I'm very sad that it's not happening in Malaysia. It's not coming. So
While and actually the cost is less than insulin aspart. It's for in India at least, so it's more affordable than the aspart for those.
it's more affordable. It works very well. You can use before or after the child eat, especially the toddler. So I think there's a great flexibility in the use of it, and the variability to me it looks very much lower in terms of the absorption and all that. If you don't have any more questions, I would like to thank Dr. Arya for the very very insightful, I would say. The sharing of the case to me is a lot more of information when it comes to using the insulin. And I would like to thank Novo Nordisk for giving us this opportunity to listen to the very well-known speakers in their field, both on the growth hormone as well as on insulin, the new generations. Thank you very much to everyone who stayed till the end of the day. Have a good dinner tonight. I think EPES have a dinner tonight. So thank you very much to all, and I'll see you again tomorrow. Bye-bye. Your right hand.
laptop, sir.